Good morning, everyone. Warm greetings to each and everyone present here. I am Arya Mane.
And I am Stejal Kare.
We welcome respected dignitaries, our eminent speakers, our dear delegates who are present physically and digitally, respected faculties, assemble of students, organizing team of Cynodent, Indian Society of Dentistry, and School of Dental Sciences, Krishna Vishwa Vidyapit Karad, Maharashtra, to the 14th World Dental Sciences and Oral Health Conference, organized by Cynodent Internationally and Indian Society of Dentistry in collaboration with School of Dental Sciences, Krishna Vishwa Vidyapit Karad, Maharashtra.
The theme of the conference is Bringing the Future of Dentistry Now and Beyond. We once again welcome you all to Karad, the city of natural beauty, and are immensely graced by your presence amongst us today for our conference. This conference will focus on the latest trends and updates, latest advances and treatment developments in the field of dentistry. It will bring together stalwarts and delegates from a wide range of disciplines to meet, greet, and learn new things all together in one place, and that's what our conferences are for.
It's a pleasure and a matter of great pride to have 20 plus eminent speakers associated with us all over the world. We welcome all international and national speakers and our delegates to Karad with a touch of heritage, spirituality, and a modern panorama.
Everything is possible only with blessings of God and with your constant support, love, and well wishes. We are immensely thankful to all our delegates. As we are bringing all this to you so easily and efficiently, we also look forward to hearing from our delegates through the numerous scientific presentations on their breakthroughs, advancements, and trends in the field of dentistry.
Let's invite the first speaker for the day. We have Dr. James Gutmann, sir, legendary endodontics from USA, here to teach us about the irrigation in endodontics. Over to you, sir.
To actually, and I appreciate Dr. Anmol for inviting me to make this presentation. I have chosen to actually cover irrigation, but I've chosen this from a very different perspective. I'm asking the question, how far have we come and where are we going? And I'm going to ask questions with very few answers today, because this is an amazingly challenging area, and I'm not sure anybody has the answer yet. We're seeing new technology being developed on a regular basis, and I'll address some of it later in the presentation. But it's an area that is so crucial to us achieving success, and that is to eliminate tissue and eliminate the bacteria within the root canal system. So most of my things are going to be involved with questions more than anything else. There's our true challenge. It's the anatomy. It's an anatomy of what we're dealing with. You can see that anatomy, and it can drive you crazy even thinking about it, with the bacteria and the tubules, with the three-dimensional aspect. And we have to ask ourselves, can we really even get this area clean? No matter what we do, we certainly can't do it with instruments alone. We have to apply our chemomechanical debridement type approach. And yet there's many ways to do it, and everybody does it differently globally. I've seen it around the world. I've seen all the different ways that this can be done. Now, when we see this article, it appeared in just 2019, this fellow by the name of Carlson, he brought up some issues. When I think they're somewhat archaic, but at the same time, he brings up an issue that is important. I'm going to share some of this with you. He's talking about the issue of sterilization. He's kind of going back a number of years. And he talks about Grossman in 1972, talks about the fact that root canals can and need to be sterilized. That was an issue that just we could never achieve. Disinfection, yes, but sterilization, all but impossible. However, what he says, his fellow Carlson, we now have disinfection and obturation as surrogates for successful sterile root canal treatment. What he means by obturation, he means that we see things on social media, and people show all the beautiful curves and the fillings and the puffs and everything else. And we're looking at that as being successful root canal therapy, and it's not necessarily accurate. And as he says on the bottom, I'm sure I have opposition, vehement challenges. Show me a sterile root canal and I'll show you success. So this issue is something that comes up. Can we achieve sterility? No, we cannot. Can we achieve a disinfected canal? We can. But he goes on and he brings out some important things. The ability to get success is impracticable and impossible at times, and without clear sterilization of the system. He talks about meeting with immediate failures, which we see, and the slow failures. And those are the ones I think that are extremely important. Those are the ones where we see failure down the line. And we kind of wonder, did we get all the bacteria out? Did we get all the tissue out? There's more factors that enter into this whole process than just the disinfection of the root canal. So we have these ever-present challenges. And he does bring out a very important thing. There is a lot of sloppy science out there right now that's inadequately addressing the issue. And it's not really focusing on the kinds of things we should be focusing on. So even though he's a little bit far to the left in his radical approach, he does bring out some interesting concepts, which we have to keep in mind. So what's our primary goal of a root canal procedures? And this is just food for thought. Again, I'm not necessarily giving you any answers. I'm giving you a lot of questions. And when you get questions and you look at the questions from a thoughtful standpoint, you begin to start changing your pattern of activity because you begin to question the kinds of things you're doing. Do we want to see just beautiful white lines on posts in social media? Is that what we're looking for? A lot of people, that's what they do. That's what they post. Do we want to see our sealer puffs? And what they will say is, if I've got a sealer puff, I'm guaranteed to have it sealed. That's wrong. That's impossible to say just because you have a sealer puff that you have a root canal seal. To prevent the occurrence of apical periodontitis, that certainly is great. Yes, we want to be able to achieve that goal. To remove the etiological factors, yep, apical healing, those are the scientific kinds of things we're after, not the clinical radiographic things. To preserve tooth structure for symptom-free function, absolutely. These are things, think about those things. There has to be a melding of all these concepts, but we shouldn't focus so heavily on like number one and number two and be so satisfied that what we see in the social media is the ultimate of what we're trying to achieve. To create a sterile environment, sterile, impossible. An environment that your body can respond to, yes. But even the body that is immunologically compromised may not be able to respond to some of those scenarios, and we may get failure ultimately. And all of you have seen beautiful root canal procedures being done, shown on the radiograph, and you're happy with it, and you pat yourself on the back, and you know it's going to be successful. Wait, once you're in the specialty like I have been over 50 years, and you see cases 5, 8, 10, 12, 15 years down the line that are failing, and you begin to wonder what's happening. Okay, as far as irrigation goes, there's many different ways we can irrigate, and you can see the types of needles that are available, and also the brushes that are available. We have this issue of manual agitation with syringe irrigation, the dynamic approach. We've got the machine approach, continuous irrigation, rotary, sonic, ultrasonic, and we have lasers, which I don't have in here because the lasers are starting to come around right now, but the lasers still require some type of activation. But these are the kind of things that we have to decide what's going to work for us and what works for you in your own hands. And are we achieving what we claim with our irrigation devices? This is a very, very sound question I have to ask. And each of us have to ask that. It's a very important question to ask. Are we actually achieving what we claim that we're achieving? We don't know at times because we have to be, I think, confident. What do you believe in? What do you use for irrigation? Are you use manual, assisted? Do you use syringe, brushes, the manual dynamic activation, multiple different approaches? Do you use brushes, continuous irrigation, sonic, ultrasonic pressure devices? Think about all these things. I can't necessarily give you what's best because everybody uses so many different things and everyone's not going to switch over and make the changes. They're going to continue to use what they're using because they feel they're getting success. But I'm challenging you to think about what you're doing And are you really, whatever you're using, are you really taking it to the highest possible level? Are you really achieving the success? And the bottom line is, are you following your cases sufficiently to be able to say, yes, I'm getting success? And on top of that, are the cases that you've treated with the root canal procedures, are they being restored properly? Has the patient been developing periodontal disease? These are things to consider. Also, something else which has to be considered is the type of needle that you're using. We know that over the years, we've seen the various types of needles all the way up to the very end. And now we see the different openings of side vent, apical vent, the different porous areas. This is a good literature review, came out in 2015. What's the best? Well, guess what? Every one of these has negative aspects about it. Every one of these is not perfect. And a lot depends too on how we're shaping the root canal, how we're opening it up, how we're enlarging it. And in this day of minimally invasive, are we giving it sufficient space for the irrigant to function within the root canal system? So regardless of what needle you're using, are we allowing the irrigant to get to where it needs to get by our shaping? Or are we minimizing things, thinking that we're preserving too structured, yet we're not really allowing ourselves to disinfect the root canal system? We see examples like this from Hapasalo's work. And you can see using a side vented needle, which is a very popular needle, but we're not necessarily getting movement apically of the solution, especially in curved canals. So we have to consider all these possibilities and stop and consider. If you haven't thought about the irrigating needle that you're using in your office, take a look at it. Which one are you using? Do you think it's really achieving your goal? Are you getting it placed apically sufficiently to allow you to get that velocity of movement, of solution, so it can debride the canal system, so it can eat away at the soft tissue and expose the dental tubules and also kill the bacteria in the process. Now, this article by Verdi in 2017 is very important. It talks about the manual dynamic versus the passive ultrasonic versus the sonic versus the apical negative pressure. And very important, it's in yellow. Current data is too heterogeneous. And that's what we talked about earlier. The research that's being done is all across the board. And that's why people, one group will say, we use this, the other group says, we use that. And the thing of it is, we just don't have a consistent model to be able to give us the type of information that we need that is predictable globally for the irrigation process that we're dealing with. And this is the challenge that we all face. And this is something that we have to seriously consider. You might say, well, I use, and that's the best one on the market because the studies have shown that's what works. Well, there's even problems with that as far as getting the solution all the way to the apical preparation. And these are issues that come into play. So the current data is too heterogeneous and we cannot come up with any good evidence base. We can come up with what we can call best evidence, but the best evidence resides in multiple areas. It's not necessarily the evidence-based, and that's something we have to keep in mind. So where are we? What's the best direction? What kind of choice for the future do you want to have that you want to be able to obtain? Do we do the manual? And we know that manual agitation can be pretty good. So is the passive ultrasonic and the sonic. And are there any others? And we'll talk about some of those as we move along. Now, this is probably the one that came on board pretty heavily back in the early 2000s, the one that John Schopel gave us, the apical negative pressure. And he talked in terms of having these small tubes and with the openings in and be able to flush and move the irrigant into the canal system and also bring back the debris. And you can see there's a number of studies since John came out with this whole thing, a number of studies which have talked about the value of it. And for example, like the Susan study in 2010 said the canal and isthmus debridement removes more debris. The Endovac shows promising results. It shows better penetration, less extrusion with the Endovac. So we see all these pieces of information, but to put them together into a meaningful package and to say that it's an expression we use in the English language, it's the cat's meow, this is the best thing possible, or this is the best thing since sliced bread. or peanut butter and jelly. These are kind of phrases that we use in the United States. It's not there yet because there are many problems with this. A lot of people have complained about the actual irrigating syringe, the tubes, the small openings getting clogged, not getting good movement, not really cleaning the canal as best as possible. And something else comes up. When we talk in terms of this 2007, this innovation, and most of you know that I'm very, very keen on the history of endodontics and where we've come from, and the fact that oftentimes we have reinvented the wheel. This concept of apical negative pressure has been with us since 1935. Seidner gave us the whole system. Prater in 1949 developed two other systems to do exactly the same thing. Same concept, flush in, vacuum out, flush in, vacuum out. So when you see people come along with all these new innovations, they have failed to learn from the lessons of history. They've failed to learn that much of this information has been there. And yet we have these gurus out there, stating, well, I found this, I found that, this is my technique, this is the best way to do it. And yet they have failed to reflect upon the value of our growth over the last 100 years or so. So let me ask you a question. What's your primary choice of irrigating solution? Where are you with that? Do you use chlorhexidine 2%, sodium hypochlorite 1% or less, 2.5%, 5.25, greater than 5.25, EDTA? What do you use? Which is interesting because already here in the United States, we are using, some people are using 6.25, others are using 8.15% or 8.25%. That's what's available, and that's what they're using. And another thing that comes up a lot, you'll see a number of studies that said, well, number of studies that we have said, well, we dilute it down to 2.5%. And what they do is they take the 5.25 diluted by half. And 5.25 diluted by half is 2.62%. And so therefore, some of these studies are inaccurate in their data and how they're using it. And so keep this in mind. So across the board globally, there's so many variances in the percentage of solutions that are being used, and yet claims are being made. And that goes back to the study which talked about that the data is so heterogeneous. We can't pull it together. We can't make it meaningful. Ask a question. Is there sound evidence that is based on multiple randomized prospective clinical trials that supports your choice of irrigating? Can you answer that? Can you answer yes, or can you answer no? I personally would have to say no. I used what seems to work best. When I was practicing, I actually had gravitated to the 8.25%. And some patients would say, wow, that was a very strong solution I smelled that you were using in my tooth. What was it? It smelled like bleach. And yes, that's what it was. But at the same time, think in terms of the two major factors that you have that are so crucial with the sodium hypochlorite. Number one, is the tissue dissolution. And number two, is the release of the chlorine ion, which kills the bacteria. This is what we're after. This is what we're trying to achieve. And yes, there's been a lot of studies who have tried to come up with different new solutions that can replace sodium hypochlorite, but it hasn't happened yet. So we have to keep in mind, what are you using? Do you have good support for what you're using? Do you have support more than just say, my patients are happy, my patients are satisfied, and my cases are working? Well, if your cases are working, do you have 5-year and 10-year follow-ups to show that they are? Keep these things in mind because they may not be working in the long run. And are we really achieving a true disinfection by using 1%? Remember, most of the studies that have looked at these percentages, what they do is they pull stock bacteria off a shelf and they say, well, it was effective against this bug, and this bug. But no studies, and I'll talk about this later, very few studies, I should say, actually go in, sample what's in the root canal, take that out and do a primary culture, and then use that bacteria to evaluate the solution that they're using. Oftentimes the bacteria have undergone changes over a period of time and therefore may be immune to some of these percentages of irrigation. What about this issue of vapor lock? We hear papers, we read about the vapor lock, the bubble that forms in these canals during the cleaning and the shaping process. What do you think it's a problem? Some people say, well, it doesn't exist as long as I have patency, and that may very well be the case. It impacts greatly on my ability to clean. How do you know that? How do you know it impacts upon your ability? But this is what people are saying. They're just trying to claim, well, we're going to get vapor lock and I'm not going to be able to clean things. And there's not a lot of science behind this. As long as I create a properly tapered canal, it's not an issue. These are the kinds of things that we're hearing by the people that are promoting the various types of procedures. Failure to deal with vapor lock will result in failures. There is actually no scientific basis for that statement, but it's out there. Keep that in mind. And vapor lock can potentially be a problem, especially maybe in our minimally invasive approaches, where our canals are so small that we might get vapor lock very rapidly. But it really hasn't been verified. So we have to do more work. There's an awful lot of research that has to be done. And yes, we do have to get that apical portion clean. There's no question about that. And it's how we deliver it and in what manner we're using and what needles we're using and what kind of pressure we're using. And are we using agitation? Are we using laser? These are all factors that come into play relative to the vapor lock issue. So stop and think about that. Now, I want you to look at this study. Effect of different concentrations of sodium hydrochloride on the outcome of primary root canal. Randomized controlled trial. Good, wonderful, love it. Randomized controlled trial. Okay. First of all, they did the electronic apex locator to the apex for registration. They used a high concentration being 5% and a low concentration being 1%. No mention of patency. No mention of patency. Keep that in mind as we look at the radiographs in a second. Use lateral compaction, which a lot of people say, hey, lateral compaction, that's old style stuff. Well, let me tell you something. Properly shaped, disinfected root canal, well done lateral compaction can be a very effective way to obturate the canal. Obturation short of the radiographic terminus. This study would be crucified by those people who would say you have to be all the way to the end of the root. No sealer expressions, puffs, which means in a lot of people's minds, it's not going to work. 12-month recall shows positive responses. So take a look at these radiographs. Cases that actually have lesions and just follow down from here and take a look at the healing. Look here, look at the healing. Look at the lesions, look at the healing. Everything's inside the root canal. Same way here, even with low concentrations. The healing, and the healing. Everything is inside, no puffs, no grandiose types of canal preparations. It used to be the 5% or 1%. Didn't make any difference one way or another. And there was basically no differences in the outcome. So we have to stop and think about many different things looking at these cases. Is it possible we can achieve success? And we don't have to always punch things through the end of the root? We don't always have to be at the end of the root? We don't quite know which percentage of hypochlorite we should be using because the 5% and the 1% showed no differences. And how well were these cases cleaned? And these cases are all cases of necrotic pulps. This is the extreme. This is not vital pulp tissue. These are necrotic pulps. So stop and think about this. This is an interesting study. And there's more to the study than just the title of the different concentrations. You look at this and you look at all those other aspects of working length determination and maintenance and ultimate healing that occurs. Now, the one thing I will bring up that is something you probably have overlooked. Every one of these cases, even though there's a 12-month recall, none of them have been restored with crowns. They've all been restored with some type of bonded materials. Does that mean we should be doing crowns on every one of these teeth? Yes, some of them have had their occlusion reduced a little bit, yes, but some of them haven't, and they've succeeded extremely well. So keep that in mind that maybe every root canal treatment that's done doesn't necessarily need the post-crown type of scenario. Maybe we're doing more damage. Maybe we're actually creating margins that might be opened up for ultimate leakage into our root canal system, which hasn't been completely cleaned. Just some thoughts. What might be lacking in our present irrigation systems? Ease of use, application. This is for you to question. What are the things you would be looking for? Lack of verification of efficacy? Yeah, we don't have that. We just look in, we drink, we just did. It's all in our own mind. Inconsistency in the information as to what is the best, yes. That heterogeneous aspect, yeah, that's a problem, no question. Lack of uniformity globally in solutions, without a doubt. Without a doubt, there's lack of uniformity, and therefore there's so much information that is going one way or the other, and we can't necessarily bring it all together into a meaningful pattern. We've got a lot of work to do in this area, and this is such a crucial area of the root canal procedures. The variable amounts and time of application for effectiveness. Let me tell you something about that. When it says, or if you said, hey, Dr. So-and-so said I need to irrigate for 30 seconds to 60 seconds, I guarantee you're going to irrigate for 15 to 20. 30 seconds is a long time. 60 seconds is even longer. How many of you really irrigate for that length of time? Keep that in mind. We tend to always take the shortcut. Are there other issues? These issues can be brought up in your own scenario. If you're not getting the kinds of outcomes that you think you should be getting with your irrigation approach, then stop and think, look in a mirror and say, what do I have to do differently? What information do I need? What science should I be looking at? How can I tailor and redo what my irrigation protocol is so I can achieve success? What are ideal characteristics of an irrigating solution? Marcus Hapasala has given these. We've got to have good washing action, remove the debris. Reduction in instrument friction, very helpful as a lubricant. Facilitate detent removal, again as a lubricant. Inorganic tissue dissolution, absolutely essential. Dissolve organic matter, absolutely essential. The collagen, the pulp, and hopefully even the biofilms if necessary. Penetration into the regularities in the tubules. This is in essence key because of the nature of the canal anatomy that we're dealing with. Can it kill bacteria and kill yeasts? Very important. Does not irritate or damage the vital periapical tissues in those cases where the tissues are there. And doesn't have caustic or cytotoxic effects to the vital tissues. These are the things that Marcus Hapasala. Marcus is regarded as a real guru and a good guru and from that perspective in the area of irrigation and outcomes. And I would strongly pay attention to what he has to say and what his research group has to say, because they've done some excellent work. But these are the kinds of things that we're looking for. Does the irrigant that you're using, does it achieve those goals? Do you have verification of it? Probably not. Is it more just a feel-good type of situation? Yep. And so I told you at the beginning, I'm going to ask a lot of questions. I'm not necessarily going to give you any answers. And we don't want it to weaken the tooth structure. And we know that some of these percentages of sodium hypochlorite, when in contact with dentin too long, can actually demineralize the hard tissue and cause a breakdown of the collagen fibers. And therefore, when you go to obturate, you're not going to have a good obturation because you're going to have that layer of broken down collagen in between the sealer and the gutta percha and the root canal wall. What would be the one thing you would like to see that could enhance your achievements? Okay, now take a look at those. You see tubules, you see bacteria, you see various types of other yeasts maybe and things like that. Enhanced delivery system and needle? Stop and think. Do we need an enhanced delivery system? Well, yeah, I guess we do. Well, maybe we don't. Maybe a laser is sufficient. Maybe that passive ultrasonic irrigation is sufficient. Maybe we need enhanced solutions. There's a lot of issues at stake here. And we need this area to be examined, researched with real tough protocols, real meaningful protocols, and then clinical applications over a period of time. And it should be done probably in a regional environment where regions of different schools or different practitioners following an exact protocol can come up with the best evidence or even evidence-based information, which will help us to understand what we really need. Now, I don't know if any of you have seen this type of irrigation needle, and I'm not necessarily here to sell you the needle. It's just, this is one of the innovative approaches that we've seen to try to enhance better irrigation and distribution. Along with the soft tissue needle, the plastic needle can go around curves, getting better penetration, which means that if you really do shape your canals well, you should be able to get into that apical section without too much difficulty and be able to get good irrigation. Again, this is just one of those needles that are out there, the various types. And I've used it. Do I have verification that it works? Not really. But does it seem logical that it is? Yes, it is. Something to consider. And in today's world, what we're seeing is the major focus is on the efficacy on the anastomosis between our teeth that have buccolingual canals. Whether it's the mesial root of the mandibular molar or distal root of the mandibular molar or mesial buccal root of the maxillary first molar, second molar, whatever. These are the kinds of studies we're seeing. And we're seeing comparisons, for example, the PASIC ultrasonic irrigation versus the Endovac system versus the SAF file. And another product is called Easy Clean, and the ability to clean the material from that anastomosis, which connects these canal systems. The only problem is if you look at every one of those teeth, that's not a stable model. That's a different tooth in every one of those areas. So you can't necessarily compare apples to oranges, if we say. So we need to have a consistent model or consistent way to be able to do these things. Now, we saw this published in 2019 by Chan, and he talked comparing the gentle wave system, which we have here in the States, versus intermittent ultrasonic activated and versus a continuous ultrasonic activation irrigation. Again, the model is different because the tooth anatomy is different, but you can see how certain procedures or certain applications may be a little bit better than others. And how they may do a better job of cleaning out these areas. But they look at the accumulated hard tissue debris that's remaining in the anastomosis. And the thing of it is, this is something we never used to think about. Are we really cleaning these areas? Yet you might say, well, I don't have to worry about that because I can obturate my canal well and I can entrap any material that's in that root that has that buccolingual communication. I can entrap it in there and that's not going to be a problem. And my question is, well, what happens if that patient develops a periodontal pocket and now it has root planing and curettage? And the cementum is removed and the tubules are open, and now that anastomosis area can now communicate with the periodontal pocket. You think that's going to heal? Probably not. We've seen a number of studies come out recently that have taken a look at it, even as late as 2021, have taken a look at the histology and the anastomosis between the buccolingual canals and how well the cleaning is being done. Yet, if you look at these, they're all prepared to different sizes. The canals have different locations as far as proximity. The anastomosis is of different size and variation. And therefore, it's really hard to extrapolate any data from these. And it's good to see people looking at these things. But the thing of it is, there are actually shortcomings in all these studies. They're not giving us the true story. In fact, if you look at for example, in the lower right-hand column, look at the shaping of the canal. The canal has been shaped away from the canal. The files have gone where they want to, as opposed to others that are more circular or more irregular. There's more of a ripping of the canal. And therefore, we don't necessarily get the kind of cleaning we're looking for. So while this data is interesting, is it the best evidence? Not necessarily. We see, again, the application of different products. It's like the Eddy, which is out of the MyFirst system, the passive ultrasonic, the XPF manual. Every one of these canals are different sizes, different shapes, different approaches. We need a model. And maybe it shouldn't be a plastic model. Maybe we need to, because we can grow teeth now in labs. We can grow teeth. Maybe we need to have a genetically developed model, which has a canal system which is exactly the same, and then apply our applications and see what we come up with. We can see what looks like nice, clean, circular canals, but do we clean the anastomosis? In many of these areas, we don't. And keep this in mind. Much of this work should be evaluated using micro-CTs. That's what we're going to see. Not sections, not cross sections, but micro CTs. So we can really see whether or not we are cleaning these areas, because this is the reality. That picture I'm showing you is a reality of what we're dealing with. And therefore, some of these cross sections are, I hate to say this, but are somewhat meaningless They're not necessarily giving us the real story. So what do we use? We use laser activation, irrigation to root canal pavement. It's becoming very popular. And there's a lot of potential protocols out there and a lot of studies that are being done right now. What about ozone therapy? That's another thing that's being looked at as far as the ability to do a better irrigation within the root canal system. And then we see the pressurized water activation or the multisonic system or the endovac type system. As we saw, it's from Sonendo. We see photodynamic applications. We see a lot of different approaches. Again, the data is so heterogeneous, it doesn't necessarily give us anything consistent that we can do accurate comparison. So we have to ask yourself questions. What are you using today? What will you be using in the future? Will you continue to use, or will you actually go to spend the time to go to the science and read and try to come up with an approach which maybe modifies what you're doing today so that you really place so much more emphasis on the irrigation process within the root canal system. For example, in this 2021 visit, it came out with the ozone therapy. They had less pain in one visit. And you know, most treatment is being done in one visit these days. We also see a tremendous trend towards the use of photodynamic therapy. And there's a lot of studies that have addressed this. And we're going to see more and more of this ultimately. But that's not the epitome yet, because it still provides a non-homogeneous type of data. It's only applicable in certain situations. And do keep in mind that all of these treatments that we're talking about may or may not be effective in our minimally invasive approaches, which are being advocated today by many of our clinicians. So what's our future direction for irrigation? Our future direction is to come up with a consistent approach, one that's going to allow us to achieve as much disinfection as possible. Sterilization, I don't believe so, but at least the breakdown of soft tissue, the killing of bacteria, and the destruction of biofilms. If we can do that, that's great. Now, what we're seeing on the future, we're seeing a process like this. This is something new that's just coming out, not necessarily available. All this is, and we've seen a lot of hype of it here in the United States, the Edge Pro microfluid irrigation. All it is, it's the BioLase. This company has partnered with the BioLase system, and they've come up with this new little supposedly new system. And it really doesn't have any clinical data yet, but you're going to see information on it that's going to try to promote this. They talk about, they have the beautiful videos. You can go to the website and see the beautiful videos, but you could go to the BioLase website and see the exact same video. We also know that the SAF file, which has been out, which has been retracted and now has come out with an irrigating system, will also be on the market soon with some type of enhanced irrigation process. And I think the ultimate is going to be this system right here called SIAC. I'm not at liberty to go into detail with it, but I'm aware of a lot of its properties. I'm aware of a lot of its capabilities, and you're going to be seeing that come out in the next 6 months. And it's going to have a major, major impact on the entire irrigation and disinfection process as we know it today. And it's really probably going to be the system of the future. It's something to keep in mind as you look forward. So start to look for these types of things in the irrigation areas or articles that are written and evaluation. And by the way, the development of this system has been done by some rather astute individuals who have really gone to great depths to provide the best possible way to irrigate and disinfect the root canal system. I'll leave you with one thought, and that is, as you look at the mountains in the distance, by the way, that's not Switzerland, that's not some of the places that you might think. What you're looking at is Antarctica. And I thought I would give you just a little bit of a coolness, knowing that you're probably sitting in somewhere in India or other places where it's hot. And it's where I am today, yeah, it's going to be up around 26, 27 degrees centigrade. But the thing of it is, I really appreciate the opportunity to provide these challenges for you. And that's why I said I didn't want to give you answers. I wanted to create the questions. You need to seek the answers. And believe it or not, we don't have a lot of answers yet. So continue doing what you're doing, do the best you can, reassess what you're doing. you have to be thinking practitioners. You are providing a healthcare service for patients to retain their teeth. So go to the best extent possible. And keep in mind those other things that we brought up. You don't necessarily have to have all the puffs to be able to say it's sealed. You don't necessarily have to have irrigant going out the end of the root. Keep in mind all of these factors and the questions that I've raised. And I hope that you will pursue this, and in the next few years, certainly in the next 6 months, when you see what happens with SIAC as it comes out, I hope you'll be able to see a whole new generation, which is really a major step forward by leaps and bounds relative to irrigation and disinfection in the root canal system. And again, I thank you for the organizers, so the committee, Dr. Anmol, and the chance to be able to share some of these thoughts with you. When this is being delivered, this will be our Christmas holidays here in the States. So I'm sorry I could not do this live, and that's why it's going to be done on video. But again, the opportunity to share these thoughts and hopefully get you excited and passionate about what you're doing. And remember, there is a patient at the end of that tooth. It's not just a tooth. There's a patient that you have to satisfy and provide the best possible care. So I thank you very much for this possibility, and you take care. Have a wonderful conference.
Thank you, sir, for such wonderful lecture. Now we're going to start with our second online lecture by Dr. Pavitra Rastogi, sir.
Good morning, everyone. And I'm Dr. Pavitra Rastogi. And today I'll be talking about facial aesthetics and cosmetology. And my apologies for not being present in person. I was fortunate enough to be there yesterday to take a workshop and have a good and enthusiastic audience with us. At the onset, I would like to thank Cynodent, Dr. Ashish and Dr. Anmol for having me here. I have a practice in Delhi NCR. I'm a maxillofacial surgeon. I work with a few hospitals, and I have my practice by the name of One Aesthetics in Gurgaon, and I practice pan Delhi NCR. So without wasting much time, I would just try to come on to the topic, which is facial aesthetics. Just a reality check, which doesn't really stand a chance in today's times, is a lot of studies quote that women age faster than men. It's true in some way because women undergo a lot of hormonal influences, and the bony framework is much smaller. So the effect of aging hits women faster, but I do believe that they have a very good skincare regime as compared to the males, and the skin really holds on to to what its integrity is in its place much longer than what it does in males. Everything that happens on the face is primarily because of the signs of aging, which is because of the loss of fat pads and volume from both sides of the face. As we age, we lose volume from the temples, midface, and the tissue accumulation starts happening more in the lower third of the face. All these tissues are kept in its place because of retaining ligaments. These ligaments primarily hold the soft tissue to the bone down below. We can't deny that there are bony changes happening as well. So the retaining ligaments itself lose its integrity, and the soft tissue also droops down. The aging triangles basically represent the same aging pattern in which the youthful face will have the base of the triangle pointing towards the menton, while the base of the triangle is towards the temple, and the apex towards the menton. And in an aged face, the triangles reverse completely because there's more tissue accumulation in the lower third of the face. You need to know about all these techniques to actually do justice and to know the best about aesthetics, which will include the use of toxins, fillers, peels, lasers, threads, blood derivatives, and microneedling. And there is a lot more of surgical options as well, which you can use and combine. Toxins, as we know, are of multiple types. They can come as 50 units and 100 units, and to be diluted with normal saline. 2.5 ml of normal saline to be diluted with a 100-unit vial, and use your insulin syringes to inject. The acetylcholine is what the toxin stops from being released from the neuromuscular receptors, so the muscle contraction stops, and the dynamic wrinkles tend to disappear. Learn when to say no is the biggest thing when you're starting your aesthetic practice, and make sure that you can understand the patient's expectations and deal with it and give the best to the patients. These are simple cases, straightforward cases of forehead toxins. If you can see, the fine lines and the wrinkles tend to disappear. These are dynamic wrinkles. Dynamic means at function. And if you can see, there's a glow that comes to the face, which is a very natural thing that happens because the toxin stops the release of also sebum, which is the sweat glands, from the sweat glands. And there's a glow that comes wherever you've injected the toxin, apart from just the hyperactivity, stopping the hyperactivity of the muscles. In this case, there's a slight difference. I've used fillers to let go of the static wrinkles here. Otherwise, the technique of injecting toxin into the procedures, corrugators, and frontalis remains the same. This is a case of a hyperactive mentalis where the toxin has been used in 3 different spots here, here, and here, 3 units each to actually relax the hyperactive mentalis. Gummy smiles are something that we see every day, and the point that we inject the toxin into is known as the Yancey's point, 1 centimeter lateral to the ala of the nose, 3 centimeter above the corner of the mouth. You inject 5 units of the toxin, and you will see results like these, which are very natural, and the tonicity of the muscles can stay in this position. These are the markings which verify the Yancey's point, and the 3 muscles which need to be relaxed. In this case, I ended up over Botoxing, and if you can see, I injected in 2 sessions in total in the span of 28 days. I injected 9 units of the toxin, and if you can see, the muscle tonicity in this case is a little less, and the patient was comfortable and happy with the smile, but the muscle tonicity was definitely a little less. So this was a sign of using excess dosage of Botox for gummy smile. This is a PubMed study. If you want, you can relate to it. And there's a lot of information here in this study. It's one of the longest studied case studies for the use of Botox in gummy smiles. You can also do mucogingival corrections, like in this case. We have done an excision of the mucogingival junction, brought it down, and reattached and suspended it, sutured. And these results stay. Toxins can also be used for hyperhidrosis for palms, for soles, for axillars. They tend to be very effective in reducing even hypersalivation cases. You can use the toxin. In neuralgia, we have primarily used a lot of toxin in the extraoral points or the trigger points. Again, very effective. PMDs make a big domain of the use of toxins. We primarily inject the toxin into the masseter and the temporalis to reduce the muscle load with the bite forces, and it really helps these patients out. We've used a lot of the toxin in facial pain and migraine. It reduces the frequency and the intensity of the migraines, and most of these migraine patients actually suffer quite a bit. And it's a tough phase when the migraine actually happens. So frequent use of the toxin actually reduces the pain frequency and intensity. Coming on to dermal fillers and threads, fillers are primarily made up of hyaluronic acid, and it's completely compatible because the body itself has polysaccharides, and it's a very natural component. The main role of the fillers are to primarily volumize and address static wrinkles. Multiple brands available. Please go ahead and use whatever you feel might be right for your patients. And be sure that the product has a CE and a certificate and an FDA approval. The filler techniques primarily that we are using are retrograde threading, boluses, aliquots, fanning. The use of cannulas have made filler injections very, very easy. It's of utmost importance that the filler placement is primarily in the subacute plane or in the reticular dermis, and you make sure that there's not the filler is not deposited too superficially, because that will be one of those reasons which the filler will be visible under natural light. Facial artery is a very important artery on the face, and be sure that you read your anatomy well, and you know that where all you need to be careful with the vessels on the face. In this case, we've done a simple correction of the lower third of the face. We have primarily injected toxin to the DAO, which is the depressor anguli oris, the muscle pulling the corners of the mouth down. We've injected fillers right where the corners are, the marionettes, the chin, the mentolabial, and some amount in the nasolabial fold. So the corners of the mouth are now parallel to the mandibular plane. But while achieving this, what I encountered was a vascular occlusion. The filler entered the blood vessel and it clogged the blood vessel. You do a capillary refill test and check for blanching and the occlusion, and you go ahead and inject the antidote, which is hynidase, and the result which you see here, the final result, is after overcoming the complication. Simple mid-face filler. If you can see the pre and post of this, this is an immediate pre and post of 1.5 to 2 ml each side, which is done for a flattened mid-face. Same patient also wanted correction of the chin. If you can see the nose to chin angle, the chin has come forward. The surgical correction for this would be a genioplasty if the patient is interested. This is a temple volumization. This is done to actually have symmetry with the temples and the midface so that the jawline can actually look narrower. These are temple threads where we go ahead and use multiple different vectors from one point or multiple points. And these are long cork threads which are addressed right to the temples. And you can even use fillers after the use of threads. Turns out to be a good way to actually tighten those temples and the volume loss in that area. You can even use mono threads. Now, mono threads are small threads which actually tighten locally. And the effects of these start coming in by about 2 to 3 months' time. They last for about 8 to 10 months. And these are normal mono threads, again, with the use of blood derivatives. The pull that comes here in this picture is because of the use of cork thread. Cork threads are long, aggressive threads. I will play the video. I've got multiple such videos. I'll show you this in the end of the presentation. Same patient, before and after immediate, she also got a lip filler done. And if you can see, the nasolabial fold is looking much better in a day's time. This is a triple vector lifts, one vector above the zygoma, one below the zygomatic arch, and one in the jawline. Same monothreads for the submental area with deoxycholic acid. And that's how the cork threads actually tend to enter the tissue. And I'll just run past a little faster if possible. Bypassing the musculature, the facial artery, we reach out to the DAO. These are aggressive barbed threads, so they engage the tissue and you can pull it in, tuck it in laterally, because lateralization of the face is very important when you want to tighten the face. After it engages the tissue, you can see that you can actually pull the tissue laterally. The entire tissue moves laterally. That's how cork threads work. And if you can see the before and after, narrows down the face, tightens it, looks good. Hereditary pigmentations, there are a lot of solutions. You can use lasers, you can use peels. We primarily want to give a little bit of volume here because there is a volume loss. And we've used threads and blood derivatives also, the before and after for it. This is the use of cannula with fillers for under eyes. And we use fanning technique here and address the entire hollow area in the suborbital, in the periorbital region, primarily for the under eyes. A very predictable way of correcting those hollow areas and static lines or volume loss. Another same case, if you can see the before and after, immediate pre and post. Again, under eyes, immediate results. This one was done with a needle. So if you can see the before and after, this is again an immediate pre and post. Lip fillers are very important and you need to replicate the lip anatomy to give the best results. In this case, before and after. For this, you should know how to replicate the lip anatomy and how much the patient actually wants. It's better to do less than to do more when you're doing the lips. In this case, lip micropigmentation was done with lip fillers. Bring the shade down. This was a cleft lip in which we had done a correction for the lip to make it look like a normal lip and a surgical scar revision for the scar that was there post-surgery, which was done years back. This was some filler lumps which were left in the patient's lip by another practitioner, and it was long time back, so the antidote did not work. So we had to take out the lumps surgically. A lot of patients undergo lip reduction surgery, and we are careful not to remove too much of lip tissue, safeguard the minor salivary glands, and this is the immediate post-op. Buccal fat removals are very, very predictable and a good procedure to do to narrow down the face in the zygomatic region below the arch. Really narrows down the face from here. The aim is not to remove the entire fat. The aim is to remove half or slightly more than half the fat, not more than that. Small incision into the vestibule, safeguarding the parotid duct is very important. You see the before and after, the face looks narrower, contoured, and looks better. Nose, we can use rhinoplasty threads. They are a very predictable option for the bridge and even getting some tip projection. And you can combine it with some fillers, and if you can see the before and after in 4 months' time, it really does look good, even though surgical rhinoplasties are the mainstay when you do rhinoplasties. In this case, apart from doing the threads, we have also combined it with some fat from the patient's own body, and we've done some fat grafting for the face as well. This was the same patient that I showed before, and if you can see, we have actually done a surgical revision for her. We've done a surgical rhinoplasty, did a mid-face lift, we've done some fat grafting, and if you can see, the face looks very, very nice. When you're doing facelifts, which are surgical, you need to be careful about the planes that you're dissecting. These are examples of male and female pattern facelifts. These are all surgical. If you can see the before and after, they give some brilliant results. And these are cases which cannot be solved non-surgically. This is another surgical case. If you can see, it's important to know your tissue planes well, dissect properly, and remove the excess tissue, get some good results going. Fat is something that we use regularly as a filler, and isolating the fat, then filtering it. And the easiest part is actually utilizing it as a filler. Just like we do the fillers, we use fat once we have filtered it. And for all the areas that we actually deal with, in this case, the temples, the mid-face, the jawline. And if you can see, the patient turns out to be very, very happy because there's a glow that comes. There's the face looks healthier. Another fat grafting case. If you can see, just to ease out the autoimmune condition on one side of the face. In blood, platelets are the answer, and most of us use the platelet-rich concentrates to give results to the face and the hair and neck and all those procedures that we're using it for. We use a lot of low centrifugation rate concepts, and we use a lot of PRF because fibrin stays in the tissue much longer, say approximately 6 to 7 times longer, and gives better results. Acne scars, acne pigmentations, we've combined PRF with lasers, subcisions, microneedling. There are a lot of techniques that you would want to mix and match and combine to give the best results. The hair starts volumizing with the use of fibrin, and the results are much faster. You can also go ahead and, apart from knowing the hair cycles, you also need to know what type of alopecia are you treating. Areata and androgenic alopecia is what we commonly treat. And you should know how to classify them. You should know the use of punches while you're using hair transplants, while you're doing hair transplants. They can be manual or motorized punches. We use a lot of motorized punches. This is a grade 4 baldness, and if you can see, we've harvested from the donor area, we've transplanted in the recipient area. These are how the results come out in about 7 to 8 months' time. The best results come in about 10 to 12 months' time. This is another case where we harvested and grafted about 3,500 grafts. And if you can see, in 10 months' time, patient's own hair. So the young male, 30-year-old, and good amount of thick hair the patient has now, but the patient needs to maintain their hair. We are giving a female pattern hairline to this patient. This is a beard transplant, and all these are transplanted hair, which we've harvested from the occipital area. A good technique to actually tighten the tissue is what we use. Lemon is what I use commonly, and trust me, I use it for a lot of reasons. Not just for the skin, not just for tightening of the tissues, not just to help collagen induction, but all those tension areas like the upper lid. You can actually tighten all those areas. You can use it for stretch marks, weight reduction marks. I've even used it on multiple occasions for intraoral reasons like second stage procedures, uh, something like a tongue tie removal, or all those reasons. I've used this device very commonly. If someone wants to find out more, please get in touch with me. I would be happy to help you out. So these are mix and match combinations. If you see the use of toxins and fillers and all these things that we have used in combination, and these are before and afters, which you'll have to mix and match the combination to give the best results to the patients. We have reduced the acne scars, we have contoured the face, we've used fillers, threads, and fractional lasers in combination to give such results. We've used fillers primarily in this case to give high cheekbones and some Botox to the masseter with the forehead. We've used multiple cork threads in this case, mid-face, lower face, jawline. We've used deoxycholic acid in the submental area. We've used mono threads, about 100 of them, 4 to 5 ml of fillers mid-face, and 100 units of toxins to get such results. Autoimmune conditions. So the first thing was to use lasers to reduce the pigmentation, then use peels to get the resurface the skin. Then we went ahead and did the fillers, about 7 to 8 ml of fillers done for this lady with the use of toxins, and repeated follow-ups is what we kept. We used threads also in combination to tighten the tissue. And she's been a regular ever since, and that's a good thing when the patient actually has good compliance towards the treatment. Again, multiple treatments done. Thing was to get a smoother skin. So a lot of peel sessions, a lot of fillers, mid-face, under eyes, jawline tightening, use of threads, and use of fractional laser with a lot of peels, about 6-7 different sessions of peels as well. So the end point is actually we need to plan to get good results, and correct treatment planning, good patient selection, use of good products are the 3 important ingredients that are required to actually give the best results and make sure that you actually deliver results according to the patients. We do a lot of fellowship programs. We train our students very well, and if you want to know more, we'll be more than happy to answer your questions. We're one of the pioneers in conducting fellowship programs with cadavers also for our students, and make sure that they train so well that they can deliver results to the patients. You can follow me on Instagram if required. You can get in touch with me. That's my contact information. That's my clinic name and the company name. That's my mail ID and my Facebook by the name of Pavitra Rastogi. So if there are any questions, please post it or send it forward to me. I'll be more than happy to answer them. I would just say thank you for a patient listening, and hoping to answer your questions once you're done with the presentation. Thank you again, and have a great day.
Moving on with next lecture, we have Dr. Lakshmi Pandey ma'am, Assistant Professor, SMBT Dental College and Research Center, Nashik. Ma'am has given various lectures, and she has also multiple national and international publications. Ma'am is here to tell us about the white aesthetics, an era of tooth color restorations. Over to you, ma'am.
All of you come in front. Back. Just come in front.
Hello. I'm audible? Am I audible? Okay. Just come in front. This side. Please come in front. I am Dr. Lakshmi. I have done my BDS from KLE Belgaum, MDS from KVG Sulia. I was assistant professor in Sharda University, and right now I'm in SMBT, Ghoti. So my topic is white aesthetics in dentistry. So can anyone tell me what do you mean by white aesthetics? Can anyone tell me what is aesthetics? What do you mean by aesthetics? Yes, good. So, how many of you are undergraduates here? How many undergraduates are here? All of you are? Postgraduates? Which department? Endo department postgraduates? Okay, good. So we'll start. See, whenever patient will come to you, they'll come to you for two most basic things. One is functional requirement and aesthetic requirements. Functional, when the patient is having pain and patient is not able to chew, right? And second is aesthetics. The patient is not happy with their teeth, right? So what I am going to take today is white aesthetics, or the aesthetic part. So recent days, it's all about white and pink synchronization. You understand? The aesthetic concern is about white and pink synchronization. So white is related to your teeth, and pink is related to the gums, right? So the color pink and white should be synchronized, so the patient should be happy, and the smile or the appearance should be pleasing, right? So I'm going to talk about white aesthetics. First, I would like to thank my guide and my HOD for giving me the knowledge so that I can share with you today. Yes. So, dentistry we are doing from very long time, right? So the earlier people, the dentists and the doctors used to provide the functional needs, okay? The patient used to have pain, they used to come to the dentist, and the dentist used to remove the pain or make it pain-free, and then the patient used to eat food and the functional rehabilitation used to happen. But now, this era, it's all about aesthetics. More and more patients are coming to the dentist or to you because they are not happy with their look or their smile, right? So now the concern is more towards the aesthetic. So it is given more importance these days. Okay. So these are my cases. In all these cases, I have done veneers, I have done composite build-up, and I have given ceramic crowns. Can anyone tell me which all teeth I have done the treatment? First case, second, third, fourth. No, I have done in all the cases. Can you tell me which teeth or which tooth I have corrected? Central incisors. Okay. Next. Okay. Third. Fourth. It's difficult, right? It's difficult to find out which tooth I have treated, right? Okay. And this? Anyone can tell me? It's just a guess. Yeah. Say. Okay. I'll tell you. All these cases, I have what all things I have done, I'll show you in the further lectures. So first I want to talk about what do you mean by veneers? As most of you are undergraduates here. See, veneers are something like basic, I'll tell you. It's a layer which you're going to put on the labial side or the proximal side and you cover the defect. Okay? What are the advantages? It's most aesthetics. Stains are not the problem, which are mostly present in the color restoration, tooth color restorations like composite. And it's lesser invasive. It means when you do a crown prep, you remove a lot of tooth structure, which is not present when you're doing a veneer. Disadvantage, it's very expensive compared to your composites. Then it is irreversible procedure. Why? Because you're gonna do the tooth prep. Second, its fragility of veneer is the biggest problem, because when you're gonna give anterior veneers, the patient is gonna bite. So when the patient is gonna bite, the chances of debonding and the fracture is most common. That's why whenever you give veneers to the patient, you advise the patient not to bite from the incisors. So this is my first case. This patient complaint was diastema, as well as, can you see incisal abrasion was there? I did the wax mop-up. Can anyone tell me what all should be the treatment modality for the case like this? Endo-PGs? Here, right? You people are sitting here, right? Yes. Can anyone tell me? See, just tell me. See, it's not Viva. It can be anything. You can give a crown. You being an endo-PG, tell me endodontic or the conservative treatment. First, composite build-up, right? Second, yeah, veneers and crown, right? In this case, I gave the patient veneers. I did the wax mop-up. Here, I did the tooth prep for veneers. I used the retraction cone. And the most important thing, whenever you are doing an aesthetic correction or giving any aesthetic restoration, shade selection is the most important thing. It's like all the work is 50% and your shade selection is 50%. If you go wrong in this, your entire work is going to, the outcome is going to go wrong. Okay, so you have to play a very important role. You have to read about shade selections. It's an entire different topic, but you have to see. Can you see? Shade selection was done, impression was taken. Then I got the veneers from the lab. Bonding of the veneers was done. This is the pre-op and the post-op. Can you see the first case which I showed you, the central incisors? Can you see? Understood? The first case which you people were not able to make out. This is the 4 months follow-up. See, whenever you're gonna do any case related, be it any department, how will you come to know about the outcome? See, you have done a case, excellent case. How will you come to know your case is, success? When the patient will come back to you and will tell you that it's an excellent case, right? So it's the follow-up. If you don't have the follow-up, who knows? The moment patient has walked out of your clinic or your department, the restoration might come out, right? So this is, now I'll talk about the another. So next thing I'll talk about is composites. It is minimally invasive. There are a number of benefits that are there for composites. Indirect restorations and direct. See, composites come in direct. It is also two types, direct and indirect. So it's a huge topic. That's later. But today I'll talk about more clinically. So, favorable mode of failure, it means if your composite restoration fails, you're going to repair it, you're going to remove it, you're going to repair it, and do the corrections, which is much easier in composites, direct composites, which becomes difficult when you're going to do any indirect restorations, right? Aesthetic concerns are good. See, but there are a few disadvantages. Even if the replacement or the repair is good in composites, but it's irreversible, right? So this is the problem. Longevity of composites is still questionable. It depends on you, obviously, because if you're gonna do excellent composite, yes. But if even a little bit of contamination, saliva contamination is gonna be there, then the question of longevity is the biggest problem. Technique sensitive, which I told you. Your each and every step of composite restoration plays a very important role. Starting from your placement of rubber dam till the polishing. You understand? Even if one step goes wrong, the entire restoration is gonna fail. This is another case. Actually, he's my friend. This is my postgraduate case. He was doing orthopedic postgraduate, same batch. This is how he came to me. First, you understand, just look at a medico having oral hygiene like this. I don't know who gave the crown. Can you see? Everybody can make out the crown. I don't know how the dentist did the shade selection. This is the labial view. This is the lingual view. I did the root canal. I did the composite build-up in the entire, whatever correction was needed. I did the wax mop-up. Then in this in which I did the root canal, the full crown coverage was needed. So I placed the crown in this central and lateral. And this central and lateral, 1-1 and 1-2, I went for veneer. See, this temporization was given. Obviously, he was concerned. I can't send him like this because he had to treat his own patients. Shade selection, again, the most important part of my entire treatment. Sorry. Yeah, here. The veneer and the crowns were received from the lab. Etching was done. And this is my pre-op and the post-op. Can all of you see the difference? See, what I did the composite. Whatever composite replacement was needed, this fractured restoration or discolored restoration I removed. And then I did the tooth prep, and then I went for the indirect restorations. All of you can understand how the entire procedure is done with step by step. This is the post-op. And as he is my friend, I could have the longest follow-up period, 18 months follow-up period. This is how he came to me. And it's like we used to meet almost every week. So I told him, the moment I'm going to leave my PG, I want your picture. And this is what I do. This is 18 months follow-up. Can you see how he came to me and how it is now? Although it was that time. I think everyone can understand. This is another case. One of my patients came to me. Her complaint was diastema and the fracture. Can you hear? See? 2-2 fracture. So this was her complaint. In this, what all things I can do? Can anyone tell me treatment modality? What should have been the best for her? Patient was poor. So I didn't opt for veneer. I went for direct composite. I'll show you. Here. First, I did the lateral. I did the beveling. Etching was done. I isolated the adjacent tooth. I used the BioClear matrix. See, it's your hard work and your ability is important. But along with that, what armamentarium you're using is also very much needed. See, you might be a very hardworking dentist or clinician, but if you don't have the armamentarium, your outcome gets affected. So before doing any case, I'm just not talking about endo or conservative or resto, any case if you're doing, the first thing what you should focus is if you have the right armamentarium. If you're placing a rubber dam, you should have the right clamp for the tooth. If you're doing a molar, if you're placing a premolar clamp, definitely you're not going to do it, right? Even if you're an excellent clinician or a dentist. So the right technique and the right armamentarium is must. So here, I chose BioClear. This is the one matrix system I love. It's very costly, fine, but still. This is the one thing which I suggest every conservative person or every restorative dentist should have. Here, This is my palatal view, as palatal and occlusal. Can you see? I use the direct composite. I use bioclear matrix. This was the lateral build-up, which I did. Can all of you make out? Can you all of you make out how the shade selection is, giving the best pleasing appearance? Okay. Next, this is another case. This case is especially for endo-PGs. See, earlier, if you will read Ingold and Cohen, you will read the moment you do any root canal, the tooth needs full coverage. Earlier, it was the concept. If you're going to do root canal, you have to give a crown. Even if it's anterior, even if it's a posterior. But now, if you're going to read the latest edition, see, earlier what we used to do, we used to give root canal, we used to do root canal, we used to give crown, but later the patient never used to maintain the oral hygiene. Then what used to happen? The crown food lodgement used to happen, and then crown failure, root canal failure, your entire procedure used to fail, right? Now, the concept is changing towards indirect restoration. See, in every tooth, there is no need to give crown. There are other coverage, partial coverage, indirect restorations like inlay, onlay, overlay. You can provide all this in replacement of a crown, right? If the tooth structure is more, here, I did the root canal. I never do any root canal without rubber dam. See, my success of root canal depends on how I do, obviously. And second, the isolation. So even a little bit of your saliva touches the root canal or your canals, when you're preparing, your entire case is a failure. It might not fail in a year or 2 years, but it will definitely fail. You understand? So I suggest every PG or everyone, whoever is doing root canal. See, you might be thinking it's such a cumbersome process. You place a rubber dam, it takes half an hour, 1 hour. No, it's not like that. If you have the right armamentarium and if you know the procedure, the technique, if you know, it takes 1 minute. I don't even give 1 minute because I know. And then rubber dam placement is there. You do the proper isolation. You can use liquid arm also. Root canal was done. And then rather going for a crown, I went for a inlay. Can you see here? Can you see? It's the cavity, the tooth structure damage was not much. Can you see? Only the mesial surface was damaged. So, can you see how aesthetically nice I have given an indirect restoration? It's a ceramic inlay. Another case, it's a basic anterior caries. See. In this, the matrix, this is also my PG case. The matrix band which I used was sectional matrix. You know sectional matrix? All, at least interns, you do restorations in your department? Obviously, you must be doing because my interns, they do anterior build-up. We give them anterior build-up. So you use matrix bands, right? So this is a sectional matrix which I used under the rubber dam isolation. Can you see here? This was the immediate radiograph. Can you see the bleeding spots? That was because I placed the band in the rubber dam. This is my another case. Can you see here? This is how a patient came to me. Her concern was aesthetic concern, and also she was having pain in the tooth. So can anyone tell me what all things I could have done, like treatment modality of a case like this? PG, endo-PGs. Can anyone tell me? If you have a discolored tooth, patient has pain. So definitely pain, discolored, it's a necrosed tooth, right? The first thing, it's a necrosed tooth. You have to do root canal. There's no other treatment modality. Root canal. Okay. When it comes to rehabilitation, what all things you can do? Definitely tooth structure loss was not there in the tooth like this, right? It's just the discoloration. Okay, then as rehabilitation, what all things you can do? Anyone? See, it's an interactive session. I can come, I can give the lecture, I can go. But you people should understand. So I did the root canal, I'll show you. And then I did bleaching. See, in this case, the bleaching effect was excellent. And the end result, the patient was happy. So I didn't go for any veneer or crown. Tooth structure was there, so the crown was not needed. I gave the composite restoration as the post-endodontic restoration. This is the bleaching agent which I used. Here, I used the liquid arm for isolation. Okay? I did the intracoronal bleaching as well as extracoronal bleaching here. And it was light activated. Can you see this was the immediate result? And this is after 1 week. Because I placed the intracoronal also. So I called the patient after a week, and this is how. So can you see the difference of the bleaching? This was before, and this is after a week. Patient was happy with it. As tooth structure damage was not much, so the crown was not indicated in the case like this. And as aesthetically, patient was also happy, so there was no need for veneer. You understood? So the final restoration which I gave to the patient was composite restoration. Okay. All of you are awake, I hope. Last benches or last chair people. Can you hear me? Here. Okay. So you people saw so many cases. What did you understand in the end? Can anyone tell me? Can anyone tell me? What did you understand? You. Yes. See, the first most important thing, you being the dentist or clinician, is you should love your job. Okay? You should love your job. See, whenever I'm presenting or whenever I am doing a case, see, every case is new to me. So whenever I do a case, it's always a challenge. Whenever I do a restoration, especially aesthetic restoration, my aim is to make the patient, so that in the end, the patient should not find out ki kya kiya hai maine. You understand? Patient ko, I'll give the mirror and be like, can you make out maine kya kiya hai? And when the patient says no, I just want that. So, you know, your end goal should give you happiness. So this is what happens when you are a clinician. Okay, the most important thing, you should love your job. See, it should not just about, I have done a case, I'll get the payment, and the payment should give me the happiness. No. It's about what you're going to deliver to the patient should give you the happiness. First thing. Second thing, definitely skills. Your PG life, or you're the undergraduate, especially your internship, is your skill development life. This 4 years, if you're going to develop whatever, is going to stay with you. How you do case, how you do isolation, how you maintain your, area. Everything depends. Whatever you learn in your post-graduation, whatever you learn in your internship, is what you're going to carry forward. You understand? So your improvement skills should be there in your postgraduate life or internship. Okay? And the third most important thing is your armamentarium. You know, armamentarium is like your weapon for the war. If you don't have the right weapon, you're not going to win. You won't give the ultimate outcome which you need. Right? So skills is needed, armamentarium, and your passion for your job. If all the three things are there, definitely you're going to deliver whatever you are hoping for. Right? Anybody has any doubt? Any doubts? Anything anybody wants to ask? See, I'll tell you one more thing. When I was in my post-graduation, we 5 people were there. We were very competitive. I don't know. I think in post-graduation, people are very competitive. So whenever we used to do any restoration or any aesthetic cases like this, we used to call each other and we used to tell, "Acha dhoondna, kaun sa kiya hai maine." You understand? This thing was there. And the moment they being the endo PGs, if they are not able to find, it used to give a huge amount of happiness. I used to feel very proud. You understand? That's why the moment I start my lecture, I show these cases. Find out what I have done. You being in the dental field, if you're not able to recognize, definitely my patient won't be able to recognize, and their relatives. Obviously, right? The patient came to me for the looks. Definitely the patient was looking himself in the mirror, first thing, or the relatives must be looking at him and complaining, right? That's why the patient came to me. So these things you have to keep in mind. Okay. And if you try to do your best, there is no failure, definitely. See, failure will be there initially, but initially you don't know the right amount of hard work what you have to do. So the moment you know, definitely there won't be any failure. So I hope all of you understood. Thank you. Thank you so much. If he has any doubts, either you people understood everything or you people didn't understand anything. There can be just two things. Any doubts? See, the first thing you should know that you should ask doubts. I ask a lot of doubts. My faculties in my graduates or postgraduates, they used to get irritated by me, but fine. Now I am a faculty, I understand why they get irritated. It's okay. But still you people should ask your doubts. I'm here because I used to ask my doubts and I used to clear my doubts. And then I used to go back to my hostel. Nobody? Anything, any procedure which you have done? See, yeah, it's a very important case, very important question. See, what she's asking is how you know that how much space should be right for doing the anterior direct composite, right? See what happens if it's a huge diastema, like 2 to 3 millimeter, or 4 millimeter, or 5 millimeter, even 7 millimeter. Definitely 7 millimeter you cannot restore. You have to go for orthodontic correction. See, our concern is not just to cover the gap, right? It should look good to the patient. If the tooth is huge, definitely it's not going to look pleasing. So we are not going to provide the restoration. What will we do? We'll remove the gap using orthodontic correction. Okay? So if minimal gap in which the shape and the harmony or the golden proportion is maintained. You understand golden proportion? It's a main concept of aesthetic restorations. So if that is maintained, you can go for restorative treatment. If it's not, if the tooth is going to look very bulky, definitely the first thing what you're going to do is orthodontic correction, and then you're going to go for restorative treatment. Understood? Okay. Thank you.
Thank you so much, ma'am. Now I would like to invite Dr. Vinit Kini, Professor of Department of Periodontics, MGM Dental College and Hospital, Navi Mumbai. He is here to teach us all about the periodontal consideration in implant surgery. Over to you, sir.
Over the years, many times. Thank you, sir, for giving the opportunity again. And then later, I look forward to interactive session. Today, I'll be speaking upon the periodontal considerations in implant surgery. Nowadays, they look at it in two particular aspects. That means otherwise you can give an implant, and in compromised periodontal cases, you cannot give an implant. That's what usually undergraduate student goes off with, the myth. But then later, it's not like that. The issue is that both those things have to be taken into account. So both those things have to be taken into account. So when we do look into the particular case, The periodontal status of the individual does make a difference in the treatment planning and the choice and the outcome and the prognosis of an implant as well. So based on that, what exactly are we looking at? You're more familiarized with this concept through something what you might have learned in your mucogingival surgeries or periodontal plastic surgeries, okay? But what people tend to overlook is that periodontal plastic surgery is not confined to the natural dentition alone. It is around the particular implant surfaces as well, particularly meaning the peri-implant mucosa and the keratinized mucosa and keratinized attached mucosa. What exactly are these terms? Understanding that is going to be very imperative when we think about these considerations when planning an implant case. First and foremost, periodontitis. What happens is that I've always seen undergraduate students come and refer to it as an infectious disease and a bacterial infection caused because of dental plaque. There is a big paradigm shift which has occurred in the last, 3 decades. Your aspects of your periodontitis is an inflammatory, disease, not an infectious disease. Plaque-induced periodontitis is an inflammatory disorder. It is not an infectious disorder. Meaning, what does it mean to you, this term? The bone loss which you talk about is not actually lost to a disease process. It's an adaptive remodeling of the host, okay, in response to a dental biofilm. What does that mean to you? This is one sentence. If you can drive this home message to you today, 1 hour of my whatever's talk is going to be worthwhile. It means that in periodontitis, the bone is not infected. The bone is healthy. The bone is viable. And the bone is capable of repair. And it does not have to be surgically removed to mitigate the outcome of periodontal disease. Does it make sense to you? You're talking about periodontal flap surgeries are not to remove a disease process. It is to correct the anatomical defect residual of a disease process. So you don't need to perform surgeries to mitigate a disease in periodontitis. You perform surgery to mitigate the anatomical defect as an outcome of an inflammatory remodeling which is host-mediated in response to a dental biofilm. See, many people, they try to make things too easy for your own good. If it were meant to be too easy, you don't need to be a doctor to treat this disease, right? Agreed? There is a difference between periodontology and dental hygiene. Yes or no? Right. So there is a lot of technicality in the tissue which you need to understand. So coming with the first part, this is a normal, what happens, let's say, the microanatomy of the particular gingiva, which is going to comprise of your outer inner junctional epitheliums, a gingival sulcus, the residual alar bone, the periodontal ligament, the connective tissue, just apical to that of the junctional epithelium, superior to the allocrest. And then later you have something called the mucogingival junction. You have your free gingiva, you have your attached gingiva. Now this is something which all of you are, accustomed to reading right from your first year or second year, your BDS, right? Now what you need to understand is, not every situation is as black and white as like this. There are going to be several gray areas in your practice which you need to understand when you take into consideration the treatment planning. Otherwise, you will end up with a catastrophe, right? So with this, when you look into this, these are your gargoyles measurements of the biological width. If you do know, like what happens, your interns, third years, what are you guys? Interns? Okay, all right. So the point is, the concept is, you've got certain dimensions which you should be aware about: the biological zone, the biological width, okay, and then later the dentogingival unit and width of attached gingiva. So in other words, just to keep it very clear, from the free gingival margin to the base of the sulcus, that's the sulcular depth, from the sulcular depth which you establish with the periodontal probe to the particular level of the attachment, that is your junctional epithelium. Then later, from the particular area where your junctional epithelium ends to the alveolar crest, that is your connective tissue attachment. And then later, the marginal gingiva to the mucogingival junction, that's your keratinized gingiva. And from the base of the sulcus to the particular mucogingival junction, that happens to be what? Your attached gingiva, okay? So this is a fairly, what happens, black and white situation. Prosthodontists learn this from the particular aspect of biological zone. We periodontists recognize this from the point of view of something called as the biological width, okay? And from a given perspective is that you say that whatever be the situation, you don't impede upon the biological width while doing your subgingival restorations or crown cementations, and we don't impede upon the biological width when we do osseous surgery. Now, in the implant, however, the situation is different. Now, it would make a difference based upon what implant system you do choose. You choose to go for a bone level implant or for a tissue level implant. Now, in that kind of a situation, the area where your particular crest or the module of the implant would end, what would always be in contact with the bone. Now, that is going to be the area of first contact of the implant and the alveolar bone. Now, you can do it equicrestal, you can do it subcrestal. Now, depending upon whether if it's a bone level implant, the module will be a part of the prosthetic abutment. In a tissue level implant, the particular transmucous element will be a part of the fixture. So nonetheless, whenever you're looking at it, if you look at that particular dimension and do the mathematics, the biological width of an implant would be somewhere in the range of 1.86. But the question arises is, do you actually have an attached gingiva around an implant? There is no gingiva around an implant since first years are also there. It is peri-implant mucosa. So whenever you're talking about peri-implant mucosa, you are going to have two dimensions within that. One is keratinized alveolar mucosa. Then later the other one is going to be keratinized attached mucosa. So that distinction is there. So the portion of the particular peri-implant mucosa that is simply surrounding the implant module or the particular, let's say, transmucosal element, in that kind of a context, that will never have a fibrous attachment to the particular implant as in natural tooth. So that is only going to be peri-implant mucosa, which is more or less free. Now, the point is from wherever the alveolar crest does exist, from the alveolar crest to the mucogingival junction, that is going to be keratinized attached mucosa. Now, that is more imperative for us rather than anything. So coming with this, rather than go back to literature, maybe around 30 or 40 years old, Gargoyle's original What Happens predicaments, they were valuable in their time, but now the particular what happens, the kind of way how things are looked at nowadays by a recent study by Tarnow. It is basically but obvious. How could we have missed it since the last 3 decades? But somewhat you do really need to have somebody to take into perspective the problem and to spend a little time to think over it. And he has done that. So whenever you're talking about a supra-bony what happens pocket, otherwise a particular kind of a situation where in the mucogingival junction is going to be apical to that of the alveolar crest. Our understanding of biological width remains the same and attached gingiva remains the same. Now, however, you change the situation wherein you have the mucogingival junction when it is coronally positioned to the alveolar crest in the case of periodontitis. Where is the attached gingiva here now? The second situation, if you see, attached gingiva can only be there where there is alveolar bone. Correct? This is around a natural tooth. Now, let's consider a case of an infrabony pocket. Infrabony pocket makes it even more complicated. If you want to go by the particular aspect from the base of the sulcus to where the mucogingival junction exists, consider the case of an infrabony pocket. Where is the base of the sulcus here? It's apical to the alveolar crest. So attached gingiva should be further less. Yes? So Tarnow has redefined the concept of attached gingiva and attached mucosa from being from the alveolar crest to the mucogingival junction. That is a recent paradigm shift. I'd strongly recommend you go through that literature. It's come out in 2022. Okay? So what happens, that will be the way forward when you pursue your post-graduation and your place planning. Done. So, but in an implant, the situation still remains the same. You will get certain kind of phenomena around an implant. referred to as early bone loss. You'll get crestal bone loss, okay, before functional loading and within 1 year of functional loading. So when you do get that bone loss, wherever the bone does exist finally, from that position to the mucogingival junction will be your keratinized alveolar mucosa, and coronal to the alveolar crest, what you will be getting is going to be peri-implant keratinized mucosa. But what is important for us? Which would we rather, what happens, go to augment? Your keratinized alveolar mucosa, KAM, otherwise we are looking towards peri-implant keratinized mucosa. Take a wild guess. I would be forced to compel that both are important, okay? So you have seen these tests which you do clinically, okay? You will find situations in your particular practice where you might have to consider what happens extracting a tooth and placing an implant. ITI protocols normally indicate that placement protocols can be done immediately after extraction, okay? Delayed immediate, meaning that means 6 weeks after what happens extraction. And then later, we have our delayed placement, which would be around 3 to 4 to 6 months following an extraction. Now, once you look into that particular aspect, you will have to think about whenever you are extracting a tooth, especially periodontally compromised versus that of any other infectious disorder, most commonly endodontic, okay? Can you attempt an immediate placement in the endodontically infected tooth? What does it tell you? I just told you the first sentence in my first thing would be, periodontitis is not an infectious disease. It is an inflammatory response. So in other words, in endodontic infections, most of the time, the trabeculae are already infected by ingress of bacteria. So that would technically lead to certain kind of what happens, your kind of osteomyelitic changes in the bone. Otherwise, it would induce certain kind of necrotic changes in the bone, which will require what happens, surgical mitigation to go for that. So for endodontically involved teeth, you would not normally go for immediate implant placement. You would wait for the delayed immediate to wait for that infection to ameliorate first before you attempt implant placement. Is that clear? Right? So from that context, like what happens is that that becomes one thing. So immediate implant placement is whatever, whose purview? Perio. Right? So from my perspective, it's a win-win for me because I teach periodontology, right? That comes here. So coming with this, when it comes to that, you also have one particular situation over here. Whenever you encounter a recession and you decide to extract the tooth and what happens, place an implant, what you have to realize that recessions automatically implies what? There is no cortical bone housing. Extraction defect can also be called as a 4-wall defect. As you know, horizontal, let's say a ridge, is a 0-wall defect. I hope I'm clear, right? So whenever you're looking at an extraction socket, it's a 4-wall defect. So whenever what happens, you are going to, extract a tooth, you will get less than 4 walls, or a maximum, best case scenario, you'll get 4 walls. If you get 4 walls, nothing like it. Otherwise, if you get anything less, the prognosis of it goes downhill. Okay, so coming with that, sometimes this is a situation where the teeth are not periodontally compromised, okay? But the width of attached mucosa is going to be compromised because of a shallow vestibule. High muscular attachments in relation to the alveolar ridge. Those are the type 2 situations that I had spoken to you about, okay? So meaning that what happens, you have a paucity of keratinized alveolar mucosa in the implant or a reduced amount of attached gingiva around a natural tooth. What's the big deal? The problem is this attached gingiva is something which is going to prevent something from getting ingress from your gingival sulcus into the spaces. Okay? If you don't have attached gingiva or you don't have keratinized attached mucosa, whatever you do eat will come around your peri-implant sulci, otherwise around the particular sulci around a natural tooth, and as a result, they will get ingressed into your what? Your spaces, causing space infections. Food lodgements, food, what happens, your foreign body reactions and all. If that does happen, what is the only way how the body takes care of it? You will say that they will come to you, you will do a particular debridement and the patient is cured. How many times is he going to come there for? He is going to come every day of his life and take an appointment with you in the evening? Every day after he has a meal and come and gets a debridement and go? No. The body will take care of it through resorption, foreign body reaction. And the result, what do you get? You get loss of bone. And when you get what happens, loss of bone, your implant is doomed for failure. So having that bit of your keratinized attached mucosa is imperative for the survival of the implant. So coming with this, the thickness of the gingiva. Now, what was the point of this is the predisposition of an individual to develop recessions in the first place. In the way how you might have studied, maybe around a decade or back, you would normally refer to this as thin and thick biotypes, okay? Now, the correct terminology for this would be the phenotype, which we talk about. So it can be diagnosed clinically by the Acuvue color-coded systems. Truth be told, this system would be more what happens in determining the biotype of the tissue. Thicker the biotype of the tissue, less predisposed are you towards what happens getting recessions, and the more what happens, your attachment levels will hold, and the less amount of what happens, labial cortical plate bone loss will be anticipated. So this is a very important aspect that is tend to be overlooked. But people who do recognize this as an important feature are mainly orthodontists and implantologists, because this is a very important aspect for determining the longevity of your particular implant processes. Now, I would refer you to a particular reference literature by Kaplanis et al. Okay? He has classified the extraction defect and what happens the socket into the 4 types, depending upon the amount of resorptions that they have undergone since extraction. And as you can see, the treatment recommendation of implants also do change based upon that, correct? So when you do look into this, you would have places where there is hard tissue loss, as in alveolar bone loss with alveolar bone defect. You will have a situation wherein you've got adequate ridge dimension, width, and height, okay? The reference for this would be Judy and Mish classification of your particular ridges. Minimum dimension to hold a particular implant would be 4 millimeters in width and at least 8 millimeters in height. Anything compromised other than that, what happens would not be enough to support an implant. And supposing that if it is present, then later the imperativeness of keratinized mucosa around that ridges are important. Now, this is something which I was talking about, okay? You put an implant, you come and load it, the patient has a tooth in the mouth, everything is fine. What do you notice? You can see the implant almost what happens through the particular mucosa. That's because of the loss of the labial cortical plate, okay? And then later, many a times, if you're lucky enough, in this situation, it's still correctable. But you can think about peri-implant regeneration. You can think about putting a particular particulate bone graft with the GBR barrier membrane. You can think about submerging the implant and re-osteointegration. That is all the case. But what happens is that when you get a recession beyond that and the threads get exposed, then later at that aspect, what you need to look about is to kind of what happens to conceal those threads as a camouflage, but it is never going to be functional. So the point is, all this can be avoided by the principle of 5 triangles, if you see over there. Whenever you do extract a tooth, okay, you will get the dimension of the socket might not be in direct conformity with the particular available dimensions of diameter and length as in a natural, what happens, provided implant series that you do get. So in that, what are the 5 triangles? I don't have the pointer to my use, otherwise I would have told like that. But whenever we are saying that, you do say that one is your design of the implant. Okay, I'm just trying to read it out for you. Can you appreciate what one is? What is that? It's the labial cortical plate, what I just spoke about. Having a 4-volt socket is very important. The more you have about that, that's better. If you are not going to have that, try augmenting that first. Do a ridge recontouring. Then later, can you read 2? That is your primary stability. That is the quality of the bone that you do get. Okay, that means the more what happens, let's say towards type 2 that you get of bone, otherwise let's say D2 quality bone, your stability of the implant would be better. Okay. Third one, which we can see, is the design of the implant, the taper that it possesses and the way how it can engage that surrounding bone, whether they're active or otherwise. Fourth would be something referred to as the distance between the implant and the inner cortical plate lining. That is going to be called as what? The jumping distance. So the jumping distance, if you are going to have less than 2 millimeters, usually you're not posed with a problem. Greater than 2 millimeters, you have to graft, okay? What is the importance of that is that you have one option nowadays of doing something called as partial extraction therapies. Okay? So sometimes when you knock off a tooth, sometimes you might be better, what happens, placed in preserving the buccal shield so that the labial cortical plate is preserved. This is referred to as the socket shield technique. Right? So then later, I was on 4, that is the jumping distance, and then there are 5, which most people tend to overlook, is the gingival phenotype. The phenotype is also important consideration. So sometimes to prevent the resorption of the labial cortical plate, you can augment that particular bit of keratinized alveolar mucosa so as to prevent further loss of the particular labial cortical plate, which can tend to expose the implant threads. So here, if you just see, this is one case which we had done in our college. If you can see, this is the CBCT diagnostic marking. What we see is a natural tooth over here, towards the left, correct? And towards the right, what you see is the particular implant placed in precision with those principle of 5 triangles. What you do notice over here is that small wedge of what happens, the labial, what happens, the proximal half of the tooth being preserved. Can you discern that? I'll just point here. Can you see it? Right? That is the tooth section that is preserved, because that is going to preserve the particular, what happens, labial cortical plate from resorbing, and it saves us a lot of money in terms of what happens, bone grafting and membranes. We work in India, money is sparse, you have to improvise, right? So that's it. So that is the one way how we look into this, and then later what happens is that we get that. This is referred to as the socket shield blockers, otherwise the root membrane technique, for the benefit of the PG students if they are there to have a look into that. So then later, I was speaking about your particular augmentation of the particular gingival phenotype by using connective tissue graft. This is something which is called as the Vista technique that we adopted. We used Vista separators. Now, what we use, and once we create this pouch, most of you are familiar with the thing called as your subepithelial connective tissue graft. You pass it in, and it adds to the thickness of the gingival phenotype. Okay? So this is a particular situation as in how much of keratinized alveolar mucosa do you need to have. You do your prosthetic examinations for your patients. And when you do that, you have something called as a residual ridge. And you get a residual ridge mucosa. In that, you get a residual ridge keratinized mucosa, and you get a residual ridge keratinized attached mucosa. What is important is that residual keratinized attached mucosa is imperative for us. And when you do get it in the edentulous case, as in a zero-wall defect, you normally have around, in prosthetics, what do they tell you? 2 millimeters is enough to cause their stability and otherwise. But if you're putting an implant, that will create a problem for you, because biological width is how much? At least 2. 2 buccal, 2 lingual. That's the minimum of 4. And if it's having greater than 5, it's great. So if it's going to be what happens 5 millimeters and all, usually you'll never have a problem, because the distribution of keratinized attached mucosa will be both sides, on the buccal and the lingual sides of the particular what happens implant. Where it tends to be slightly oriented more buccally or lingually, our flap design for an implant will have to change to a apically displaced, otherwise to that of split thickness apically displaced. That you can, what happens, refer to Nevin's surgical modifications in periodontal surgery, volume 1, volume 2, volume 3. Okay, there are quite a things to read. You can go according to that. So this is the other alternative for the same. Okay, and wherever you do need to augment, like I told you, work in India, you have to improvise. Economics matter. So the cheapest source for native collagen is God-given, is from the hard palate. Okay, you can accomplish it since you are going to use it in implants. If you are going to use it by an onlay technique, can be done by the particular free gingival autograft. If it is going to be the inlay technique or a sandwich technique, you have to do the subepithelial connective tissue graft. So as you can see, there is a limit to that commodity. The palatal vault and the presence of your vessel and nerve bundles sometimes limit the amount that you can take. So 10 millimeters by 15 millimeters is usually what is usually harvested. And usually for that, once you harvest it, do you get a scar? if you harvest it with the periosteum, yes. And if you do wait for that to correct, then later what happens is that it might take a minimum of 6 months to establish the original thickness. And whenever you're doing it for these techniques, try to harvest it only with the connective tissue, what happens, sparing the periosteum. So if you can see the first photo, this is a case where there was inadequate width of what happens, keratinized attached mucosa. We harvested a particular FGG from the palate and we deepithelialized it. So what we have is a deepithelized free gingival autograft, which is essentially a connective tissue autograft. And if you see very clearly, we use the gingival formers with 3 punches in that what happens in that particular graft to keep it as an onlay for the particular aspect to stabilize the graft, so that we will get the augmentation of the keratinized mucosa. And we did a closure. So as a result, we were able to do it in that way. This also was done in my department. These are textbook references from what happens in Evans for showing the particular alternative modes of therapy. Here in which what happens, we saw that the apically displaced flaps were used, and as a result, you can get what happens, the kind of a thing without exposure of the bone. Why split thickness is important? The periosteum surrounding the bone will prevent further resorption. It's very important. So that is the empirical part of that. And then later, this is a case where your sandwich grafting was attempted. When we look into this, sometimes you can choose to submerge it further. You can remove the gingival formers, put on the cover screws, and submerge it for a period of 6 weeks to 8 weeks again to get the bulk of the tissue. Now, this is the way how it would be going about. One other technique is called as the Elegard's technique. Okay, it is about root submergence. Okay, sometimes you can refer it to as a coronectomy with a particular root submergence. The principle behind that is that you will preserve the alveolar bone height to prevent resorption. This is very important when you are doing delayed immediate type of implants. Okay, one case which we had done in our department was when we extracted the tooth. We, what happens, grafted the defect with a particulate, what happens, DFDBA, and then later what happens is that, once again, ideal situation, I would have used a particular GBR barrier membrane, but the problem is it comes at a cost, somewhere in the range of 9 to 16,000 Indian rupees. Now that is quite a penny to pay. So what we do in the Elegard's technique is that we take connective tissue and we use the periosteum for its GBR effect. That is what we had done. That is the GBR barrier membrane, so which we are going with that. How much more time will it take? 2 minutes. Okay. And we are done with the particular aspect of the particular closures. And once you do that, you would get the final result that you wish. Maintained alveolar bone crest, adequate thickness of the particular peri-implant mucosa, adequate bulk so that further recession would not be there, and adequate support so that what happens is that the tissue would be in a position to find as a particular scaffold for itself rather than rely upon just what happens collapsing on the implant. If you do choose not to go for these grafting techniques, you can go for your biologics, which what happens mimic that of connective tissue. They come at an expense. Mucograft is available in our country, costs 22,000 rupees for a what happens cubic, what happens inch. And similarly, alloderm are the older variants which we talk about. So these are the advances in tissue engineering which you can incorporate. So with that, I wish to conclude with a warm thanks. And then later is that I would what happens request any questions if there are any, right? We're done? Autologous dentine, this particular postural extraction therapy is a block form of that. Autologous dentine grafts, when you take it in a particular, extract the tooth, crush it, and you put it there, it can be used to the same effect, yes. Only one problem is, when you do that, when you put it into the mill, you can't actually assure of the particle size. So if you can get what happens, a dentine autologous matrix milled down to 200 microns, it would serve just as good as a bone graft. Absolutely. But what happens is that if it's going to be above 200, it can cause a foreign body reaction. That's the only issue, right? Any further questions, please? I wish to conclude. Thank you so much. Thanks. Sure.
Thank you, sir. A very good morning to one and all present here. I am Dr. Ulfat Kachi.
And I'm Dr. Jia Joy, the master of the ceremony.
I would request all the dignitaries to grace the dais. We would like to welcome our chief guest, Dr. Neelam Mishra ma'am, Vice Chancellor of Krishna Vishwa Vidyapit. Our guest of honor, Dr. M.M. Utaya Kumar, President of Sri Lanka Dental Association, Northern Province, Secretary Sri Lanka Association of Oral Implantology, Dr. N.D. Sashikiran Sir, Dean of School of Dental Science, Conveyor-in-Chief of the conference, Dr. Anmol Bagaria ma'am, Founder and CEO of Cynodent, President of Indian Society of Dentistry and PFA Section Chair at Large Asia Region, Dr. Ashish Chandra Sir, Co-Director of Cynodent and Vice President of Indian Society of Dentistry and PFA Section Co-Chair at Large Asia Region, and Dr. Siddharth Verma Sir. We welcome you all to the inauguration ceremony of the 14th World Health, Dental Sciences and Oral Health Conference organized by the Cynodent and Indian Society of Dentistry in collaboration with School of Dental Sciences, Krishna Vishwa Vidyapit, Karad, Maharashtra, in a wonderful city of Karad, the city full of beauty and history and is surrounded by mountains and rivers.
As it is very important to commence the event with God's blessing, we have Ganapati Vandana performed by the students of SDS.
गणनायकाय गणदैवताय गणाध्यक्षाय धीमहि गुणशरीराय गुणमण्डिताय गुणेशानाय धीमहि गुणाधीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि
Thank you, students. The theme of the conference is bringing the future of dentistry now and beyond. It will bring together stalwarts and delegates from a wide range of discipline to meet, greet, and learn new things. We also look forward to hearing from our delegates through the numerous scientific presentations on their breakthroughs, advancements, and trends in the fields of dentistry. This conference had pre-conference courses on facial aesthetics, dental implants, and lasers in dentistry yesterday. This conference is providing a great opportunity to students, clinicians, and academicians to learn and to explore beautiful city as well.
It's a pleasure and a matter of great pride for us to welcome all the delegates to this prestigious institution. Today, we have started with the lectures covering multiple approaches of dentistry by renowned speakers across the globe. Scientific events were planned such as the table clinics, paper and poster presentations to expand your caliber. Among the other events in store for you, we had Dentist Award Show, Gala Dinner and Cultural Night. No academic event can be implemented without Ma Saraswati's blessing. Thus, I kindly request all the dignitaries to come forward for the lighting of the lamp.
Following the culture of Atiti Devo Bhava, we would like to start with the ritual of presenting a bouquet to our chief guest and all the dignitaries as a token of respect. Felicitations of Honorable Vice Chancellor Dr. Neelam Mishra ma'am. I request Dean Dr. N.D. Shashikiran sir to felicitate Honorable Vice Chancellor Dr. Neelam Mishra ma'am with a floral bouquet.
Thank you. Now I would request our Dean, Dr. N.D. Shashikiran sir, to felicitate our guest of honor, Dr. M. Uttaya sir. Thank you, sir. Now, I would like to call upon Dr. Anmol ma'am to felicitate our Dean, Dr. N.D. Shashikiran sir. Thank you, ma'am. Thank you, sir. We would like to invite Dr. Shashikiran N.D. sir to address the gathering.
morning. Shall I see the enthusiasm now? Good morning. Yeah, thank you. Before starting, just seek the blessing of our Honorable Chancellor, Suresh Bhosle sir, Advisor sir, Ved Prakash Mishra sir, and then Praveen Singare sir. Dignitaries on this stage, Honorable Vice Chancellor Dr. Neelam Mishra ma'am, then we have one more guest of honor. He is Dr. Uthaya Kumar. He is come all the way from Sri Lanka over here for this function. He is a president of Sri Lanka Dental Association, Northern Province. Along with that, we have Dr. Anmol Bagaria, founder of CEO, Cynodent, and Dr. Ashish Chandra, co-director, Cynodent. The dignitaries of the stage, my dear colleagues, students, delegates, and guest speakers over here. A warm welcome from the School of Dental Sciences. I am honored to welcome you all over here. I would like to begin my expressing heartfelt thanks to the Cynodent for their invaluable support in making this event possible. Under the aegis of Krishna Vishwa Vidyapeeth and our organizing committee for the dedication and hard work in bringing the event together over here. This hybrid event witnessed the registration across the country, including states like Punjab, Haryana, Karnataka, Jharkhand, and so forth. We started this program yesterday and day before yesterday. We had a pre-conference courses. Along with, we started with online papers, poster presentation, table clinics. That is yesterday and day before yesterday. Today, we started with the guest lectures. We are lined up around totally 15 guest lectures for this today's function. It's a proud privilege moment for a School of Dental Sciences, as we have here Dr. M.M. Uthai Kumar, who is a president of Sri Lanka Dental Association, a northern province, amongst us in a distinguished as a guest speaker too. A special thanks to our guest speakers, whose hands-on lectures and insights on specialized topics will greatly enhances our knowledge and practice in the field of dental science. To all the delegates, both online as well as an offline, your presence makes this conference truly special. And I encourage you to take the full advantage of this knowledge sharing and networking opportunities. Together, let us strive to advance dental science and improve oral health outcomes. I wish you all the productive and enriching conferences. Before I conclude, hope we have fulfilled all your things in cultural, as well as yesterday we had a grand gala banquet. If anything, any lacunas which has been happened, please forgive us. Today we are having once again from morning to the, you can say, evening tak, we have a continuous lecture series over here. Then we wanted your active participation over here in this hall as well as in the School of Dental Sciences. Thank you very much.
Thank you, sir, for your inspiring words. Next, we would like to invite Dr. Anmol Bagaria to address the gathering.
A very good morning to one and all present here. I would firstly pay my sincere thanks to Honorable Vice Chancellor Krishna Vishwa Vidyapeeth Karad, Dr. Neelam Mishra Ma'am, Dr. Uthaya Kumar Sir, President Sri Lanka Dental Association, Northern Province, for giving us their valuable time and gracing the inauguration ceremony of our conference, and all our dignitaries on the dais, respected Dean Sir, Dr. Siddharth Sir, Dr. Ashish, and all our dignitaries of the dais. I once again welcome you all to the 14th World Dental Sciences and Oral Health Conference organized by Cynodent Indian Society of Dentistry in collaboration with School of Dental Sciences, Krishna Vishwa Vidyapeeth Karad. I also welcome all our eminent speakers, all our faculty members, and dear delegates. I hope all our delegates are enjoying the learning experience with us. I wish you a happy day and a happy conference ahead. Thank you.
Thank you so much, ma'am. Now, I would like to call upon Dr. Ashish Chandra sir to address the gathering.
A very good morning to one and all present with us today. I, Dr. Ashish Chandra, extend a warm welcome to you at the 14th World Dental Sciences and Oral Health Conference organized by Cynodent International and Indian Society of Dentistry in collaboration with Krishna Vishwa Vidyapeeth Karad, Maharashtra. I heartily welcome all the dignitaries on the dais, our honorable guest of honor, Honorable Vice Chancellor Ma'am, Dr. Neelam Mishra Ma'am. We welcome you, ma'am. A special welcome to our chief guest, M. Uthaya Kumar Sir, President Sri Lanka Dental Association, Northern Province. I welcome our respected School of Dental Sciences Principal, Dr. Shashi Kiran Sir, Organizing Chairperson, Dr. Anmol Bagaria, Organizing Co-Secretary of the Conference, Dr. Siddharth Sharma Sir. We welcome all our respected dignitaries of the dais. Heartily welcome to all the heads and faculties of various dental colleges and our dear delegates for making this conference a grand success. Cynodent has served you selflessly for 8 glorious years now, and today we are yet again at your service as we embark upon this beautiful 2 days of learning and sharing. Now I will like to let you know a brief about Perry Fawcett Academy. Perry Fawcett Academy section at large Asia region has come up with the fellowship to the deserving dentists across the globe. Along with this, we have our student merit awards for the UGs and PGs to encourage them to do outstanding contribution in the field of dentistry. We also have community service awards, in which this year I would like to let you know that around 40 colleges around the India has participated in 2024, and more than 1200 plus healthcare camps has been conducted under the banner of Section at Large Asia region, which has benefited to a broader population around the country. We also encourage college with Best Dental College and of the State Awards in our convocation ceremony. I welcome more dentists to join our prestigious Perry Fawcett Academy for the upliftment of our noble profession. Yesterday, we started our conference with extensive 2 days of learning, in which we started with pre-conference courses, which included certified hands-on courses on facial aesthetic, lasers, and dental implant dentistry. And today, we officially inaugurate our 14th World Dental Sciences and Oral Health Conference, where we will have our scientific sessions and lectures by the eminent speakers from all across the India and internationally. And not just that, to acknowledge and honor the stalwarts of dentistry, we have International Dentist Awards, recognizing and honoring dentists across the globe. So buckle up yourself, because there's a lot we have to teach and a lot you have to learn and upgrade your skills and knowledge. And I again, on the behalf of Team Cynodent International and Perry Fawcett Academy, I commit to continue to serve you in the coming years as well. I wish you all a good time with us. Thank you.
Thank you, sir, for your inspiring words. Now, I would like to invite our guest of honor, Honorable Vice Chancellor, Dr. Neelam Mishra Ma'am, to address the gathering with her words of wisdom.
First of all, a very good morning to one and all. I'm audible? A good morning to one and all. I welcome from the bottom of my heart, our guest, Dr. Uday Kumar from Sri Lanka, and our organizing chairperson, Dr. Anmol Bagaria, founder and Cynodent, CEO Cynodent, organizing secretary, Dr. Ashish Chandra, our respected dean, and all our respected faculties, students, delegates, all a very warm welcome from our institute. So respected dignitaries on and off the dais, esteemed organizers and participants, ladies and gentlemen, it is an absolute pleasure and privilege to stand before you today in my humble capacity as the Vice Chancellor of this illustrious university in the inaugural ceremony of 14th World Dental Sciences and Oral Health Conference on the theme, Bringing the Future of Dentistry Now and Beyond, organized by School of Dental Sciences. I extend my heartfelt gratitude to the organizers for inviting me to be a part of this prestigious event, which marks a significant milestone in the field of dental education profession, including its advancement in the all-round manner. I am deeply proud to witness the outcome of months of hard work, dedication, and visionary thinking that has culminated in this notable conference. This event stands as a testament for our commitment to advancing the cause of learners of dental education in the country in a big way, so as to enable them to cater to an effective and efficacious dental healthcare delivery system in India, which is wanting in so many ways. The purpose of this conference is to bring together the brightest minds, the most innovative ideas, the latest developmental propositions. We aim to create a platform where knowledge can be shared, ideas can be nurtured, and partnerships can be forged to drive sustainable and transformative changes in the domain of health profession, education, and in general, and dental education in particular. Our world is facing formidable challenges in the domain of dental health care because of various impacting factors, including developmental pace of scientific and technological advancements, and also the demographic alterations. These challenges call for innovative solutions, and education lies at the heart of this transformation. It is quality-centric education that is going to generate the world of tomorrow, and it is open-ended innovation in the domain of education that will make it possible in the interest of man and mankind alike. Today, we have gathered here not only to take the stock of challenges and concerns that confront learner-centric dental education, but also to evolve a way forward for the same, especially in the Indian context, so as to make the operational systems outcome-based and quality-centric as well. I must emphasize that the success of this conference depends on the active participation and engagement of all the attendees. Your presence here today reflects your commitment to making a difference in the world of dental education and profession alike. I encourage all of you to network, to exchange ideas, and seek out opportunities for meaningful collaborations. Because transformative dental education needs a paradigm shift from standalone institution to a cluster approach. It is through such interactions that groundbreaking solutions are often born. In conclusion, I would like to extend my best wishes to all the participants, speakers, and organizers of the conference led by Dr. Shashikiran Sir, Dean of School of Dental Sciences. May your discussions be fruitful, collaborations be transformative, and innovations be revolutionary. Let us work together to ensure that dental education and profession continues to thrive, to evolve, and to invoke desired sustainability, whereby we are able to make Mother Earth a better planet for human habitation till eternity. Thank you, and let the conference begin with great enthusiasm and optimism. Jai Hind.
Thank you so much, ma'am, for enlightening us. Now, I would like to call upon Dr. M. Uthaya Kumar, sir, to address the gathering.
Good morning, everyone. First of all, I would like to thank our Vice Chancellor, Mr. Madam, and the Dean, Dental Faculty, Sasigaran sir, and the Cynodent Group, Dr. Anmol and Nasik, and organizing Dr. Siddharth, and all other faculty staff, and my dear students. It is my great privilege and respect to be here as a part of you. So, first of all, I would like to thank all of the organizing committee for inviting me to and give that such a respect and the wonderful hospitality here. I noticed, because dentistry is a growing field in the medical sector, so they have mentioned the health for globally for all, Cynodent theme. It's mean all the facilities and techniques should go not only the city, for the outside the city. So I appreciate this type of workshop for the students, especially students, because many workshops conducted for the doctors in all over the world, but students have the limited opportunity to learn advanced things. They have only academic career, they learn a lot of things. It is hard to practice outside the market because they have to practice with the many senior doctors. So I wish you all the best for your career, and thank you very much again for inviting me and giving us such a wonderful respect. Thank you very much.
Thank you, sir, for such kind words. Now, I would like to invite Dr. Siddharth Verma, sir, to propose the vote of thanks.
So it's my humble privilege to stand in front of you to extend my vote of thanks. So on this note, I would like to extend our heartfelt gratitude to our Honorable Vice Chancellor, ma'am, Dr. Neelam Mishra, ma'am, for taking time from our busy schedule to be part of our event. Thank you, ma'am. We also extend our warm welcome to our esteemed distinguished speaker and guest of honor, Dr. Uthaya Kumar, sir, for being with us. Apart from the dignitaries on the days, all the dignitaries of the days, my faculty members, we extend you a very warm welcome. And this event would not be successful without having a distinguished set of speakers we have amongst us. So they traveled all the way along, accepting our invitation. We thank them for accepting our invitation and being a part of our conference for this two-day event. Thank you to all the distinguished speakers. And obviously, the event would not be fruitful without having a good presence of the delegates. So a very big thank you to all the delegates who have registered for the conference and taking the benefit of the conference, both online mode as well as offline mode. And this event would not have been possible without the tireless and dedicated efforts of the team Cynodent, headed by Dr. Anmol and Dr. Ashish. They have been literally in the past 1 month, we have been continuously on phone calls trying to put this event together. And one very good thing what we saw in this whole process is the whole team of Cynodent. It's not just a bunch of individuals, they are a close-knit family with having elders along with them who are working tirelessly for this event. That's a very rare thing what we see in the current era. So we thank you, the entire team for Cynodent, for making this event happening. In this context also, all my respective committee members who have been heading the scientific, the cultural, the registration. So thank you for all your tireless efforts for making this a smooth functioning event, along with my student volunteers. Without their help, this would not have been possible. Lastly, all the technical departments, the photography department, the civil department, and the electricity department, we thank you all for your kind help towards putting this event together. So I would like to close my statement by saying a quote. The illiterates of 21st century are not those who cannot read or write. The illiterates are those who are not willing to learn, unlearn, and relearn. So with this quote, I wish everyone to have a good learning experience in this couple of days. Thank you all. Thank you.
Thank you, sir. Now, I kindly request everyone to please stand up for the national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you everyone. Now we would like to start our Cynodent Dentist Award 2024.
Dr. Lakshmi Pandey, I would also like to invite Dr. Siddharth sir and Dr. Uttaya Kumar sir to come up on the dais to felicitate the speakers. Dr. Lakshmi Pandey ma'am to receive the token of appreciation.
I would like to invite Dr. Vinith Kine sir on the stage to receive the token of appreciation.
Now, I would like to invite Dr. Vishwaraj H. Nikam sir to come forward and receive the token of appreciation.
Now, I invite Dr. Anmol Bagaria ma'am, Dr. Ashish sir and Dr. Siddharth sir to felicitate Dr. M. Uttaya Kumar sir. Would like to start with the Cynodent Dentist Award 2024. I to come forward on the stage to give away the prizes, starting with the Emerging Pedodontist of the Year. The award goes to Dr. Namrata Gaukar ma'am.
The next award is Emerging Researcher of the Year. The award goes to Dr. Amit Zadav sir.
The next award is for Emerging Prosthodontist of the Year. The award goes to Dr. Abhijit Kore, sir.
The next category of awards is Emerging Orthodontist of the Year. The award goes to Dr. Yusuf Ahmed A. Ronat, sir.
The next award is for Emerging Oral Medicine and Radiologist of the Year. The award goes to Dr. Ashwini Rani SR, ma'am.
I would request Dean, sir, to come up on the dais. The next category of award is the outstanding contribution in the field of orthodontics, and the award goes to Dr. Channam Malappa R. Ganigar, sir. I request Dr. Yusuf, sir, to come forward and receive the award.
The next award is for the Emerging Prosthodontist of the Year. The award goes to Dr. Swapnil Chopde, sir.
Next category of award is the International Dentist of the Year. It is backed by Dr. Udaya Kumar, sir.
The next award is for the Best Student-Friendly Dental College. It goes to KLE Dental College. I request the students of the KLE Dental College to come forward to receive the award. Next up, we have award for the Best Private Dental College of Maharashtra. It goes to KVV Karad.
I request all the staff members of School of Dental Sciences to come forward to receive the award.
Thank you, sir. Thank you, ma'am. Now I would like to invite Dr. M. Uthaya Kumar, President, Sri Lanka Dental Association. He is an eminent dental implantologist. Sir will guide all the insight on how digital dentistry will make our practice more successful. Over to you, sir.
Of Krishna, this is Sasikaran sir, and the organizing committee, Dr. Anmol and Dr. Asik, for inviting me to deliver this lecture in the important people. So last 2 days I am here. I am happy to about how you treated me very well, and even Sri Lanka and India has a very close relationship from the independent day in 1948 we got, you got I think 1947 October 15. So from that day Sri Lanka and India have very good connection. We look cultural, more cultural and religion are more or less same. So I have been several countries, but in other countries we don't have such a tradition. So I am thanks again for everything you have done for me. So dentistry is a part of the medical service. So Dr. Anmol and Asik, they started the Cynodent to provide the knowledge to the future dentists. It is really important that every day we have to upgrade our knowledge, because people go with the new things to life. So when new phone comes, they go to the market and get the phone. So like that, all your service provide. If you have a good dentist and provide the new thing with digital techniques, the people will come and see you and get the treatment. So to become a successful in dentistry and the life, the very, very important thing is, this is a city I came from. So you may know the person, the left corner, the former president, the Abdul Kalam, he is a scientist, and he visited to my school. So it was a great opportunity to a wonderful person to my city. It's a northern part, a very small city, but the president visited there. This is a university I studied, because only one university in Sri Lanka, dental school. Every year 60 people intake. So this is a very beautiful place. This is a second place I lived. I was migrated to Australia, and this is the city of Melbourne. But I like to work in my country, whatever I learn from outside the country, because we studied the poor people, money, tax and everything. So I wanted to apply the knowledge and skill to the people. So as now you all are the students and different faculty, different year. So in your career, very, very important thing, what is this is an interactive session. You can stop me at any time and ask the question. This is not a lecture. And what is the important in your life? To have a good car or to have a good home? So you let me know. Decision making. So every point you have to take a good decision. I think you all have make a good decision to become a dentist, because dentist is the most important person to make smile others, no? I was selected to the faculty of medicine, but basically I didn't like, because every day I want to cry with the people, no? Because when they come to ICU, EO, so when they lost their the loving one, so we also want to cry with them. So dentistry is always, we have to be happy. One person is coming to your chair and broken tooth, when you deliver the very good composite filling, so after you give the mirror, how much you can see the difference on the face. So now see, this is a traffic signal. If you go
and think where I should go, no? So you will stuck on the road. Like that, you have to take a good decision in every step. So if you want to invest the money on your clinic, you have to think about what you are going to buy. Even so, you are a dentist after you are graduated, so you will make a decision. You want to become a good dentist or earn a money, or some people, even when I was in Australia, I met many Indian friends. They come to Australia to work, so you have a good opportunity to go not only in India, so you have an opportunity to go outside the country and work. So take a good decision now. So what you are going to do. And even if you earn money or study, your life-work balance is important for your health. Because now is digital world, everyone is busy. So always you don't have time to talk with each other, even family. So always your patient will ring and you are always with the phone. I have seen in Colombo one hotel, there were 4 people. I think they are from some other countries. Wife is sitting one with the other corner with the phone, husband in with another phone, children are playing and with the phone, one son is iPad. They don't know, they are not aware about the surrounding. So busy life, so we have to take off from our work and spend the time. So successful of practice. So today I'm here to teach you how your digital part will help you enhance your practice, and that, so you have to have a good communication. Even Australia, I paid $5,000 and learned how to communicate with patient, because not like our countries, we have to pay for everything there. Even small courses, they charge for 800. This is a good opportunity to learn good things from Cynodent. It's a non-profitable organization. When I contacted Damal, she asked me to deliver the lectures. I told, okay, don't worry, because sharing knowledge is very important. So one day, we are not taking with us anything. So whatever we know, we have to tell to others to become more. So good communication skill. So what is the good communication skill? Even sometimes your patient come and fight you, know. So sometimes they will tell, so doctor, you have done an extraction in my wrong tooth, no? So sometimes it is usual thing, because what is the reason for telling the story? Do you know about that? Because the patient come to the pain, they can't identify the particular tooth. No? With severe pulpitis, you cannot isolate the tooth. So they will tell some tooth, but when you examination, you will find that some other tooth. No? So you will go with the correct tooth, but patient will later will come and tell some story. So good communication skill is important. So we have to understand their problem first. So we have to talk with them very nicely, because don't interrupt to them. So that is a very important thing. And other thing is, in Western country, infection control is important. I have seen some magazine saying in India, some road dentists are there. I'm not sure. Is it true? Some are extracting the road in the... No. So I read in one paper, but it may be the whole story. So it's mean, even Sri Lanka, some technicians are doing the dental job. So they don't follow the infection control rule. Because in the many countries, even if you go to the abroad, they have the exams, especially for the infection control and the communication. There are 2 main parts you should pass out of 12, for an example, 12 tasks. The infection control and communication should pass. And other thing is continuous learning. To become a good dentist, so you have to learn every day. So if you are changing everything new, when you go to the shopping complex, new dress, so what is a modern, these dresses are there, what is a new phone is coming in the market, even car, mainly men, so they go to the market and buy a new car. So what is a new car available? Why we should not go for new things in the dentistry? I have seen many, even Sri Lanka is a small country, so only small, if you conduct any program, around 200, 300 dentists will actively participate all over the country. It means a small country. Practicing dentists are around 5,000. Now only they are upgrading their knowledge and skill. I was the first person to buy CBCT intraoral scanner, and I motivate my friends to buy those things, because it's mean people invest the money on their home and the car, and they don't like to buy even the digital X-ray, RVG or something. It is our intention, so we have to change on that. So continuous learning is important.
So in your country, is that CPD is compulsory or not, sir? Continuous dental program is not compulsory. Some other countries, even Australia, so every year we have to have 100 points CPD, continuous learning, to renew our license. That is a good thing, because some people voluntarily become to learn, but some people, they practice whatever they learned 20 years back. Even when I prepared the crown 20 years back, one of my senior dentists came, why doctor should cut the enamel? Enamel is natural thing, don't cut the enamel. So without cutting the enamel, how you can put the crown? So that is a nature. So we have to go with the changes. And the last I mentioned, invest on the required equipment. So if you want to cook, so if something is not there, your food not maybe taste, So like that, the treatment, so we have to have a good knowledge and skill, some investigation facilities. In Australia, when the patient come, first thing they will go for an OPG. OPG is, so do you go to OPG for every patient here or not? No. So when we think it's an unnecessary exposure. But in digital, it's a less radiation. So what they do is, here is mainly in our countries, we treat the patient what they ask, not what they need. So important thing is, even private practice. So many friends, so okay, when the patient come, when I tell, so you have to have X-ray, and they said, okay, doctor, no need, so you go, carry on, so I can manage. That is not an issue. We have to tell, no, we are not mechanic, no. Whatever they ask, we have to do, no. So we are the professional. We have to think about that. So that's why they invest on if you don't have an X-ray, because I have a CBCT in my own clinic, so it was for my interest, because I am doing implant. But many of my friends from other areas sending me. So when the patient come to my clinic, they ask the first question, doctor, can you do the implant here? So it's mean they think the change, everything is there. They are satisfied about the equipment. That is an important thing. Better to have, at least start with the basic investigation, like with the radiograph, like IOP radiograph, RVG or postplate sensor, those things. And communication is, I mentioned about that. Listening, even the exam, they teach me, and in Australia, don't interrupt the patient. When, okay, we'll go and take an injection and go and for the extraction, it will lead to some wrong thing. So best way is listen carefully, because every time you plan for the treatment previous day, 15-20 minutes. For an example, if the patient is coming for perio or implant treatment for next day, you go for an X-ray and history and examination. Think about that, what we are going to do. Spend the time on that. So here is what, okay, we are not listening much. It is a common issue is everywhere. And okay, even government college and hospital, it is difficult to practice. So because we have to see a lot of patient on a particular time period. So without interrupting, we have to listen. Sometimes they will interrupt in a pain in a different ways, no? One person will tell, okay, I am having an ache. Some person will take, I have sensitivity. Some people will take some like a throbbing-like action. So they can't describe the pain very clearly. So I think oral medicine specialist is there. Oral surgeon, he may understand what about the pain and, okay. Another thing is, keep your practice clean. So I am talking a little bit about how to improve your practice and how to be success in the practice and normal things, and the digital I will touch on that. So when you go to the hotel, if someone is there with the dirty things, you won't eat. Now, globally, everyone is changing. The next generation is coming forward and looking little sophisticated and fancy. No? So we have to have those things. And supervise, because in autoclave, every day, I think you have maintenance system, no? Every day testing system and stickers and everything is there. But in my clinic, I always on my machine, because we don't know whether they started or not. In between that it stops. So we have to ensure and monitor those systems. You can stop me at any time. Anything in dentistry, whatever I know, I can tell. But I don't know everything. But I know a lot of professors are there, academic staff. I think this main audience are students. because you have to become a good dentist. Your career should be a good. So whatever I learn, I know, I am telling you. So do you think, so you have to stick on the traditional practice or you have to change? Change, okay. So do you know, sir may know this about that. This old TV, this is a new TV. So when you go to the market, why should we should buy for this old one? So now is new technologies and TVs are available. So digital things are every day in every sector in my practice and everyone. So first thing is the record keeping, the practice management system. Do you have your own practice management system, or how do you connect with the computer? You have own, not a common one. You have developed the own one. Okay. And the radiographs, because when they come for investigation, important value in the diagnosis and treatment plan purpose. And CBCT is an valuable thing. And endodontics, we use the endomotor and apex locator. Earlier we measured the working length. I'm not agree with all the digital are correct, but there are some error. But so digital we have to change. Even the new TV we buy, sometime second day it will give some problem. But old TV may long period. So and intraoral scanner, 3D printing, milling and laser. Yesterday also there was a lecture about the laser, and I was there. So this dental for Windows, the software system in Australia, this basic things. This software has a lot of things there, pocket depth and so many things are available. So this, do you connect the software with all your investigation on that, X-rays and OPGs? Good. This basically, if the patient come with the pain, do you go for an X-ray with all the patient? Yeah, okay. Because we think it is unnecessary or over engineering. So we are using the digital more. But actually, in Western countries, they take a single X-ray, IOPA, before the extraction, because they don't have much exposure to X-ray. Even when I was in Australia 4 years, I didn't do one extraction. So it's mean extraction are very less, but our people are very keen. So they know, okay, but what is the important to take an X-ray before the treatment for IOPA? Sorry for asking question. If you can stop me, you can ask the question, I will ask, otherwise. So single X-ray will tell what is the problem. If the cavity is there, you can assess how much is extended, how far, any periapical lesion, or sometimes your root abnormality is very important in the extraction. So you can have a multi-rooted tooth, even the single, sometime premolar have multi-rooted, molar have 4-rooted, and taurodontism is the biggest anatomy. And so better to, because after we gave the injection and when we struggle, it will take much time, no? So you will have some idea about that. So I think in our setup, we are little bit restricted to go for things, but when you go outside, if you have own practice, you don't have limitations. So better to go for an X-ray, single X-ray. And OPG give a value information, because OPG 6 year, 12 year, 18 year, there are guidelines. In our country, we don't have the guidelines. In India, but about India, do you have any guidelines to general practice? No. So in Australia, they have the therapeutic guidelines. If you are interested, you can Google and read. So every treatment protocol they have. For an example, if the patient come with the pulpitis, what is the protocol? What they should maintain? So take a history, investigation, and the examination and investigation. What are the things should be included? Because they will show a lot of money. You know that Western countries, the problem is dental treatment is expensive, and same time, if they do the mistake, they can do a lot of money. There's a issue. That's why they take an X-ray, simple thing, they go for a safe side. So our countries, we have some limitation. Economic barrier is there, technological barrier is there, so we can't use everything. Can you hear me? Yeah. So nowadays I talk about the about the this milling machine. So even I bought recently. So it has a good solution, because when you have this equipment, so it will reduce your time, and it will you can satisfy more in the patient. So this one of my friend, he came from UK. He did the implant of many years back, 10 years back. He wanted to do the solution immediately. So because he stayed at my home, because he is my classmate, he studied same school, so he wanted to stay at my home 2-3 days. I want to give a solution. So the traditional way, you have to take extraction and allow to heal, and you have to take an impression and cast and send the laboratory. There are a lot of things you have to do. So this is after treatment. So he immediately bite everything and eat. So he was happy. So because it was digitally done. So digital workflow, I think you may know, students, and intraoral scanner instead of impression, that is a digital impression. There is a software, CAD/CAM. It's a computer assisted designing and computer assisted milling. So milling is the milling machine, designing is the software. If you all are really interested, even many dentists, they are very, even prosthodontists I met in Chennai, they are very happy to do the only design part. They are not doing other work, because they are very keen to design. Because like a came, if you are, if you familiar it, you may be very interested on that. So this is a time consuming. And as the Cynodent concept, I am agree with that health should go to everyone. Oral health, every people should have equal access in the oral health. Because city people, they have the more facilities. No? So if they want to go, sometimes they will, even money is the second issue, economic barrier. But some people, even they have money to invest on their teeth, because you can motivate the people. Because if you have the car, only you can drive on that. But you can't use every time, no? So, but teeth is really important to smile and talk. No? So every day start with smile, no? Smile is very important. So people, okay doctor, you give me a solution, I don't care about the money. They will try to speak. So we have to identify the problem. If you have the traditional solution, you will go straight away to extract the teeth and give the denture, and patient will come and after 5 years and blame you, doctor, you should have told me about implant or some permanent thing. So whatever the things you know, whatever the things available, you have to tell to the patient. So at the end of the point, they can make a decision according to their wish or according to their economic concept, they can go for a decision. But our intention is we have to tell what are the facilities available in that. And so we here only we provide the service to demand people. They come and demand. So we don't have in that road, when you go to some areas, even I have seen any rich man, he has the very big vehicle, but he doesn't have the front teeth. So it's mean he knows he doesn't have, he's scared to do that, because he don't have the knowledge about how to replace the tooth, no? So some people will tell, even implant, they will tell about the, okay, you are putting something inside the mouth. So will it harm to my mouth? So you have to think about that, and you have to tell the evidence-based studies, no? Even the many countries are practicing implantology for many years. So 30 years and after Brenmark, so they have started and practicing. If something is wrong, they should not practice. So in such a way, you have to explain to the people. They will ask many questions, no? Even Sri Lanka common question is, doctor, if you extract the upper teeth, will I lose the vision? What is the common problem? So that what is the reason they are asking? Anyone knows? Coincidence, you know coincidence. So when somebody is 60, 50-year-old, their vision usually disappear, no? Come to very in a part. So vision, that time that person might have gone to dentist and extract the tooth, and later after 6 months vision might have lost. So they may be correlate, and that one because of the extraction of tooth. So that is the knowledge, and we are here to provide the knowledge to them and apply our skill. That is an important thing. So as I mentioned, the personal intention is provide, because my clinic is the rural area. Rural mean, so compared to Mumbai and Karat, different, no? So like that, we are in out of city. But I have all the facilities to provide. So after they come to visit my clinic, oh doctor, we didn't know, so everything is here. And like that. So they are embarrassing and they will go for a treatment. So sometimes they will come for a filling and later, okay doctor, can I do the replacement of tooth? Because you have to build the patient-doctor relationship. When you talk, you can identify some problem. When you talk little bit deeply, so patient, I told to my staff, don't call their patient. Tell their name. So Mr. For an example, Kannan, he came for a filling. So don't say patient, because patient is a definition medically and physically ill. If someone want to bleach their tooth, they are not patient, no. They are. So as I mentioned, dentist is the only profession make others to smile. No? So people ask because patient come and ask, don't ask the implant, doctor, we need the implant, this brand, Biogorsen, I need the BNB, I need the Braden. They don't ask the implant. They need the solution for their missing tooth. If one come for your clinic for missing tooth, what is the first step you will ask? Anyone? If front tooth is missing, so what is the first question asked? What is the first usual question? How did you lose your tooth? That's an important question, no? We have to think about that, no? If due to trauma or periodontal disease, so we have to go. If it is sometimes they will give it lose itself. So it means you have to care about the perio problem, no? So nowadays global time is busy. Everyone is busy. Some people will come from abroad and they want the immediate solution. Even if you are busy with some patient, so if you tell, okay, can you come tomorrow because I am busy, they won't agree because they want immediate solution. Some people are like that. You have to manage the people in all category. Some persons are very calm. Some person will like in a fighting mood, they will come to fighting mood clinic. No, if you can't, can you say do now? Like that they will ask. So you have to manage, and that's why I am telling you have to change with modern technology, because it will ease your time. And cost-wise, if you invest on that, you agree or not. So recently I bought a milling machine. So usually I paid the money for the laboratory, what I pay for the bank, less than bank. It means you can invest. So it will give good investment. So digital impression, and so I saw one case, he wanted immediate solution. If you go for so do you have intraoral scanner here? Oh, yeah, that's added. Okay. So digital impression, you have to take an impression. So your final year, which year student? First year. Final year. So what are the error when you get the impression? Do you know about the material? You have to think about the properties of material, no? So how? And properties of doctor, how he taken a good impression, no? So we have to think a lot of things when you take. But if you do the intraoral scanner with digital impression, you have to think only about the machine and software. Software they will upgrade. Every day you can automatically upgrade. So I am not challenging technology won't give the error, but the error are minimized. So even CBCT, you may know about the accuracy of CBCT, no, 0.1 is standard deviation is there. So everything is error. When we go, even you travel in a bus, you travel in an aeroplane, which is safe, which is fast, but not safe, no. Bus, it has a brake. But aeroplane, if something happened in the middle of the sky, what will happen? But if you think, you won't travel. So don't think the negative. So when in the morning wake up and do whatever I do, it will be fine. So sometime when you go to the next section, if you're shaking your hand, difficult, no? If you follow all the protocol, so take a good history, examination and investigation and treatment planning and go for a good treatment. So, and that time, even if you do any attempt fail, or if something wrong, you have safe, no? You have follow all the protocol. If you don't ask the history, and if you give the injection, if the patient collapse, you also upset, no? Because you didn't ask the question, no? But if you ask the question, okay, patient said, I have a diabetic, I have some medical problem, and that point, you give the injection, patient will, okay, you will tell, okay, but because of that reason, it might happen, no? It is management easy. So, always follow the protocols, whatever we learn. So, sometimes people will come and ask, doctor, can you give only small, so you put the tooth, so I can manage. I will tell, no, this is not a karate. So, whatever you ask, I can't do. Even I am ready to give as a free treatment, but I want to follow the step, no? Sometimes they will tell, okay, you did a small filling. So, sometimes they will ask, it is shaking, no? Doctor, you extract. So, shaking tooth is more difficult than the normal tooth, no? So, they won't get the good anesthesia, local anesthesia on that, because usually bone fibers doesn't have the, bone doesn't have the pain fibers, no? We are not anesthetic, we are mainly the nerve and soft tissue, no? This is after milling machine. I am saying that this patient was waiting for implant, and after that she want to go to abroad. She want the immediate solution, and see the digital impression and the milling machine solution and color matching is, you can appreciate. I think the patient was happy, even the husband and everyone is talking over the phone and they are happy. It's mean, so it is not a miracle, it is not only me, so everyone can do. So we have to apply whatever in the medical sector. Dentistry is the most advancing technological field, no? Nowadays, if you read some papers or something, so dentistry is most advancing. Yeah, and I mentioned about that. The patient asked implant or this missing tooth, they will come and ask, doctor, please, I want to replace. And they won't care about, some people tell, okay, I went to one of my the friend clinic, he is telling this biocorrection, this is add-in, this is and this one. So price-wise, we can choose the implant, economical wise. But they don't have what is the collar, what is the thread type, what is the osseointegration and those things. Because over talking may create some problem. And the end of the talking for half an hour, patient will, okay, doctor, I will go and think and come back. They never come. Because when you tell a lot of things, it may be complicated. So you can tell, it is even, you can, titanium is used, even fracture bone, no, for a long period, even screws and everything. So you can explain, normal orthopedic surgeon use the titanium, even sometime my uncle had a fracture and he used the internal plate, it's still there 30 years, 40 years, like simple example we can tell. So we have to talk in a simple word with the patient. That is an important thing. Yeah. Other thing is, as I mentioned, the digital is not always replacement of analog or our conventional practice. It will ease our time and cost. And for the implant dentistry, for an implant, we take an impression and study model, template, radiographs, and surgery part, incision, drilling, and everything in the manual we do. But this one is, do you think is manual or guided? Any implant expert here? This done in a freehand surgery or? This is a paralleling pin. The next to that slide is paralleling pin, because this I did with the freehand. But it's more or less okay. But digital, we can do. We don't need to use the paralleling pin and take an X-ray, because mental foramen is there, no? Any third year, fourth year student? What is the black area below the implant? Yeah, mental foramen. Because in 4-5 region, lower, we have to, in implant dentistry, the always vital suction, upper is limitation is sinus, lower is limitation about the ID canal and mental foramen. So we have to think. Otherwise, the implant, many even we graduated from 22 years back. One of my friend classmate, he come, okay, He comes to every courses. From me, from the 20 years, he does all the implant, AAD, everything, but he didn't start to practice because he's scared. Because they say, this is a vital sector, mental foramen nerve is there, and it will damage and go something, and they will think about the only negative part. You are walking, no? Every day you are walking. There's a chance to fail, no? So if someone tell if you walk, you will fail. Do you sit on the chair without walking? No. That's why medicine is always challenging. Dentistry is more challenge. Difficult to satisfy the patient. They will tell so many problems, even before treatment, after treatment as well. I mentioned about the freehand surgery. We have to follow the many steps. Guided surgery is not a solution for the freehand, but it will ease all the steps because you will have a more accuracy. Take a CBCT will give a more assessment, and you guide. So CBCT, so you have a CBCT, not DICOM. So their CBCT file is DICOM. Intraoral scanner is STL. So you have to merge both STL and DICOM. Their software, Exoplan, Blue Sky. All the steps. If one step is in error, you will end up with the waste of time and everything. So guided surgery, you can't straight away start the implantology in guided surgery because guided surgery is not an alternative for freehand surgery. When you do many surgeries, guided will help you serve your time. And if something happen in the middle of that, so guide will break. That time if you don't know how to open the flap and do the surgery, that time you will struggle on that. CBCT should be a proper, accurate intraoral scanner. Yeah, and do you all know about the 3D printing and the milling? No, difference? What is the main difference? Yeah, milling is like when you, from the stone, you are making statue, no? That is like a milling. Which one is strong, milling or 3D printing? Yeah, milling is more strong because 3D printing addition, that is a subtraction. You are reducing the things and making. So in that case, you will, from the block you are making now. This is you are adding. So there's a chance to break. So there may be error in the printing technique as well. So why we use this advanced technology? Main thing is consume our time. We reduce our time. If you want to take a conventional X-ray, you have to take it and you need the developer. You have to develop and put on the sunlight for a few hours and come back. No. Digital X-ray, it comes in the chairside solution. If someone come to your clinic and okay, you have toothache, take an X-ray and show them, okay, this is the problem. They will appreciate you because immediately in a 2 minutes time, the X-ray will come on the screen. So they will really appreciate, even this facility is available. Sometimes people don't know because we are the medical professional. We are here to help our patient because they don't know everything about their condition or their diseases. They come to see us to get the treatment. So we have to explain to them what are the facilities available, what is So when you take every treatment planning, what you will discuss with the patient? Usually what do you do? Every treatment plan you will tell, if you don't do, what will happen? If you do, what are the consequences, no? Everything is, consequences is there, everything, no? Nothing is 100% perfect, no? Sometimes people will come and ask for the extraction of third molar. You will tell, okay, if you extract, this will happen. If you don't extract, this will happen. The end of your discussion, sometimes patient will vanish. That is their problem, but not our problem. But if you have the X-ray or digital technology, you can show them, no? But if you have the CBCT, you can more describe them, no? Where is the canal? In the IOPA, you have to see only the canal where it is. We don't know where it is passing or where it's going lower. So CBCT will give more accurate. So digital things will help your decision making and treatment planning. Oh, this is a guided surgery. I did in immediate after surgery, we put the multi-unit apartment. So it may be, sometime it may be boring or new things for the students, but just to learn everything. But one day you will apply on that. So it is easy. So this one immediately after the surgery, patient is very time consuming. If the open surgery, doctor, do you do the surgery implant? For an arch, how long it will take for one arch? 1 hour, 1.5 hour average, suturing, preparation, suture and everything, 1.5 hours is minimum. So guided surgery is half of the time, 45 minutes, 5 minutes is roughly enough. So you can have a more patient. You don't need to rush, no? If the one patient is coming, you are doing surgery, someone is coming and knock the door, doctor, I want agent. So you can't manage, no? So digital things that serving your time. And less surgical invasive. When you see that photograph, you won't get any suture. So you don't need to open, no. Your CBCT is there, your STL file is there, software will do everything. You have to put the guide on that and you have to drill and finish everything. This is a surgical guide, see. This is a guide. But you have to, even if you don't have the CBCT, you 4-5 friends, you can get together and do. When you graduated, if you are practicing some area, even I know one of my friend in Colombo, he said, in Sri Lanka, material has a little bit limitation. Relax, you know Relax, cement. The Relax U200 is a cement to bond the crown, the prosthetic. So they bought, but share with their friends because they don't get everyday crown, no. That's why CBCT, some common thing, the scanner, intraoral, you can get together and buy and apply. But how much my practice changed, because I started with one chair and I went to outside the country and learned. So come back and I really noticed that in Australia, they are telling about the office. They are not calling as a dental clinic, dental office, because everything is digital and they are making as a very clean and everything. And so this important thing is always guided surgery or whatever the advanced things is not superior. But don't blame to other doctors who are doing their traditional practice, because sometimes it can make the good impression and cast and good ground. But it doesn't mean the 100% is we are sure, because the technology is giving a lot of things, so we have to apply, no? That have heard about the artificial intelligence. India is very good in IT. I know Bangalore is the IT cup is there, no? I met many friends in Australia. They are very much, there are a lot of people are in the IT field. Wife are dentists. They are doing exam, they marry and come back. And when they prepare the exam, sometimes I help them. That's why I know many people in India and Australia. You see, this is with all the guided. So, because any periodontist is here, because you have to raise the flap and do the surgery. No, here is flapless surgery. So you are not damaging any harmony or any soft tissue change. No, so in that case, soft tissue is preservation is there. you can appreciate the aesthetic, no, anterior. So you won't get any different. So this is a guided surgery kit. You need to have some implant surgery. Both are not same, like an X-ray. Do you have RBG or post-plate scanner here? What do you have for the IOPA? RBG, yeah. So because it's developed from the film, D film, E film. Do you know anything about what is the difference between D film and E film? E film is the fast, less exposure. Like that, the advancing dentistry is less radiation. So this is things I got the award for Asian Best Dental Implant Center. This is for motivation for you. So I started the practice as simple. So I become now is a bigger practice in Sri Lanka. So even bigger, many people come from even city Colombo to my place and see, because of I am changing the way of life to the advance of technique. So my take message is change your life with changing the advanced things. So always change with the whatever the new thing. When you go to the shopping, you check what are the dress available, new thing. Huh? So when I come here, my daughter tell, okay, buy this one, see internet and tell, and I want to carry. Like that. But when I come to or go to some abroad, I will buy all the dental stuff, whatever the new thing is available. So you have to change the new things, and new things are not superior, but even your grandma is give a better advice rather than your mother. But new things we have to change to improve our practice. Thank you very much for your listening. And if you have any question, you can ask me. This is my email address and contact number. If you want any question or any help, so we are here to help. Thank you very much.
I'm going to tell you something new, very interesting and very hot topic. Minimal invasive procedure for mandible impacted third molar tooth, a study to prevent incision and soft tissue handling. See, mandibular impacted third molar is a very, very common in our day-to-day practice. Each and every day, at least 1 to 2 patients are coming in our clinic for the impacted, who want to remove their impacted mandibular third molar. And the protocol, since 70 years, 80 years, worldwide in UK, US, Germany, Australia, Kolkata, Delhi, Hyderabad, Karad. The protocol is incision, reflection of a flap, then cutting the bone, and removal of a tooth. See, 30-40 life-turning moment for you in your day-to-day practice of impacted third molar. Because no a single theory I am going to tell you. I am telling you the result of the patient in front of you. The patient is in front of you and you have to remove the tooth without incision. See, the management of impacted mandibular third molar is a very, very common procedure. The protocol is incision, reflection of flap, osteotomy, suturing is the normal protocol which causes more trauma to the tissue. So I minimize the procedure of impacted third molar, for which I got copyright by Government of India in 2019. Felicitated by Dr. Christopher Hammerle, Zurich, Switzerland, for the invention. This is my clinic, round the clock we are working. What is the initial protocol and what is the MIP-MIT? See, initial protocol I no need to tell in detail. I'll directly go to the MIP-MIT. See, first of all, I'll show you one case and then I'll tell you why to learn this procedure. First of all, I'll show you. Suppose this is a tooth. clinically visible 3 to 4% in the oral cavity. Again, I am telling you, carefully listen this, and then after this case, आप लोग straight बैठना start करोगे. The clinically tooth is visible only 3 to 4% in the oral cavity. This is the X-ray. Now I am asking you, is it possible without incision? Is it possible? Any intern here? See, the tooth is out. Like a simple extraction. Patient satisfaction and healing after 7 days. And the procedure needs only 3 to 4 minutes. Why? How come? Is it possible? And I'll tell you, this is my challenge to everybody, because I promoted this technique, USA, then Uzbekistan, then Egypt, and after 4 to 5 years, every patient will come and ask you, आपके यहाँ पे बिना टाके की अक्कलदार निकलती है नहीं? Then आपको मेरी याद आएगी. Because मैंने उतना उसको spread किया है. I'll prove you, I'll show you, and I'll document you case by case. This is a very important topic. Now, again, I'm going back for this. Voice, please. बेटा पीछे से एक आधा फोटो लेना. See, I'll tell you some simple things of extraction. If the position of a patient, if the position of a doctor, selection of instrument, amount of force and direction of the force, ये 5 चीजें अगर आई ना, तो extraction is very important and very easy. Extraction is an art. आपकी उंगलियों को उसकी आदत होनी चाहिए. Because you are a surgeon, dental surgeon. Surgeon must have 3 qualities: lion's heart, lady fingers, and eagle's eyes. And eagle's eyes should be on the tip of your fingers. आपकी उंगलियों को सब पता होता है. See, the access area is very small in case of third molar. No visibility, saliva, blood, tongue, flap, instrument, suction. कुछ दिखता नहीं है. तो आंखें कहाँ होनी चाहिए? उंगलियों को होनी चाहिए. The eyes should be on the top of your finger, and that should be eagle's eyes. And हमें कुछ नहीं दिखता है भाई, और हम असिस्टेंट को डांटते हैं, ठीक से पकड़ो, दिखता नहीं क्या? बेचारे को तो इतनी जगह दी जाती है. समझ गए? तो मैं बोलता हूँ फ्लैप लेना ही क्यों है? अभी एब्डोमिनल सर्जरी कोई ओपन करके करता है? इफ यू वांट टू डू एनी एब्डोमिनल सर्जरी ऑफ योर मदर, फादर, वॉटर में भी कोई तैयार है ओपन करने के लिए? एवरीवन विल आस्क कितने टाके पड़ेंगे? स्टिचलेस है क्या? Yes or no? You agreed with me or not? So why not in dentistry? Why we are incising? Everybody is incising lifetime. बस इसमें क्या होता है कभी कभी इतने जल्दी हो गया. मैं I visited Baner, Pune to one new doctor, lady doctor. I extracted that. It was the horizontal tooth. मेरे स्टाइल से मैं गया. I extract, मैंने एले दिया. I was asking for the gauze. मैम चले गए थोड़ा कबर्ड की तरफ. 2 मिनट में आए. Tooth was in the tray. उसको हैप्पी होना चाहिए था. तो पीछे आके मुझे बोले सर क्या? मैं बोला क्या? इट्स गुड. हो गया. नहीं सर मैंने 6000 बोला है. दिस इज ऑल्सो प्रॉब्लम. लिसन टू मी. तो डोंट लाई विद द पेशेंट. यू शुड बी इथिकल. उसी दिन से मैंने थोड़ा सोचा कि इसके लिए क्या करना पड़ेगा. तो मैंने बोलना स्टार्ट किया. ये सर्जरी है एब्डोमिनल की तो 40,000. स्कोपी से करने हैं तो 80,000. स्टिच डाल के अक्कलदार निकालनी है तो 4 to 5,000. If stitchless, within 5 minutes, 8 to 10,000. Patients are ready. आपका टाइम बचता है. पेशेंट. Tell me, what is the culprit behind the post-operative complications after third molar removal surgically. No, what is the culprit behind the जो swelling आता है trismus उसका किसकी वजह से आता है? What is the culprit? Yes, madam, please. No, excessive force is okay, not. Anybody? See, the main culprit is soft tissue handling. If the soft tissue handling is less, the post-operative complications are less. Believe me, this lecture was very zoom in Uzbekistan, or Uzbekistan people are following now stitchless surgery. Call your friends who are outside, roaming here and there, message them, because this is very important lecture. See, even for the extraction, I will tell you, simple, the things are not written in the books. I'm telling my experience. There is no any theoretical thing. There are 3 types of forces we are using during extraction. 1, to hold the forceps. 2nd, to hold the tooth with that forceps. And 3rd, to pull the tooth. Am I right or wrong? The amount of force to hold the forceps should be maximum. जोर से forceps पकड़ो. The amount of force to hold the tooth with that forceps should be maximum. And the amount of force to pull the tooth should be minimum. हमारा वाइस वर्सा होता है. डर डर के फोर्सेप पकड़ते हैं, डर डर के टूथ को पकड़ते हैं और जोर जोर से खींचते हैं. एक्सट्रैक्शन इज हियर, यू हैव टू लर्न. जैसे कुश्ती में दांव होते हैं, रेसलिंग में दांव होते हैं, वैसे एक्सट्रैक्शन में दांव होते हैं. हर बार कुश्ती में ताकत की जरूरत नहीं होती है, दांव होते हैं. यस और नो? तो एक्सट्रैक्शन इज आर्ट. मेरी तबीयत ऐसी है, मैं कैसे एक्सट्रैक्शन करूं? नो नीड, जरूरत नहीं है. यू शुड नो द things behind the extraction. I'll tell you one by one. Now what I am doing in third molar, what is MIP, MIT? I'll tell you, 1 minute. Give me 2 bottles. खाने का टाइम हुआ है, but within 15 minutes I'll finish. Suppose this is a second molar and this is a third molar, which is impinging like this or this below the C junction. मैं तो आपको very easy, I'm telling you, what is the motto? आपको क्या करना है? What is your aim during third molar removal? कैसे आएगा बाहर? To remove the resistances first. Simple language. If the resistances उसके remove हो गए तो tooth will be out. Yes or no? Simple language. The first resistance for that tooth to come out is what? Adjacent tooth. Second molar के वहाँ घुसा हुआ रहता है. Am I right or not? Second, tissue and bone. Am I right or wrong? Great. Now, my first step is take a burr, straight burr, and break the contact point by trimming the third molar in contact with the second molar without hampering second molar. Got it? If you are not confident, use matrix bands in your early days. Break the contact point. The first resistance is gone. Now, second, reflect with the Moon's probe properly. ठीक है सर, पहले see, 2 things are very important during extraction. 1, 2 P's are important. Lifetime याद रखो ये चीज, मैं आपको जो बताने जा रहा हूँ. 2 P's are important. 1 is purchase point and second is a path of removal. It's not written in a book. It's my study of 22 years. I extracted a truck भर के tooth. After that I realized, जैसे मजदूरों को हाथ को कुछ होता है ना, ऐसे मिट्टी उठा के ऐसे हो चुका है extraction करके. After 22 years of practice, after 15 years of practice, I realized there is something different. So believe me, the first resistance is gone. Now, 2 P's are important. 1 is purchase point and path of removal. Every tooth is having its own path of removal. Extraction should be here first and then you have to apply. There is one sentence, begin with end in the mind. Begin with end in the mind. So, your extraction should be here first and then you have to apply on the tooth. Are you getting something? So, purchase point is important. जिसको purchase point proper मिलता है, अच्छा elevation होता है. And path of removal, वो पता होना चाहिए। सारे टूथ का पाथ ऑफ रिमूवल कहाँ होता है बेटा, बताओ कौन सी दिशा में आप उनको पुल करते हो लास्ट? हाँ, बक्कल, यस और नो? क्या लिंग्यूल निकालते हो? तो एवरी टूथ इज हैविंग इट्स पाथ ऑफ रिमूवल वेयर, बोलो पीछे से थोड़ा, वेयर? बक्कल। तो ये भाई साहब ने क्या किया है, इनकी क्या गलती? इनका भी पाथ ऑफ रिमूवल का है, बक्कल ही है, यस और नो? बट इनको कैसे खींचेंगे? अगर इनको बक्कल ही खींचेंगे तो ये आएंगे, yes or no, agreed or not? Because tooth develops, development of a tooth develops like a cornucopia. Google it, what is, see, physics is very important. You should learn the physics first of all before extraction, because physics is the physiology of a nature. What I am telling, physics is the physiology of nature. If you know physics good, you will do the extraction nicely. Wheel and axle principle. The physics, extraction is the physics. So, what I am telling, the path of removal you have to learn. तो बक्कल ही करते हैं, करना चाहिए, नहीं कर सकते इसको। अगर इसको बक्कल ही करते हैं तो tooth will come out easily, yes or no? Now, my first resistance is gone. Now my tissue reflection is there. But sir, ठीक है, there is no purchase point. And even there is a big resistance of this bone. Am I right or wrong? हमने कॉन्टैक्ट पॉइंट ब्रेक किया, एक रेजिस्टेंस गया और तीन रेजिस्टेंस है ना, उसका क्या? Am I right? Now, if there is a purchase point, well and good. If not, you have to create with the help of micromotor burr with one ditch with copious irrigation by undermining the tissue. Never ever use air rotor in tissue. It may cause a surgical emphysema. Got it? So, create a purchase point. Sir, purchase point भी create किया, but ये resistance का क्या है? ये जो है, so always buccodistally, you have to take a micromotor burr and just undermine the tissue and just remove the collar. Believe me, reflection of a flap is very dangerous because it gives the reaction of a body in the form of swelling. I am just undermining the tissue. ये सब होने के बाद always everywhere in the world third molar we are putting the elevator here and we are pulling the distally. Am I right or wrong? But there is a big resistance from the distal side, external oblique region, anterior border of ramus, very thick bone. So what I do, because of contact point breakage and good purchase point, my state elevator is going more in, so I never ever elevate the tooth like distally, I always elevate the tooth buccodistally. Got it? Buccodistally. If I am more deep, I never do like this, I always do like this. What happens in this? Crown comes buccally, tooth rotates around its own axis, automatically roots goes lingually, cortical plate expands, and this becomes a cornucopia. What is cornucopia? Cornucopia is a physics nature's law. It's a spiral binding. जो मिट्टी उड़ती है जब हवा में और पत्ते उड़ते हैं, तो it is always like this. It's a cornucopia because every quarter turn it becomes wider. Are you getting? Every quarter turn it becomes wider and it is coming out. It's a physics. So if you rotate the tooth distobuccally, this is a distal side. I never do like this, always do like this. So tooth will rotate like this and it becomes a cornucopia. Believe me, I'll give you my number. Do it, and whenever it happens, call me definitely. Then you will realize that definitely something is happening. Now I'll show you some cases. Again, जो latecomers हैं उनके लिए, if this is a tooth, like this, out within 3 minutes, like a simple extraction, no swelling, no trismus, nothing, and healing after 7 days. It's a revolution. When I got the certificate from the government of India, there was the sentence, it is for the well-being of humankind, manushya jati ke kalyan ke liye. This is the cornucopia. Nature is great. Galaxy is the cornucopia. Sunflower is a cornucopia. Everything is a cornucopia. In geometry, a golden spiral is a logarithmic spiral whose growth factor is phi, a golden ratio. That is, a golden spiral gets wider by a factor phi for every quarter turn it makes. See, this is a cornucopia. Are you getting something or not? When you apply this scientifically, your patient will laugh like anything. Ho gaya within 2 minutes. You will charge more. You can charge 8,000, 10,000 for 2 minutes only. Fibonacci in mathematics is also cornucopia. Now this sentence. Every structure including maxilla, mandible, teeth, etc. has a growth site and growth centers. From the growth centers, the structure develops in a path which follows the logarithmic spiral. Logarithmic spiral follows the Goddard proportion like it emerging from as a cornucopia. Scientist Robert Murray Ricketts in 16th century had studied the growth rotation in a details and gave the theory to determine the center of a rotation of a mandible from which we can access the growth of a mandible. That is a growth prediction. Similar theory if applied on the third molar growth centers, then the growth of a teeth is occurring in a logarithmic spiral path. Growth bhi aisi hoti hai tooth ki. And also follows the Goddard proportion so that in MIT, patient position, doctor's position, instrument, purchase point, site, and force directed in a distributical direction, expansion of a cortical plate, all will provide same rotating or spiral direction to the tooth in which tooth develops naturally. So MIT actually following the tooth eruption pathway and hence it becoming the absolutely less traumatic. This is a mechanico-physiological theory of MIT. It's a mechanics, physics and physiology. See the tooth? सारी दुनिया इसको इंसाइज करती है. किधर भी जाओ, कोलकाता में जाओ, यूके में जाओ, जर्मनी में जाओ, incision. I never incise the tissue. Because if I am cutting the tissue, very important sentence, if I am cutting the tissue, it belongs to the patient. If I am cutting the bone, it belongs to the patient. Good surgeon duty is that he has to preserve the things that belong to the patient. If I am cutting the tooth, that has to be extracted. And that is a waste product for the patient. वही डॉक्टर अच्छे डॉक्टर होते हैं जो मिनिमम ट्रीटमेंट करके पेशेंट को ठीक करते हैं. This is the contact. See what is the contact point of purchase. Tooth is out, 3-rooted. It was not visible in the oral cavity within 2 minutes. See the invasion like a simple extraction. Another case. If the tooth is like this, out like a simple extraction. If the distally the second molar is carious, no need to take care of this then. Endodontically जाएगा, उसको contact point break करते कोई hazard हुआ तो no issue at all. See, tooth is out, like a simple extraction. This is very important. I'll take 10 minutes more. Very important topic for you all. See, 4-8 not visible in the oral cavity. I challenge everybody. This is distriangular. मेरा 2019 में कॉपीराइट मिला. मैं सारे टूथ MIT से करता था, बट 2020 में अचानक एक साल के बाद मुझे समझा कि डिस्ट्रायंगुलर, दिस इज मींट फॉर डिस्ट्रायंगुलर ओनली. सी इफ आई एम कटिंग द कॉन्टैक्ट पॉइंट, डिस्ट्रायंगुलर में एलिवेटर कहाँ अप्लाई करते? बताओ बेटा, बताओ. सब जगह पे मेजिली करते हैं. डिस्ट्रायंगुलर में कहाँ करते हैं? Yes, anybody? Always we apply distriangular को distally to make the tooth straight and take out. Mesily apply करने तो हमें क्या रामस में ढकेलना है tooth को? समझ गए? तो always we have to apply the tooth elevator distally and make it straight. Now, if I am cutting the contact point and applying the elevator distally, the surface area in contact, the resistance is less. And this last point will act as a fulcrum and tooth will rotate around its own axis easily. अभी distally मैंने जब elevate इसको लगाया तो वो easy है या कट करने contact point करने से पहले easy था? Where? This is easy, no? Because there is no surface area to rotate and tooth will rotate like this. See, and the tooth is out. 3-rooted distriangular is out. Another, and see the invasion of this. like a simple extraction. Now, see another case. Always such patients are coming in your clinic. आप पेशेंट को बोलते हैं टाके डालने पड़ेंगे, 5,000 खर्चा लगेगा, फिर खेलते बैठते हम 1.5 घंटा, असिस्टेंट को 4 बार डांटते हैं, उसके बाद पेशेंट को 2 दिन के लिए स्वेलिंग आती है. Why? See, tooth is out, like a simple extraction. क्यों आएगा भाई स्वेलिंग इसको? है possible? Like your invasion should be like a simple extraction. I'll tell you. मेरा जो एलिवेटर है उसका नाम है भवानी तलवार. I'll show you the भवानी तलवार. Wait. और एक भाला है. अभी आप बोलोगे सर बहुत इजी केस दिखाए, ऐसे थोड़े मेजी एंगुलर वगैरह, थोड़ा कुछ दिखाओ अच्छे से. ठीक है. अभी this is a huge root. Tooth is out like a simple extraction. If the tooth, now see case, this is the case of one gynecologist, उनकी wife dentist है, she called me, the tooth is like this, clinically, like this, x-ray, inside तो सब करेंगे इसको. I'll show you the procedure, how much time it will take. See, start to end.
It's deep below the CE junction, that's why it's
1.5 घंटा नहीं लगता है. What is distobuccal force? C. It's a cornucopia.
चला सर वाटतं फक्त.
And out. This is the time required for the surgeon. Start to end. And see the invasion, like a simple extraction.
See the conservative approach. No incision, nothing. Everything is perfect. Done with this.
Patient is surprised.
With this.
हो गया है. Yes. The tooth is out, like a simple extraction. Patient is very happy. And patient कुछ बोला है, तब तो मैं पानी ही पीता हूँ.
नमस्ते, मी डॉक्टर शिवराणी खानावरे, डेंटिस्ट व माझे मिस्टर डॉक्टर अमोल खानावरे, गायनेकोलॉजिस्ट आहेत. आम्ही बिगवनला खानावरे हॉस्पिटल मॅटर्निटी व डेंटल येथे प्रॅक्टिस करतो. त्यांचा हॉरिझॉन्टल इम्पॅक्टेड टूथ होता. आम्हाला डॉक्टर निकम विश्वराज सरांचे नाव व त्यांचे जगप्रसिद्ध नॉन सर्जिकल टूथ एक्स्ट्रॅक्शन प्रॅक्टिसबद्दल समजल्यानंतर त्यांच्याकडूनच टूथ एक्स्ट्रॅक्शन करण्याचे ठरवले. त्याबद्दल त्यांच्याशी कॉन्टॅक्ट करून त्यांना व्हिजिटसाठी रिक्वेस्ट केली व त्यांनी लगेच होकार दिला व आमच्या हॉस्पिटलला आले. त्यांच्याबद्दल माझ्या मिस्टरांचा एक्सपिरियन्स ते शेअर करतात.
नमस्कार. माझं 1 वर्षापासून ज्यावेळेस एक्सरे काढला त्यावेळेसपासून आम्हाला कळलं की माझा हॉरिझॉन्टल इम्पॅक्टेड टूथ होता. पण ते काढायची भीती वाटत होती, कारण ते सूज आणि माझ्या गायनेकोलॉजिकल प्रॅक्टिसची रोजचं प्रॉब्लेम येणार होता म्हणून. पण ज्यावेळेस निकम सरांचं कळलं आम्हाला की निकम सर नॉन इन्व्हेजिव्ह पद्धतीने, नॉन इन्व्हेजिव्ह टेक्निकने व न इन्सिजन घेता, बोन लॉस न होता ते टूथ काढतात म्हटल्यावरती एक धीर आला. ज्यावेळेस सर आले त्यावेळेस आता सध्या सगळ्या सर्जिकल ब्रँचमध्ये नॉन इन्व्हेजिव्ह टेक्निक पुढे येते. मग त्याचप्रमाणे डेंटल सर्जरीमध्ये पण नॉन इन्व्हेजिव्ह पद्धत त्यांनी आणून ते जगप्रसिद्ध म्हणजे वर्ल्ड वाईड ते फेमस होत आहेत. मग त्यानुसार त्यांनी आल्यानंतर मला काउन्सिलिंग करून व्यवस्थित लोकल ॲनेस्थेशिया दिल्यानंतर काही समजायच्या 3 ते 4 मिनिटांमध्ये न बोन लॉस होता, न सुचर घेता त्यांनी माझा दात काढला. त्याबद्दल मला नंतर एक अर्धा-पाऊण तास झाल्यानंतर मी लगेचच माझे रुटीन ओपीडी व पेशंटची काउन्सिलिंग करायला चालू झालं. आज 2nd डे आहे टूथ एक्स्ट्रॅक्शन नंतरचा, तरी पण अजिबात स्वेलिंग नाही, काही नाही. त्याबद्दल आम्ही पूर्ण खानावरे कुटुंबातर्फे निकम सरांचे हार्दिक आभार मानतो व त्यांच्या जे पुढचं रिसर्च आहे हे असंच वर्ल्ड वाईड फेमस व्हावं त्याबद्दल त्यांना.
If the tooth is like this, out like a simple extraction. If the tooth is like this, now see, J hook, slightly distangular. Tooth is out. See the invasion, Everyone want to learn this? Yes or no? Now see. Tooth is like this. अभी देखो. Start to end देखो. Tooth is not visible in the oral cavity.
Reflecting the gums.
है? This is our Bhavani Talwar. I'll show you the photograph. Tooth is not visible. I am undermining the tissue, not incising the tissue. It's like a gynecologist, normal delivery, not a
Just
cesarean
undermining
section.
without
See my
incision.
struggle like a gynecologist.
Yes.
Purchase
See the
point.
tooth?
What I am telling, purchase point. Sir, with your permission,
I am
I'll
creating
take
the
more
purchase
5-7
point.
minutes. Okay, 5 minutes. Distal buccal out. My handle is anterior.
tooth is
means
coming
it goes
out.
this way. See my struggle.
Yes. Very good. Just dear cooperate me for 5 minutes, please.
Still I am not incising the tissue.
This is without incision, with minimal invasion.
Tooth is out.
See,
Like a
the
simple
tooth is
extraction.
coming out. Tooth is out. See.
Like a simple extraction. If the tooth is not visible in the oral cavity and patient is like a chubby chicks like this, even the tooth is erupted and patient is opening the mouth, the fat is on the occlusal table, we have to find out the third molar, yes or no? If erupted tooth is also there. And if the tooth is like this, not visible, if the patient is like this and the X-ray is like this, now tooth is out, like a simple extraction. How come? If the tooth is like this, with root curved, around 95% tooth is in the bone, tooth is out, like a simple extraction. And patient is happy. This is after extraction, not before extraction. Sometime before extraction is also, I have to see like this. This is another case. If the tooth is like this, now see this case. Possible? And tooth is out. Can you believe this? Don't try this at home. जैसे बोला जाता है वैसे don't try this at your clinic until and unless you know the MIT properly. नहीं तो यहाँ से जोश में जाके करते हैं लोग. You ask me anytime. I'm always available personality. Even I'm doing major surgery, एक sister रहती है phone उठाने के लिए. I never refuse my call. I'm always available. आप try करके देखो. हाँ. If the tooth is like this, out, like a simple extraction, see. ये थोड़ा वहाँ से क्लिक करो, पीछे करो, हाँ इधर इधर, हाँ करो, नहीं हो रहा है, ठीक है, this video is not playing, I think. Patient was very satisfied, इसलिए वो बताना था, ठीक है. This is another case, tooth is out. See the case. Like a simple extraction, patient is very happy, paid me 12,000. See even the bone loss, no, nothing. And these are my instruments. One is Bhavani Talwar and another is a Bhala. The first instrument name is London Hospital Pattern and second is the Coxwell. And all are the old is gold, but ये कोई use नहीं करते. हमें अभी fancy instrument चाहिए. एक बार भी ऐसे कहते उसका सांप बन जाता है. This is my team. Round the clock, I conduct courses worldwide for this. See another case, last case. Root pattern, tooth is out. हाँ, अभी आप बोलोगे सर आपका ठीक है, बट मेरे स्टूडेंट्स ने किया, जो हमारे यहाँ पे 20 डेज के लिए कोर्स के लोग आते हैं, वर्ल्ड वाइड आते हैं। अभी मेरे पास इंदौर की तीन की बैच होती है हर मंथ। तो सी दैट गर्ल फ्रॉम मुंबई, उसने किया है वो। सी ये वीडियो है, प्ले होता है क्या?
मेरा नाम अमृता सालुंके है। मैं स्पेशली डॉक्टर निकम सर के पास पुणे से आई हूँ, ऑल द वे ट्रैवल करके। मैंने दूसरे डॉक्टर के पास जाके कंसल्ट किया था, बट उन्होंने मुझे स्टिचेस लगाने पड़ेंगे एंड 1-1.5 घंटे का ऑपरेशन बोला था। बट मेरे हस्बैंड का टूथ अक्कल दाढ़ इन्होंने ही निकाला था, दैट इज विदाउट एनी स्टिचेस। विद इन 3 to 4 मिनट्स डॉक्टर निकम ने मेरा अक्कल दाढ़ निकाला। उसके ऊपर पूरा स्किन था, वो तो अक्कल दाढ़ दिख भी नहीं रहा था। उन्होंने एकदम पेनलेस सर्जरी किया है आई वुड से, एंड एकदम मतलब मुझे कोई पेन नहीं हुआ है, कुछ भी नहीं हुआ है। और पूरी दुनिया में ये एक में डॉक्टर ऐसे हैं जो अक्कल दाढ़ प्रॉपरली निकाल के देते हैं, दैट टू विदाउट एनी स्टिचेस। यू कैन सी पहले ऐसे थे मेरे दांत और अभी विदाउट एनी पेन उन्होंने निकाल के दिया है। अभी मेरा ये साइड का निकालना है, मैं सेकेंड टाइम फिर से आऊँगी ये साइड में निकालने के लिए। एंड आई वुड रिकमेंड कि आप कोई भी डॉक्टर से जाने से पहले इनके यहाँ प्लीज़ आना, बिकॉज ये आई वुड से फॉर मी इज़ द वर्ल्ड्स बेस्ट डॉक्टर।
मेरे कोर्सेज जो इसका प्ले करो भाई, प्ले करो उसको। हाँ प्ले करो, हाँ इसको।
वो लाईक दिस इथे, आणि मग त्याला सपोर्ट देऊन हे असा 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 करशील। चल पकडलंस होतं। नाव गो।
I don't believe that I've finally removed it without any suture or without any surgery. It is such a satisfaction. It was so conservative. Great.
हेलो, myself डॉक्टर पूनम परदेशी। मैं धुले महाराष्ट्र से यहाँ कोर्स के लिए आई हूँ सर डॉक्टर विश्वराज निकम के पास, उनका MIPM-IT कोर्स के लिए। सो कोर्स बहुत अच्छा चल रहा है, वो 1 month का है। आई विल रिकमेंड डॉक्टर विश्वराज निकम टू एवरीवन who wish for disinfection. Thank you, sir.
These are some batches. हाँ ये प्ले करो।
ओरल सर्जरी हा विषय मी बोललो होतो की खरंच शिकवला जात नाही। ज्या लेवलला आपण कॉलेज सोडलं ना त्यावेळेस जे ओरल सर्जरीचं नॉलेज होतं तेवढंच नॉलेज होतं। आज मलाही 20 वर्ष झाले, मॅम माझ्यापेक्षा सिनियर आहेत, पण हे मॅम पण मान्य करते
आम्हाला मोठं करू नको
नाही बोला। तर ओरल सर्जरीचं नॉलेज तिथपर्यंतच होतं आणि प्रत्येकाच्या आयुष्यात काहीतरी घटना घडल्या ओरल सर्जरीच्या बाबतीत का ज्याच्यानी एक ट्रॉमा बसला आणि तिथून पुढे ओरल सर्जरीची भीती निर्माण झाली असते आणि म्हणून ओरल सर्जरीचं काम माणूस कमी करतो, कारण डेंटिस्ट्री इज इक्वल टू ओरल सर्जरी। आपल्या गावाकडे काय माहिती, लोकांना दाताच दवाखाना म्हटलं का दुसरं लोक म्हणत नाही रूट कॅनल करायचं, दात काढायला चाललो हेच म्हणतात. सो डेंटिस्ट्री इज इक्वल टू ओरल सर्जरी आणि ती खूप डिफिकल्ट होती असं सगळं वाटायचं. ते शिकवणारं कुणीच भेटलं नाही ऑनेस्टली. पहिल्यांदा तुमच्या रूपाने आम्हाला खरोखर सगळ्यांच्या वतीनं मी सांगतो सर, खरंच ओरल सर्जरी म्हणजे देवासारखं.
Another case done by a girl from Indore in my course. See, done by her. किसने किया है? The girl from Bid. See the pattern of bone. Tooth is out. See, इसका तो weight कितना कम है लड़की का, देखो, फिर भी उसने निकाला है. See the pattern of the root. Happy patients. The girl from Bhuvaneshwar, Odisha. See the pattern. Girl from Dubai. Along the way to Fulton from Dubai. See the pattern of a root and done by her in the course. Foreigners भी आते हैं if they know. ये play करो बेटा. Bilateral. The patient came long way from UK. Bilateral क्या है उसका?
Tooth is out and absolutely perfect by MIP MIT technique. Show that minimal invasion.
See the invasion.
It's like a simple extraction. Very nice. And nicely completed by so nice dear. Very nice. And your one work is over. Good. You're happy? Thank you. And now tell your US people, your friends, come to India for the stitchless and penless extraction.
I first launched this in 2019 at Maharashtra State Dental Conference, Nasik. जब मुझे कॉपीराइट मिला, पहली बार लॉन्च किया था. Idea Karad, this was my good memory when I was speaker in 2000, I think 2020, yeah, at Hotel Alankar. Zonal conference Amravati, कुछ चीजें बोले. First national launch in Kerala. Nationally first launch किया था. Play करो भाई. Geo World Trade Center, Mumbai.
Sometimes what happens, 8 is there, 7 is missing, and 6 is present. How to elevate it? So take an anchor like this.
National award at Tiruvananthapuram, Kerala. International launch first time internationally in 2019, Tashkent, Uzbekistan. First launch, first lecture in AOMS, Association of Oral and Maxillofacial Surgeons of India, at Maharashtra conference, state conference, first launch in front of oral surgeons. First launch in the AOMS, Association of Oral and Maxillofacial Surgeons of National Conference of India. And first launch at globally 16 Asia's oral and maxillofacial surgeons of around 42 countries. Only oral surgeons of 42 countries. See the cornucopia. Asian Congress. And ये तिरंगा ऐसा लहराया था वहाँ पे. Live demo in Ahmedabad Dental College. In front of all these people. 3 cases, 3 horizontal in 15 minutes. रायपुर कोर्स. इसको प्ले करो भाई. 2 दिन का कोर्स भी होता है. प्ले करो ना, हो जाएगा. नहीं हो रहा है? ठीक है, चलो जाने दो. कॉस्मेटोलॉजी भी सिखाया जाता है आपको, PRP PRF। पॉलीट्रामा का छोड़ो, अभी वो नहीं दिखाऊंगा मैं। अच्छा दिखाओ थोड़ा पॉलीट्रामा क्या होता है, बच्चों को पता होना चाहिए ओरल सर्जरी में क्या होता है। हो रहा है प्ले? Submental intubation. The girl is doing the plating. This is in the course. Orbital plating. IDA का प्राइज मिला था तिरुवनंतपुरम में, appreciated by Nicole Kisarka, World Dental Federation, FAMDent Pune 2020, FAMDent Heroic Dentistry Award of India for the year 2022. प्ले करो भाई एक लास्ट वीडियो और इसके बाद 2 मिनट में खत्म, लास्ट 2 minutes.
Award. It goes to Dr. Vishwaraj Nikam. He's here somewhere.
Yes. He is telling it was the last lecture and lecture was earth-shaking lecture. He was telling.
Yes. Impacted teeth, which is almost non-invasive, I would say, but it's minimally invasive, and that prevents any sort of discomfort for the patient as well.
Congratulations.
He has a copyright on it.
In fact,
Congratulations.
at the last Famden show, this was the last lecture, but it was an earth-shaking lecture because he shared technique of extracting third molars without using forceps, only to.
And only 15 days back, I got a prize in the Hotel Taj, Mumbai. जो आज तक ताज का फोटो मैं बाहर से निकालता था ऐसे करके ताज पीछे लेके, पर देयर वाज अ बैनर इन होटल ताज। एंड सबसे बड़ी बात, अप्रिशिएटेड बाय डॉक्टर स्टैनले मैलेमेड सर। स्टैनले मैलेमेड पता है ना भाई कौन है? लोकल एनेस्थीसिया बुक जो पढ़ते हो ना, इनके है वो। एंड दिस इज माय कॉपीराइट, एंड नॉट ओनली कॉपीराइट, this is in the textbook of oral surgery from the December, MIP MIT Dr. VH Nikam's technique, Bharat Sarkar. Apart from dentistry, I have my hobbies. I played a role of Chhatrapati Shivaji Maharaj. Take the photograph. Anybody want to contact me, feel free to contact me anytime. Message me, WhatsApp, show me the case, show me the x-ray, discuss with me, do it. And the sentence is, the perpetual preservation of what remains is most important than the meticulous replacement of what is lost. Divan's principle. Thank you very much. Thank you. If anybody is having any doubt, elevator के नाम है London Hospital. मेरे लिए वो भवानी तलवार है. And second is Coxwell, that straight elevator with bhala jaisi blade, that's a Coxwell. Happy all? Thank you very much. Yes sir, please.
So you are not closing the wound. So the purpose is satisfaction of patient, or because if you close the wound, the success may be higher because
Yes. Yeah. I'll tell you, very nice question. See, I'm telling you the flapless surgery. I'm not telling the stitchless. Stitches depends on the surgeon's choice. And if the tooth is more deep, even the invasion is like this, very small. Your question is very right. If the invasion is like this, but after the removal of tooth, the inferior alveolar nerve is going to expose for the environment, you have to give only one stitch if you want. But it depends on me. Sometimes I give, sometimes I never give. Because like a simple extraction, if the nerve is not exposing, I leave it like that. Because in case of third molar, first molar, we never use this research. And one more thing I want to tell you, if there is a inferior nerve, हम हमेशा उसको ऐसे देखते हैं और एकदम डराते पेशेंट को ऐसा चेहरा करके, पेशेंट अपने चेहरे की तरफ देते, ये देखो नर्व के पास है, अरे नर्व के पास रहने तो कुछ नहीं होता है, नर्व को डैमेज करने के लिए भी टैलेंट लगता है. दिस अ टू डायमेंशन, ऐसे भी हो सकता है, ये नर्व है, सपोज दिस इज अ नर्व, इतना दूर भी रह सकता है, इतना दूर भी रह सकता है, एंड सपोज इफ इट इज चिपक के है, तो भी आप टूथ को ऐसे करोगे तो भी नर्व हिलेगी, जगह पे आएगी, इट्स इन हॉलो स्पेस, नर्व को कुछ नहीं होता है, नर्व अपनी जगह, अंटिल एंड अनलेस यू टेक अ बर, गो टू द नर्व एंड उसको लगा दो, तो उसके लिए कुछ नहीं होता है. अब इलिवेशन से नर्व को कुछ नहीं होता है, नर्व को जाके आप इंजुरी करते हो तो इट बिकम्स समथिंग बैड. देन thank you. I am outside because another lectures are there. I have to stop now. If anybody is there, I am available outside. Ask me anything, no problem. I am there sitting outside, okay? Because I don't want to disturb the new speaker. Okay, thank you.
Thank you, sir. Next, we have Dr. Sagar Jaryal, sir, reader in Department of Public Health Dentistry, KLE Dental College, Belgavi, Karnataka. Sir will be speaking about what are the different opportunities after BDS. Over to you, sir.
Good afternoon to one and all. I think today I'll be discussing on opportunities after BDS. So I can see many students are from first year BDS. So for them after BDS might sound little bit this thing out of subject, but definitely these things will help you once you see the things. What are the career options after BDS? You have a career in private government sector, private practice, higher studies, academics and research. So this is a planning flowchart. This is a planning flowchart. You are read in third year for 3 marks or 10 marks. Like identify the priority. Life also is same like planning. You have to have a proper planning. If I ask identify the priority, what are your priorities in life? Like what are your priorities after BDS? You want to do masters in public health. So there are students like they want to do masters in public health, and few students want to do DDS, and few students want to prepare for NEET. So at the baseline, at the nascent stage, you should have a very clear priority, crystal clear priority. If you want to do MDS, then you have to stick to MDS. If you want to go abroad, prepare for abroad. It happens today, if you want to do MDS, even if someone tells MDS is getting saturated, you get fickle-minded. It should never happen. So you should decide what are your priorities at the initial stage. For first year students also, once you come into second year, you have to take a call because NEET preparation includes all the subjects from first year to final year because it includes 19 subjects. So 6 subjects are there in first year and second year. From first year only, if you start solving, planning to prepare for NEET, it will be very helpful. So as he said, he wants to do masters in public health. So the scope are there in US, UK and Canada. So today I'll be speaking on especially for USA. What is this? STEM, science, technology, engineering and mathematics. So if you are either of this background, we are eligible for MPH. So we are from science background, definitely we can do masters in public health. So why I put this STEM? There are two things, STEM and non-STEM. The subject masters in public health duration is for 1 to 2 years. Average it will cost around $30K to $100K. So in Indian money it comes to 85 lakhs. So in STEM, epidemiology, environment and biostatics comes. In non-STEM, health policy and social and behavioral science. What is this STEM? The first 3 subjects like epidemiology, environment and biostatics come under STEM. What is the advantage of this STEM is, once you complete your masters, still in student visa, that is F1 visa, you can stay for 3 more years in USA. That is last year only it has been implemented in masters in public health. Whereas in non-STEM, it is health policy, social and behavioral science you complete, only you can stay is for 1 year. Because in US, after you complete your irrespective masters in public health or any course, you need H1B visa. We call it as employer visa. But it's very difficult to get, because once you complete, you apply for H1B visa, it is like lakhs of Indians will apply for H1B visa. So in US, there's a table of randomization, only it takes 100 students. So for that, this MPH is 3 years, you can't go for STEM. Next, student have to finish 40 to 56 credits. What is this credit? In US, everything is credit based. Everything is credit based. In India also, DCI is planning to start a credit based studies. So what is this credit? You have to have 48 credits. It depends, it varies with every university. Like if you want to do in Texas, Boston or Michigan or Columbia, top universities, minimum it is around 48 credits. So every credit will cost you around $1,000 to $1,900. What is this? 1,000 means how much it is? How much it is? 85? Loud. Kitna hota hai? What is the dollar rate now in India? 85. So what is the cost? 85,000. So for 45 credits, how much it is? 48 credits? Roughly around 45 lakhs. Roughly around 45 lakhs. Right? So it is a 2 years course. So you have to plan accordingly. In first 6 months, how many credits you want to do? Like if it is 48, if you plan properly, it is 12 credits every 6 months. So in 2 years, you'll complete your kitna? 48 credits. I'll suggest it's not hard and fast. You have to do only 12. At one point of time, you can do many credits also. I suggest you all to do only 12. The only reason is after 6 months, you will be evaluated by your guide. If he feels you are potentially good in expert in your subject, you will get a scholarship. You people will get scholarship. That is $700 way off. $700 way off for every credit. So remaining are 36 credits. So $700 way off is directly 22 lakhs. Directly it is 22 lakhs. So you'll complete your MPH in the 23 lakhs. You can complete your masters in public health in 23 lakhs. Then how to repay the loan? You can repay the loan within 2 years. You can repay the loan within 2 years. So to get into MPH, what are the exams to be given? IELTS or TOEFL. If you ask me, IELTS is easier compared to TOEFL. It is an English exam. It is written and computer based. Reading, writing, speaking and listening. So in IELTS, exams have to be given in the respective centers. Like if it is in Maharashtra, only you can give exams in, you can give this exam in Mumbai. If it is Karnataka, it is Bangalore. So there are various centers where you can give exams. After you clear the IELTS, then there is GRE. It's an optional. If you people are opting for biostatics, it's all about mathematics. GRE is all about mathematics. And few universities, when you further want to do DDS, ask for GRE. So application is SOFAS. In India, how it is a DCI website. In US, you need any information, it is SOFAS. So once you complete masters in public health, as the student said he wants to do public health, what are the job opportunities? He can be a public health educator, epidemiologist, consultant, biostatician, data analyst and clinical research coordinator. So after that, next is many students dream of doing DDS. Many people want to have a practice in US, that is Doctor of Dental Surgery. The first thing is you are supposed to give INBD exam. What is this? Integrated National Board Dental Examination. It is a comprehensive assessment of dental knowledge and clinical skills that is required for licensure as a dentist in United States. So you have to clear INBD exam. So how you have to prepare? The resources are, there is one YouTube channel like Dental and Boot Camp, Booster, that is quick notes. Always you have to go for boot camp. because you can make your own question paper assembled and you can prepare. Then there is prep deck, and other important resources are ADA principles of ethics document, sample questions, and pharma document. So if you are preparing for INBD exam, it is same what you have read in the BDS, the same. Little bit you have to know about the Western culture, little bit extra things. So for that you have to go through, that is booster or boot camp. This all information cumulative I have taken by asking my own students who are doing DDS or who are practicing in US. So how much time you need? For everything we need a time frame. For everything we need a time frame. How much time we need to do INBD exams? If you are a fresh graduate, it takes around 4 months. It takes around 4 months. Who is practicing and suddenly is planning to do DDS? For them, it will take around 6 to 7 months. So how that exam is given? INBD, there is something called as how to build your application. How to build your application. That is good GPA. What is GPA? The most important thing is grade point average. You go to US, anywhere, everywhere it is grade point average. It is a 4-point scale. It is a 4-point scale. So whatever marks you get in BDS, later there is some site called ECE. They convert your marks into that is GPA. That is grade point average. So from the first year itself you start concentrating on studies. If your percentages are more, then definitely your score will be more. When you go for interview, they'll only see is GPA. Other than that, if you are good in any extracurricular activities like sports, dance, everything are taken into consideration, because US needs some diversity. They need some diversity. It's not that only the studies. Any voluntary health agencies, NSS programs you can do, Red Cross Society, or any outreach programs, everything is considered. So how to build your application? That is good GPA, statement of purpose, that is we call as SOP. Why you have taken this subject or why you want to do DDS. Then wide range of dental service. By having many diverse experience, your CV makes you look like an attractive candidate. Know about each dental school. When you want to apply in US, you have to know about the dental schools. What is the cost? What is the time period? Because you people have that sticky, for DDS it takes 2 years. No, it's not hard and fast. Few universities like Michigan takes 3 years. Few universities like Columbia takes 3.5 years. So you should know about the schools. Most important is start early. What is start early? That is preparing. So you know it is the GPA, grade point average. It takes all year cumulative marks. It's not only final year marks. First year, second year, third year, and final year. Then it's best for first year students. If you want to go abroad and if you plan to settle in US or you want to practice in US, it's the best at the nascent stage. You can start working from first year BDS. So most important, start early. And once you prepare your CV, in the interview they'll ask you, what is your CV? You people should be well versed with your CV. It is then which is that portal we can apply? That is Capid portal. Once in that you can choose which all colleges or universities you want to apply. Once you apply, please make it very clear, once you finish your BDS, in first attempt to get DDS is very difficult. 98 to 99% you won't get. It is minimum 3 to 4 cycles. It is minimum 3 to 4 cycles. The only way for success is winning mindset and patience. Winning mindset and patience. It takes lot of time. It is a bit Herculean task, because next slide what I am going to tell you is what is this preceptorship program in clinical subjects. Once you finish your exams, you are given your INBD exams, you have cleared. So you have applied for some Capid portal, you have applied for some college. For example, this student has applied for some university, she has applied for some college, and she doesn't get selected in the interview. We call it as bench test. She doesn't get selected. So what is she supposed to do? What is she supposed to do? She has to work on her CV. She has to work on her CV. How she will work? She will apply into this practiceship program in clinical subjects. What it is? in Boston University, she can apply. In this only we are observer. In this all programs we are only observers. We can't do any practice. We are an observers. So and there will be some international students doing the patients. We will be just an observer. But that US university always feels their practice and their culture is different from India. So they feel ki you should get little bit well versed with this program. So people to build their CV go for this because you are in the tourist visa. To get F1 visa, that is student visa, you have to do some course. You have to do some course. So meantime you can do this practiceship program or you can do masters in public health because you are getting the student visa. When you have masters in public health, definitely your CV will be good. Then it will be easy for you to get into DDS. So it is a 3 cycles or 4 cycle. Then this, what are the requirements? That is your scores should be between 90 to 120. The score should be between 90 to 120. And BDS transcripts and phone interview. And what is this EC transcripts? Whatever marks you get in BDS, first year, second year, third year, final year, it gets converted into GPA. And that is through EC transcripts. So that for that also roughly around 18 to 20,000 we pay only to get our marks into GPA. You feel you are not satisfied with GPA score, whatever you get, they will not give any explanation. That's it. If you have got 2.4, it is 2.4. Few times it will happen, unfortunately, we go into odd batch. You might lose interest or you might fail or your mind is little bit here and there. That means life is end for DDS because we are taking your cumulative marks. 1 year you have been, there is no marks. What you are supposed to do? Definitely if you go in odd batch also, there is a scope because that time we take it as cumulative CPA. Once you take it as cumulative CPA, that means that people in US will be knowing the international students are from odd batch. They take cumulative CPA. So once you know you are in odd batch, you have to make for some points. So definitely that point you have to work on your CV. That is build your this thing by any voluntary health agencies or Red Cross societies, outreach program or being good in national level sports. Everything in US is considered. Everything in US is considered. If you see World Cup, US versus whichever match happened, maximum 6 to 7 players were Indian. Maximum players were Indian and few were engineers who were playing. Definitely in point system, this is included. If you are a sportsman, national level, not in only India, definitely they include in US also. So you have to have good CV. Then the next thing comes is for your that program, you can apply through this link, Boston University, ULCA and NYU. Next is for DDS, see the numbers, it is in 6 figures. That also dollars. 2,000 like to $4,000, that is 1.5 to 3 CR. 1.5 to 3 CR. So if I tell this girl she is interested in doing DDS, your parents will pay 2.53 CR until you have some old ancestor property where you can keep the mortgage and take the loan. Definitely you can do. Other than that, any liquidity cash will be there around 2.5 to 3 CR. But her dream is to go to US and practice. That means her dreams are shattered. What you are supposed to do? There is something called as personal loan. Personal loan. So what is this loan? If she takes from the Indian bank around 2 crores loan, once she completes, she has to pay the rate of interest is 11%. And if she fails to pay, it gets converted into compound interest. So we never advise students to take any education loan. Education loan. Because personal loan interest is more in India than education loan. For any your BDS also loans if you are taking, please think twice before taking student loan. There will be later so many hidden fees also. Personal loan is less than the student loan. Definitely government should take some action. They should reduce some subsidy where student loan can be reduced. Car loan you get in 4%. Any vehicle loan you get in 3%. But when it comes to education, the loan is rate of interest is very high. Then what you are supposed to do? There is something called as Pro-DG finance. Okay? In this, the most advantage is no co-signer and no collateral. What do you mean by this? No cosigner and no collateral. In India, if you want to take any student, if you have taken loan, there will be some property. If you have taken 20 lakhs, you have kept some collateral, or there is some cosigner. But when you take in this, you don't need neither cosigner, neither we need any collateral. So that is advantage. No hidden fees, no surprises, and it is quick, easy online application, and it is loans for tuition and living cost. So in this, 40,000 plus students have been funded, 150 plus countries have been supported, and we are lucky India also has been supported by Prodigy, and 1,500 plus schools are supported, and more than 2 billion has been funded. How much? More than 2 billion has been funded. So once you complete your internship, if you don't have any financial support, still you people can do DDS, your dreams you can fulfill. Only thing is you should have a winning mindset and patience and know how to handle this loan. If you take Prodigy loan, only flaw is today the cost of dollar is 85 rupees. Like if you have taken $100,000, that is 85 lakhs. After 3 years when you are repaying, if the dollar rate is 95 rupees, because there will be some inflation. If it is 95 rupees, you are paying at the cost of 95 rupees. So it will be around 95 lakhs. You should know it is 95 lakhs. And little bit rate of interest is more, but less compared to India. The best thing is there is no cosigner, there is no collateral. There is no cosigner and there is no collateral. Easily you people can get the loan. And the other thing I can suggest is, if any of your relatives in US, please take help from them. If they are ready to give the loan, please take from them, because if in US, if you have some local guardian, then the advantage is they will see the credit score of that person whom you are taking from, XYZ. If the score is like here in India, if I apply for loan, they'll check for civil score, civil point. What is our civil score? Same in US also, there is something called as credit score. They will see credit score. So highest is 850 points. So if the person is between 750 to 800, from whom you are taking the loan, then the rate of interest is only 4%. The rate of interest is only 4%. So as your credit comes down to 600 to 650, it is 6. So the hierarchy is 4, 6, 8 and 10%. So, but if someone like your relative or someone is ready to pay also loan, last moment it might happen, they say no. You are given your INBD exams. Okay? To give one INBD exam, how much cost it will be? 4 lakh rupees. $120 to give exam. Okay? Traveling allowance and daily allowance, all together, it comes to 4 lakh rupees. Because it is a 2 days exams, it consists of 500 questions. 300 will be theory based and 200 will be case oriented. So once you finish your DDS also, you assume this girl has completed her DDS. Okay? She now is a proper US dentist. So she can start her practice. She can open a clinic? No. Because only green card holders can have clinic. What she is supposed to do? Now still she is in student visa, that is F1 visa. If she wants to go for H1B visa, that is not, it is called as employer visa. Please don't forget that you can start practicing. You are just going to be the employer in some organizations. In US, there are many organizations like Pacific, where they run more than 300 organizations. So there directly, if you get selected in that table of randomization, if your number comes and if you are selected and if she gets H1B visa, then she'll start working for that universities where she'll be paid. And the working system is there between 9 to 5. There's a proper systematic between 9 to 5. It's not like any mass practice. And later still she thinks she wants to have some clinic. She doesn't need any bossing. She wants to have clinic. What's she supposed to do? Get married to some green card holder, vice versa. Or she can go and work with someone who has green card holder in partnership. Definitely that person should have a green card holder if you want to do DDS. Worst to worst, after completing, if she doesn't get, If she doesn't get H1 visa, what to do? It doesn't mean that she'll come back. She can work there in some non-profitable organizations where she'll be paid a little bit less, but that company itself will move her documents and see to it they'll get her H1B visa done. Okay? And slowly after 2-3 years, then she can shift to some big companies. Once that company is calling, it's not ki just they'll send the agreement to sign. No, you have to go through, take a legal opinion from the lawyer. There will be some many hidden clause. You can't live for so many years, or if you have done some mistake in the patient, 2 to 3 years you are liable. It is very stupid. 2-3 years you can't be liable. You are working somewhere, again they'll call you to do patients. No, you have to go through proper clause. The fees might be very high. Of lawyer also is minimum 2 lakhs to go through the legal in Indian currency. But make a point, take a suggestion from always lawyer, and then you can move forward. So you can have a first student when you start, it's the tourist visa and bid exams you give. After that you get into MPH or apprenticeship program, that becomes your F1 visa. Later if you want to come still in future, you want to be there working, then it is H1B visa. If you are thinking of DDS, it's very firm, you are never going to come back from US. Then only you think. Otherwise paying 2-3 CR and then later you regret ki why I want to come back to India. No. That will take 50 years to pay the loan in India in that currency. So make a point, because once you start working for these specific organizations, your salary will be between minimum 8 to 10 lakhs. Your salary will start from 8 to 10 lakhs and working hours will be proper between 9 to 5. Clear? This is for DDS or Masters in Public Health in US. Still they are for Canada, New Zealand and Australia. There are various options, but for us the time is given only 30 minutes, so I have covered only US. Next is NEET. Many students want to prepare for NEET. That first, the most important thing is time management. Internship gets over usually in the month of August, September or October. Post-COVID there are some variations. So how much time is there? 15 months. And last 3 months we need only for revision. Last 3 months we need only for revision. Then effectively how much time you have? 1 year. Once you go in final year, 8 subjects, people start thinking so much. In internship you have 19 subjects. Okay? You have to complete 19 subjects. So once you complete your final year, your internship has started. With what subjects you are supposed to start with? Always start with your clinical subjects. Just you have completed your final year, you need a little bit quick start, because if you start with somewhere basics, you might slow down. Start with the clinical subjects, complete them, then study together like subjects like DADH, oral path and oral medicine, like physio and pharmac and medicine, OS and oral surgery. 8 months you have to give for dental and 4 months for basic science. Weekly exam is a must. Okay? When we say you join CD's coaching class, Bhatia coaching class, any coaching class, but 95% is you, 5% only coaching class helps you. That is because weekly if you give exam, if I keep oral path exam, definitely you will study. After that we'll give marks and the rank is given, you know where you stand. Otherwise in internship, there's no one monitoring you, it becomes very difficult. So please make a point, if you join coaching class of CDs, it's a very good, maximum students do crack from CDs. Okay? So after that, later there is something called a crash course also. After last 3 months of your internship, that also you can go for this thing. And if you want a prestigious seat in top colleges, you cannot neglect basic science subjects. Like go through last 10 years questions. You cannot go wrong if the question is repeated from same year. What do you mean by this? If one question also if you do wrong, your rank will be around 1000 to 2000 behind. So if you get the same marks also, they'll see your final year marks. And we are lucky if you are some from deemed universities or here, we do get more marks. So it will be definitely, there will be some advantage. And study the topic in detail from which questions have already come. The best book is Neeraj Wadhwa. Try to understand the trend from out, which subject has more weightage in question paper, then allot time accordingly. What are the MCQ books to be read? Neeraj Wadhwa, Dental Pulse or Gauri Shankar. Then there is some important synopsis book like General Pathology and Microbiology. Govind Garg or Sparsh Gupta for pharmacology, and Vivek Jain for PSM and biostatics, and Mudit Khanna for medicine. Because if I tell you all to read medicine in internship, Robinson, everything, that book itself will take 1 year. And you're supposed to complete 19 subjects. How you will study? You need to do a smart study. You need to do a smart study. Solve maximum MCQs. So after like 10 months, only 5 months are left. Every day night when you're saturated, make a point to solve one question paper. Okay? That of 200 MCQs. For 5 months you're solving. So how many MCQs you have solved? 30,000. And 6% of that repetition, 172 marks, you are into a competition. 30,000 MCQs, just 6% of the MCQs also repeat, you are getting the marks 168 to 170, where cutoff will be around 180. So definitely your rank will be within 500 to 1000. So if you get within 500 to 1000, you will get the seat in government college, where every month stipend will be around 7-8 pay scale, 90,000 to 1 lakh. Indirectly, stipend of 36 lakhs, plus every year fees you are paying, if like deemed anywhere 10 to 12 lakhs. Around 60 lakh rupees your people are saving. Only in internship if you do smart study. So these all books, again for first year BDS, also I am saying, again you people will be reading general pathology, microbiology in second year. First year also you read anatomy, open dental pulse, basic subject, and solve the MCQs. Okay, in exam also the MCQs come. There also you can score 20 out of 20. Okay, make your basics strong, because honeycomb or soap bubble appearance, anyone can tell ameloblastoma. But when they ask chicken fever is caused by which chain, no one tells alpha chain, beta chain, because it becomes difficult. And there where we stand from other students. So make a point ki how to study and do smart study. So current trends are case-based clinical questions are coming. Clear your clinical concepts. That is, internship posting is helpful to clear your clinical concepts. And questions, that is, you have to go through the last 5 years CT papers. That's what I said. If the exams are in the month of March, make a point from November 1st, every day night you are going to solve one question paper. At the end of the day, you are a bit saturated. What you are reading, it will just, next day morning it takes half an hour, but night you just drag it for 2 hours. Instead of that, you solve question papers. It might be, you might get very less marks out of 200, 60, 70, whatever, irrespective. But trust me, by Feb, your marks will be reaching 160, 170. You are into a competition. Okay? Solve maximum MCQs. If there are 4 options, selecting the best one, you will get confused. This also might be correct, this also might be correct. Ruling out 3 wrong answers is more logical approach. Ruling out 3 wrong answers has more logical approach. So for NEET preparation, still we have, even I do take course in our dental college, value-added course, NEET preparation. We have a lot of study material and everything. We have a student exchange program with SDM students. For them also I teach how to prepare for NEET. If any of students in Karad also are interested, you can take my number and ask, we will share the study material. Next is, many students after BDS wants to have a practice, because you should be proud first that you are doctors. Okay? So if you want to have a clinical practice, approximately 5 to 15 lakhs depending on the place, your investment. Okay? Dental needs investment. MBBS 1 chair and 1 torch, but MBBS dental needs investment. You have to invest a minimum 5 to 15 lakhs. Then what things you are supposed to do after BDS? Directly you can open clinic. Definitely you can. Just little bit you have to upgrade yourself by applying for diploma courses. That is, ask about patient exposure. If you are doing diploma course, ask for about the patient exposure, whether how many patients you will get to do. If you are joining for implant, at least 5 implants you do. Okay? That is about patient exposure, experience and expertise of the mentor, what is the cost and duration of the course. For root canal treatment, prosto, application of laser, smile designing, periodontal management, there are various diploma course. Next, where to do? Deemed universities. Savita Dental College, approximate the cost will be between 5 lakh to 8 lakh. Manipal Dental College, 3 to 5 lakhs. D.Y. Patil, around 5 to 7 lakhs. IDA state branches also have started some diploma course. So individual clinics, this ma'am, Komal Khatri ma'am, her course are very famous for implant. 6 days, 6 implant. So Narsimha Bharadwaj sir he works in Savita Dental College. So definitely Savita Dental College also, there's a lot of weightage if you do diploma course. They have collaboration with many international universities. This is if you want to join the academics. Last, out of curiosity something. Last, if people think कि चलो मेरे को और ही कुछ करना है, then there is something called as MBA after BDS. MBA after BDS. That is top MBA. That is, if you want to do, you will be definitely doing some medical related. So it is MBA in healthcare management, MBA in hospital administration, pharmaceutical management, and public health management. Exams given are CAT exam. So top MBA colleges in India. Tata, the fees is only 1 lakh. For Tata, the fees is only 1 lakh. In second year of your MBA, in campus interview get selected, and your placement will be minimum 8 to 9 lakhs per year. Okay? And after 2-3 years, if you have good experience working in very big hospitals, you can go to abroad. Again, for that, this all exams like for dentistry you have to give. But for MBA, directly you can go to abroad in other universities. So next is top universities providing healthcare management courses in the world, like Boston and Stanford University, Columbia University, University of Toronto. There are various universities. And I have covered only US scenario. Definitely New Zealand and Australia, also and UK and Canada. There also there are a lot of scope. Same, it holds good whether you want to do MPH or MBA in hospital management. Our own students are doing this. I have taken whatever this information is from my students from past 14 years. If I am saying DDS source is booster or boot camp, it is because I asked what books they have read, they have cracked based on their results. I am given the source. If I have given the NEET books, it is only based on the topper. My cousins itself are a topper, and so many students we asked who are come among top 5. They have told this is how the studying pattern should be. Solving maximum MCQs is the mantra for success for MDS. Thank you. Any questions, please? If you have any difficulties or any questions, you can ask. I would like to thank Cynodent and our principal sir, Shashikaran sir, and organizing sir, Siddharth sir, for giving this opportunity to speak. Thank you, sir.
Thank you for your wonderful lecture, sir. Now I would like to invite Dr. Surya Kumar Metkar, Professor and Head of Oral Pathology.
Thank you for introduction. I am going to speak on the biopsy in the practice management. I will make interesting presentation, though it is not related to theoretical. Now, can you see what is this? Curtain. Yes, this is a curtain basically. What you can see behind that curtain? Anyone? Anyone from audience? What you can see behind that curtain? Can you imagine? You can't imagine. For that, imagination is required or that knowledge is required. Now you can see there is one beautiful house that is surrounded by nature. To see that nature, what is required? Either you should open the window or either you should remove that curtain. Then and then only that nature is visible. Similar way, what you can see in this picture? This is an oral cavity along with the teeth. That oral cavity is lined by oral mucosa. That oral mucosa is what? Curtain. But beneath that curtain, what is there? For that, at least you have to raise flap or that microscopic vision is required. Then and then only that is visible. Now you want to see that structures. What are the structures beneath that mucosa? Now in anterior area, you can see that adipose tissue in the palate. In the posterior area, what you can say? That glandular tissue. Again, muscles, nerves, blood vessels are there. And from that basically certain pathologies are going to arise. The clinically pyogenic granuloma. But if you see that microscopically, that case is diagnosed as a squamous cell carcinoma. That means that for both treatment modality are differs. Another case I will show you. Now what you can see in the palate? Palatal ulcers are there. That means what you can give clinically diagnosis? As a squamous cell carcinoma. But if you see that microscopically, that case is diagnosed as a necrotizing silometaplasia. Though it looks like a squamous cell carcinoma, for squamous cell carcinoma, that chemotherapy, radiotherapy, and that basically surgical management is required. But necrotizing silometaplasia is what? Basically, it is an inflammatory disorder of salivary gland. For that, basically, it is going to heal within certain weeks. No treatment is required for necrotizing silometaplasia. Remember that. Now, clinically, what you have diagnosed? Squamous cell carcinoma. That's why microscopic diagnosis is very, very important. Again, another case, what you can see, anyone? There is whitish keratotic lesion seen on the buccal mucosa. What you can think, anyone? Lichen planus. Clinically, again, that case is diagnosed as a lichen planus. But microscopically, that is a different. If you see microscopically, that case is diagnosed as a lichenoid reaction. For lichen planus is considered as a potential malignant disorder. Lichenoid reaction is considered as an allergic disorder due to the silver amalgam restoration. If you see carefully, that silver amalgam is there. That patient is allergic to the silver amalgam. That's why that lesion is developed on the buccal mucosa. Again, another case, what you can see in this picture, clinically or provisional diagnosis, what you can give? Radicular cyst, because we are giving the diagnosis on the basis of radiograph. That case is of radicular cyst. But again, if you see microscopically, that case is diagnosed as odontogenic keratocyst. For both, the prognosis are different. The radicular cyst has good prognosis as compared to odontogenic keratocyst. For both, the treatments are different. That's why, again, microscopic diagnosis is very, very important. Again, another case, what you can see? Radiographically, there is a periapical radiolucency in relation with the apices of the tooth. But if you see microscopically, again, that case is diagnosed as a metastatic adenocarcinoma. That patient gives history of breast carcinoma, and that lesion is metastasized in the basically mandibular region in the apices. Again, another case, simply this looks like a epulis, or you can call peripheral giant cell granuloma. But microscopically, again, that case is diagnosed as a basically that clear cell odontogenic carcinoma. Though all the lesions are looking like a benign, that lesions are malignant. Though lesions are looking like a malignant, that lesions are benign. That's why microscopic diagnosis or histopathological diagnosis is very, very important. Again, I am stressing. Another case I will show. Here what you can see? The history of gingival swelling since 3 months. Again, lingually, that there is a basically blackish pigmentation along with the gingival margin. Again, did I miss something? Should I ask something else? I missed. The size and the duration of the lesion is such a large lesion within that 3 months. I should ask about the past dental history. Again, the history revealed the previous excision twice in the private clinics over the period of last 6 months. But the tissue was not sent for histopathological examination. Again, that lesion is of short duration. Multiple recurrences are there. pigmented lesion is there, asymmetry in the lesions, shape and color, that means ABCDs of malignant melanoma that you can think. That lesion is aggressive, that you can think about the malignant melanoma. Again, case 2, you can see the patient complaints of the lesion since 8 days. Again, dark black colored pigmented lesion of short duration. Now that means what you are going to think? Malignant melanoma, but that is not true. That is not malignant melanoma. What you can see? Short duration of the lesion is there, pigmented lesion is there. Again, lesion is bordered by red halo, the clear-cut margins are there, the traumatic lesion is there, and that you can think about the hematoma. Simply that is hematoma, no treatment is required. Case 3, again here you can see that patient has malocclusion. Again, radiographically you can see here that basically that cystic lesions are there. That means in the form of dentigerous cyst, or you can think about the odontogenic keratocyst. Again, another photograph. Anyone, what you can see in this picture? Any abnormality? If you see carefully above the eyebrow, that one ulcerative lesion is there. That means that is a basal cell carcinoma. If you see carefully here, the lower mandibular area, here that draining sinus is there. That means that might be an infected odontogenic keratocyst. If you see carefully here, that nevus is there. If you see carefully here, on that basically eyelid, there is one cystic lesion that is called as chalazgion. That means that is a case of Gorlin and Gault syndrome. That is also called as nevoid basal cell carcinoma syndrome. That cases are usually associated with the multiple ocases. Now another simple case, that bleeding gums, though oral cavity is healthy, but if you see carefully, that purpuric lesions are on the skin, that means that patient is suffering from thrombocytopenia. For that patient, you should go for checking of that basically platelet level, that basically prothrombin time, bleeding time you should check, and then you should do the any treatment modality in that patients particularly. With these cases, I am going to highlight some little bit theoretical part related to that biopsy. But what? At the end of the session, all the participants would able to select appropriate biopsy and do biopsy in the future. What do you mean by biopsy? Biopsy is nothing but the surgical removal of the tissue for microscopic examination is called as biopsy. Why that biopsy is required? What is the purpose? Basically, to confirm the provisional diagnosis, to determine the nature of lesion, whether it is a benign or malignant. Again, to determine the treatment plan, valuable self-teaching diagnostic aids. Again, to remove the cancer phobia. Also as a medico-legal record. For that also, that biopsy is required. Who can perform the biopsy? For performation of biopsy, that oral surgeon is not must. As a simple BDS person also can do the biopsy. Any qualified dentist who has confidence, sir already told that you should have confidence. That's why usually that skill and confidence can perform the biopsy procedures. Again, indications of biopsy: any persistent lesion more than 2 weeks, inflammatory changes of unknown cause, if it is not responding to local treatment within 10 to 14 days, then again persistent hyperkeratotic lesion, if you are suspicious of the neoplasm, lesions interfering with the local functions, one lesions not specifically identified clinical or radiographic findings, or any tissue surgically excised or expelled from the body, material from the persistent draining sinus, bony lesions which cannot be diagnosed specifically. Then some relative contraindications. In that relative contraindication, some anatomical landmarks and racial variations are there. Again, compromise general health. Then lesions proximity to the vital structures. These are the relative contraindications. In absolute contraindication, the pulsative lesions or vascular lesions or the pigmented lesions. These are the usually absolute contraindications for the biopsy. Then what are the basic types of biopsy? One is the excisional biopsy, another one is the incisional biopsy. Excisional biopsy means what? Removal of the entire lesion, or a perimeter of normal tissue surrounding to the lesion is also excised to ensure the total removal. That usually the 2 to 3 millimeter of normal appearing surrounding tissue is excised. Then indications for excisional biopsy. The lesions are usually less than 1 centimeter in size. Clinically, you are suspicious of benign lesion, small vascular, pigmented or pedunculated lesions. In that, you can perform the excisional biopsy. Conditions that require excisional biopsy are basically macular lesions, the nodular lesions, or the papillary lesions where that excisional biopsy is required. Some advantages: the entire lesion is available for that processing purpose, or excisional biopsy itself is considered as one of the treatment modality, or diagnosis and treatment can be given without delay. Incisional biopsy, samples only a particular or representative part of the lesion is processed. Usually if that lesion is large or lesion has a different characteristic at different location, then usually the incisional biopsies are preferred. Indications: extensive size, more than 1 centimeter in diameter, hazardous location. If you are suspicious of malignancy, these are the few instruments which are required for the biopsy. Then principles of biopsy: tissue should be representative of whole lesion, adequate amount of the tissue should be taken. Then if several lesions are present, then specimen should be taken from the representative area. Necrotic tissues should be avoided. The biopsy site should be selected in an area that shows complete tissue changes. The material should be taken from the edge of the lesion to include the adequate normal tissues. Then lesion should be biopsied in the wedge shape manner. Take deep narrow biopsy rather than the broad and shallow. Always you should include the epithelium as well as connective tissue in the biopsy. If the lesion is large or has a different characteristic at a different locations, more than one area of the lesion may need to be sampled. Now you can see here the different characteristics are there. In one area ulcerative lesions is there, one area that exopathic growth is there. From that basically you should take the multiple biopsies from that particular site. The biopsy procedures: first you should give anesthesia after cleaning that area. Then you should stabilize that part. After stabilizations, you should give incisions, and then you should take the tissue, and then you should achieve hemostasis. Then you should do proper handling of the tissue. During that handling, you should take certain precautions. Use a traumatic forceps. If you are using traumatic forces, then that basically artifacts can be seen. Identification of surgical margins, that can be done with the help of sutures. Then due specimen care should be taken. That specimen should be transferred to the 10% formalin. Then you have to close the surgical area with the help of suture. Then you should fill the biopsy data sheet or requisition form in detail, and that should be sent to the pathologist. Now these are the punch biopsy. Here involve the special instruments, particularly punch, that is used for the removal of portion of the lesion. The punches are composed of circular blade and the trephine attached to the pencil-like handles. The instrument is gently rotated with the firm downward pressure. The punch is pushed down until the subcutaneous tissue is reached. Now you can see the various sizes of punches are available that might be usable, reusable, disposable. Then these are the certain advantages or disadvantages of the punch biopsy. Again, punch biopsy technique, now see, you have selected the area, just you have to hold like a pen. That firm grasp is required. Just downward and circular motion, that pressure you should apply, and then you should cut the area with the help of scissors, and that should be sent for the processing. The submission of biopsy, that should be accompanied by the requisition form. The biopsy being performed, the biopsy specimen is stored in the 10% formalin, then that tissue sent to the lab. Then after that basically grossing, then all that procedures are there, dehydrating agents are used, then clearing, then embedding, then microtomy techniques are there. Then that sections are ready, then sections are stained. Now that slide is ready for microscopic examination. Now what points you should remember while performing the biopsy? First and most important, application of antiseptic agent. You should not apply antiseptic agent on the lesional tissues because it will create artifacts. Injection of local anesthesia. Do not inject directly local anesthesia within the lesional tissue. If you are injecting, then it will cause the edematous changes. That tissue edema will be there, or that blood clot formation will be there. Then that will be confused with the basically any vascular lesion. Again, another thickness of tissue already I have highlighted. You should always take deep and narrow biopsy rather than the broad basically. And that biopsy should include epithelium as well as connective tissue. That's why deep biopsies are usually recommended. Again, handling of tissue. Due care should be taken during the handling. Use a traumatic forceps. If you are using traumatic forceps, see here, it looks like a blood clot and then it can be confused with the vascular lesions. If you do improper surgical care, if you are doing rough handling, then sometimes pseudo-cleft formations can be seen, and that pseudo-cleft, usually that cleft formations are usually seen in the bullous pemphigoid and cicatricial pemphigoid, and that you are microscopically you are going to give a diagnosis as a skin lesions, but it is actually artifact. Then cleaning of tissue. Always you should clean that specimen for that blood clot, for cotton fibers, glove powders. Then fixation, transfer the specimen into the 10% formalin. You should not use water, saline, acetone. Volume of fixative. Again, that volume should be of 20 times than that of that volume of that specimen. That is also important part. Then, if you have detailed history of the patients, if you have clinical examination, if you have radiological examination, histological examination, you are going to give that final diagnosis, and that will be beneficial to the patient. Then take away message. Never neglect smallest information which is available. Not to neglect other methods, particularly that clinical, radiological. Always examine the intraoral and extraoral area thoroughly. Systemic history is also important, and that should be correlated. Whenever in doubt, go for the specialist consultation or take second opinion. Every excised lesion should be sent for histopathological examination. Common things happen commonly, so most of the times you are correct. Rare things usually happen rarely. Now what you can see in this picture, that signs and symptoms and that investigation should be correlated with the human brain. That's why always remember, search, relate and correlate that part. Now what you can see in this picture? Anyone? What you can see? Who is this guy? This is Arjun. That he is doing archery. Now what he is going to do? That Dronacharya has asked question. What you can see? Then he told, I can see eyes. But here, don't be Arjun for diagnosis. Arjun had a clear-cut goal on which he has to focus, concentrating only on one point. But here people should not concentrate on only teeth. You should concentrate on the adjacent structure surrounding to the teeth. That is one motto. Again, what you can see in this picture? That's why always try to become Krishna, who collected the entire information and used that for the victory of Pandavas. That's why remember, you should collect the information, the clinical information, that radiological information, that microscopical examination for a diagnosis of that basically patients. Now, I am very thankful to the management and principal of School of Dental Science, Karad, especially sir, and one of my friend, Dr. Rishikesh Mahaparade for his correspondence, and Dr. Verma also, and that all the organizing committee of Cynodent conference for giving me opportunity to speak in front of you. Thank you.
And now I would like to introduce Dr. Mohini Daulatani ma'am, periodontist and implantologist. Ma'am has completed her post-graduation from KVV and also has been a MDS gold medalist. Ma'am has also completed her associate fellowship in laser dentistry from WCLI USA.
So before I start the lecture, I would just request all the delegates to please come ahead. Everyone. Everyone can shift ahead, please. Benches, I said. Daulatani. Yes, I'm from this parental college, Krishna Dental Science, that is 2000 batch. So just a small gist before I start my presentation. This is my clinic, that's Advanced Orthopedic and Dental Care in Vashi. I've completed my fellowship under Dr. Apurva Gupta. Plus, I'm a perio and laser mentor at this academies. So, to begin with, why our dentistry is continuously changing? There is continuous change in our dentistry. We are evolving day by day to give better patient comfort as well as the operator comfort. Initially, we had manual chairs. Now, we are coming with lot of automatic chairs that is just going all digital. From black fillings, we are coming to white fillings. From painful to painless extractions, we are coming. From drills to no drills. From painful dentistry, now everyone is using conscious sedation, as everyone knows. Very common in dentistry now has come up as conscious sedation. And from blood-filled sites, we are coming to bloodless sites. So this all is possible because of your laser. So they say laser is a boon to dentistry. Laser is a boon to dentistry, but do you wonder how? Do you think, is it a magic wand? Everyone, yes or no? Do you think, is it a magic wand? Yes or no? You could please answer. Yes or no? Okay, yes, according to you. I think I could just hear one or two people who said no, but the real answer is no. It's not a magic wand at all. Why laser is so good? It's because of its unique properties. So what are the unique properties? The word itself tells you. Light amplification, stimulated emission of radiation. So how is your laser light and ordinary light different? Whenever you take a laser light, it's monochromatic. Monochromatic means it just has a one wavelength. That is, it just has one color. But when you take ordinary light, it is the sum of your Vibgyor. The next is laser light is unidirectional, but your ordinary light will emit in many directions. Next, laser light is coherent. That means the waves that come out of the laser light are in space with each other. The next quality is coherency, that is waves are in space and time. So because of this unique property, the laser is into the picture. The next is amplification. I think everyone knows this. You have atom, you have nucleus. whenever it gets charged, from ground state it will go to a higher state, right? So whenever it is in higher state, it is unstable. It comes down and it emits a photon. So just understand what's going on in your laser machine. You have the central solid medium. Whenever energy is given to a machine, it gets excited. The atom gets excited, the photons are released. Then what do photons do? They are bombarding with each other and creating this amplification. Means 2 photons are emitting 4, 4 are emitting 8, and 8 are emitting 16. That property is called as amplification. The next is stimulated emission. So as you saw in this diagram, I told you, once the energy is absorbed, it goes to the higher ground state. Because it is unstable, it comes to the ground state by emitting a photon. But in higher ground state, one more photon comes and bombards it. So instead of releasing 1 photon, every time in your laser light, 2 photons are being emitted. So that quality is called as your stimulated emission. And the last property is your radiation. So what is radiation? As you know, this is a diagram of a wavelength. All the wavelength below 350 are considered to be invisible ionizing radiation. Between 350 to 750 is your visible radiation, and above 750 nanometer, it is considered as invisible thermal radiation. And diode laser, to be specific, is between 800 to 980 nanometer. Okay? So how do you classify laser? The laser is classified depending upon the biological hazard to your eye and skin. So coming to the first, you have class 1 and class 2 laser. They are absolutely safe and will not create any hazard. That is laser printer and the laser pointers. Class 3 and class 3B lasers are the one who have the power of more than around 0.5 watt, such as your low power laser therapy. And the next is your class 4 laser. So class 4 lasers are the one that we are using, diode laser and Ariag laser. Depending on the tissues used, you have soft tissue laser and hard tissue laser. Now, how does the laser delivery happen? It happens with various modes. But what is diode laser using? It is using its fiber optic mode. So what is fiber optic? As you could see in this diagram, it is as equal as you're holding a pen and you have a glass sheath. So it is as equal you're holding a pen and you have a very good tactile sensation. So whenever you do an incision, it is as equal as you're just doing it with a pen. With scalpel, you have to hold, you have to have a precise incision. And once you do any surgery with scalpel, the main thing that comes up is, what happens when you do an incision with scalpel? Blood. But it's not with this laser. You do an incision, it's completely bloodless. So actually laser is more benefited to an operator. You have bloodless side. And what is patient experiencing? Completely painless treatment and is very, very comfortable. On the same day, he does the surgery and just goes to the office. But if you do a surgery with scalpel, you are telling patient, have painkillers, have antibiotic, wait for 5 days, be on this diet. But it's not the same with your laser. Okay? So what are the modes of laser? It's contact mode and non-contact mode. All the incision and excision surgeries are done with your contact mode. But whenever you're using low power laser therapy, that is LLT, that I'll be describing, is done with your non-contact mode. So how is the emission of mode? Whenever you start your laser machine, you will have 2 modes, that is continuous wave mode and pulsed mode. Continuous wave, as the term is denoting, the laser will come out continuously as long as you're pressing the foot switch on. But what will happen if the more laser is emitted? It can cause increase in thermal heat to the tissue. So you have to release it manually to give the thermal relaxation to the tissue, right? That is continuous wave mode. And the next is gated pulsed mode. So machine itself will set a timing period where it is making the laser power off so that the tissues get the thermal relaxation period. Okay, so it's continuous wave mode and gated pulsed mode. How do laser interact with the tissue? There are 4 mechanisms. One is absorption. So once the laser gets absorbed into a tissue, what do you have in your tissue? Everyone knows. We have pigments. What are the pigments in our tissues? In soft tissue, yes, we have melanin. What else we have? We have melanin, we have hemoglobin, we have water molecule. In hard tissue, what do you have? OH crystals, hydroxyapatite crystals are there, right? So this all gets absorbed, and that is how your mechanism happens. So that is your absorption. Bhaiya? Yeah, so just see here, whenever you have a wavelength, as you could see that red color is hemoglobin and melanin. So your soft tissue diode laser has the maximum absorption of your melanin. That is the reason diode lasers are considered to be a soft tissue laser. But when you go and see ARIAG laser, so that absorption is more in your water molecules. So that is the reason hard tissue lasers are your ARIAG laser or ARIAG chromium based laser. Reflection is a mechanism that is used by the Cynodent device, and scattering is like whenever you use a laser on a tissue, you will always find that area to be heated. So the laser is getting absorbed into the tissue, and around 10% is not having any work, but it's heating up the tissue. That mechanism is by your scattering. What are the thermal effects of radiation? Just imagine you have a tissue at normally it's 37 degrees Celsius. But what happens as the temperature gets increased? When you increase the temperature to 45 to 50, that's hypothermia. Hypothermia means you will start seeing the blanching of the tissue, right? The next is 60 to 80 degrees Celsius. What will happen? There is protein coagulation, denaturation of protein. Have you seen an omelette? What happens when you put it on the pan? It's clear white, but then it becomes milky white. So that is your denaturation of protein and coagulation happening at 60 to 80 degrees Celsius. Okay, and at 100 degrees Celsius, what happens? There is vaporization of tissue. As everyone knows, water will boil at 100 degrees Celsius. So you have a lot of fumes coming out. Same happens with your laser tissue. It's not that the blood is coming out, but what comes out whenever you do a laser surgery, the fumes are coming out. That is the reason you always have to keep the high vacuum suction on. Okay, to be very clear, that's called as laser plume. That are hazardous, so while doing laser surgery, we always keep the high suction vacuum on. A small light to LLT, because we have cases on it. We are using laser at a very low power laser, so that is known as low power laser therapy or photobiomodulation. So what is that? It uses red and infrared wavelength at 3 to 15 millimeter depth penetration happen. So what does this laser? What does the laser do when it is having a very, very minimal power? You will not do any incision, you will not do any excision. When you decrease the power and you're applying it to any of the tissue, what happens? You can reduce the pain, you can accelerate the healing, and you can also use it for nerve injury. When does nerve injury happen? Very commonly, paresthesia हो गया, कब होता है? Extraction after your third molar surgery, very common. We have case ahead that we'll be seeing. So that is your low power laser therapy. It will decrease the inflammation, edema, it will help in nerve regeneration, increase the bone formation, and it will help in your angiogenesis. So how do you use laser? You can use it for incision, excision, ablation, to accelerate the healing and for also bacterial reduction. So let us have a look about all the clinical cases one by one in each field. So what do you do in endo? Very commonly we do RCT, our bread and butter. So we do AO, we do BMP, we do obturation. Despite that we have pain, post-operative pain hota hai. We tell the patient, obturation ke baad 24 hours hota hai, that's normal. We give painkillers, right? So there is one more thing that has come up in your RCT, that is sterilization of your infected root canals with laser. I am not saying that you will be replacing the sodium hypochlorite irrigant, no. You are doing the AO in the same way, you will be doing the BMP completely. You are adding up the laser to have a complete bacterial elimination. Okay, so how is it? This is a case where 1-5 I did AO, I did BMP, then I went and did laser bacterial reduction. So how was it done? Just have a look. So the fiber optic tip is placed 1 millimeter short in elliptical motion. You get it for around 15 to 20 seconds. So just one cycle helps a lot. Okay? So once this is done, you complete the obturation and give the cap. But you always have to make sure when you're using laser. ऐसे नहीं laser है तो चलो use it up. If you put it at a very specific point for a longer time, you can create a ledge. And that's not how it should be. If you're crossing the apical foramen and you keep it at more that area, you can harm the periradicular tissues also. So you have to take care when you're using laser. Okay, so to specify, so you are using irrigation, this is just an adjunct and not the replacement. Next, for the veneer case, this is a case where the doctor had planned for the veneers. So it was a referred case. We planned for laser-assisted gingivectomy. So initially we just did. ये चालत नहीं है. हे बापरे. ते काढा. So we did the gingival zenith marking. We used the laser, and also we planned for the depigmentation at the same time. So laser gingivectomy was done. What we saw was we had excellent control of the bleeding. That really helped us a lot. And on the very third day, he could plan for the veneer prep. So this case is still under process. Next is in your pedo. What are the common cases you do in pedo if it comes to the surgery? Frenectomy, tongue tie, mucocele, right? So this is a case of mucocele, just a 5-year-old girl. She had painless lobulated swelling. So we planned for laser-assisted excision, and this is how it looked immediately post-op. There was no bleeding at all, and this is after 1 week. So can you see the change? And what if we do the same surgery with scalpel? Just imagine the kind of bleeding it would have been. More than the patient, the parents panic. So if it's a pedo case, you can't have anything done with scalpel, right? Next is your tongue tie. So whenever you use a laser tip, because the tissues get adhere, you have to make sure that you will be cleaning it with the wet gauze. The next is tongue tie case. Tongue is unable to touch the palate. So once we do the laser-assisted tongue tie surgery, this is how it looked after 1 week. Can you see this yellowish thing at the center? This yellow thing, that's called as protein coagulum that gets formed after the laser surgery, and that is the reason you do not require a Copac when you do a laser surgery, right? When you do a conventional surgery with scalpel, we are like, Copac chahiye, but not with the laser, because you have a biological dressing coming up after that, and this is after 1 week. So just see the difference, right? So that was your pedo cases. Whenever you do laser surgery, you have to know the anatomy when you start the laser, okay? Now coming to the OMDR department, what are the clinical cases we have very common? Pain, right? Ulcers. So this is a case of ulcer on day 1. Now we used laser, that is low power laser therapy, that is LLT. So that is your 0.5 watt, 30 seconds and in non-contact mode. So how we did it, just have a look. Can you see 1 centimeter away from the target tissue, you keep it 0.5 watt and just use it for 20 to 30 seconds. So once this was done, this is how it looked on day 2, day 3, and day 4 it gets disappeared. When you have ulcer, you always tell the patient, use a gel, तीखा नहीं खाना है, गरम नहीं खाना है, ये नहीं करना, but it's not the case with laser. On the very same day, you will have beautiful results, right? So that was about ulcer. This is one more case where we did PBM, and the results were very clear on day 3. The next case is grafted implant site. This is a case that was referred. The surgeon did the surgery, he did the GBR, but the next day it landed up having abundance of inflammation. So but obvious I can't open up the site, but yes, I can accelerate the healing with help of my laser. So how we did it? We gave photobiomodulation.
पहिल्यांदा सूज दिसली हां सूज दिसते
for 2 times a week. Okay, first day, third day. Once this was done, this is how it looked after 1 week. And this is after your giving Maryland bridge. This is 2 weeks healing. So can you see the difference? So with help of laser, you are accelerating the healing process. Okay? So this is after the surgery, third molar surgery was done, and the patient had immediate paresthesia. So when he came to me, he said, I just have paresthesia on tongue. The tongue right side is only supplied by a lingual nerve. So what did we plan? We planned for LLT along the lingual nerve. So how did we do it? We did give neuroband port, right? We tell the patient neuroband port up khao, din make. For 30 days we tell him to have once a day or twice a day, and you tell patient 5 से 6 महीने के बाद recovery हो जाएगा. And it depends body to body. That's what we all dentists do. But what is with laser? Just see. Along the lingual nerve, we did the photobiomodulation completely. And then after 1 month, we did a video recording.
फील हो रहा है राइट फील हो रहा है अब फील हो रहा है अब देखो
So complete 100% recovery
Feeling?
was there within
Right?
1 month.
Okay.
Right? So now coming to oral surgery, what is that you do very, very commonly? What do you do in oral surgery? Extraction, and in extraction, what do we say the patient? When will it heal? When will it heal? 4 to 6 weeks, depending upon the body to body, depending upon the age. So this is a case of fresh extraction socket where we planned for photobiomodulation. Can you see the beep that's happening? That's continuous wave mode in your laser. This is how it looked on day 3. This is how it looked on day 6. So same, I gave 2 cycles a week of LLT. This is after 1 week and 2 weeks. Can you see the difference? Pre-operative and post-operative, within 2 weeks we had a very good results, and the patient was very, very happy. This is a case that was referred after giving local anesthesia infiltration. The patient developed an anesthetic reaction and it was burning like anything. He was in severe pain. So what we did same photobiomodulation. It was so painful, he could not eat anything from the right side. He was on only liquid and cold diet. So once he started with this, all problems got solved. Just see how it looked on day 3. This is after 1 week, 2 weeks, and 3 weeks. So the patient came with this, and that is how we went within 4 weeks, right? I did not give him any kind of gel application. That was not required. He did not require to take any kind of painkiller. That is the beauty of laser. Okay, if you understand the mechanism, it will work like that. Coming to the ortho, whenever you do an ortho treatment, the maintenance part is very, very poor. So that's the reason you have a lot of rolled marginal gingiva. So we planned for laser-assisted gingivectomy. This is how it looked post-operative. This is 1 week follow-up, and this is 3 months follow-up. Can you see the result? It gives you a knife-edged margin very nicely. So coming to the prosto, right now whenever we want to take the impression, what we all do, we use retraction cords, we use retraction paste. We put it and then you record the impression, right, to have that clear margin. But with laser you don't require that. With laser you can you do it laser troughing once and you get a very, very clear margin. So this is how we do it. And this is how we could see the gingival sulcus, right? We recorded it and the prosthesis was placed. Whenever you use laser, make sure you keep the exposure time minimal, go slow, allow the laser to interact with the tissue. This is a patient, she had a metal cap and it was getting dislodged 4 times. Like within 6 months, 4 times the cap came out. But what was neglected? The clinical crown height. So when she came, we planned for laser-assisted gingivectomy on the very same day. I did laser-assisted gingivectomy. I finished the margin. I sent it to the lab, and on the 4th day, I could give her a cap. If I did the same surgery with scalpel, I would have told her to wait for a week, then record it, and then give the cap. You got the point? Next is perio, the last topic and my favorite because I'm a periodontist. We have a lot to discuss in this. This is a case once you complete your root canal, you have a lot of gingival polyp at that point. And we are like, we'll do it with burr. Very commonly what we do, we just take a burr and get it off. Or take a scalpel, get it off. It keeps on bleeding. You do the POR, you do not record the margins properly. But with laser, you could do on the same time laser-assisted gingivectomy and on the same time do the POR and record your impression. That is with your laser. Same is for your opelectomy. Whenever you do opelectomy, always make sure to remove the distal pocket. Just removing that part will not help. You have to remove the distal pocket also. This is a case of frenectomy. That's your papillary frenal attachment. Ongoing case of ortho. So what we did, we planned for laser-assisted frenectomy. The tip was initiated. Continuous wave mode was used at 1.2 watts. And this is how we did it. The frenums are, the fibers are excised slowly. You will be excising until the depth where you don't have the tension test positive. Okay? This is how it looked post-operatively. So for all my cases, I do any kind of surgery, I make sure to do LLT. LLT is a low power laser therapy. Why? So that the patient will not have any pain and I should have an accelerate healing. So photobiomodulation is done for all my cases after the surgery. Because the rhomboidal formed after the frenectomy was very big, I just gave one frenum. I just gave one suture at that point of mucosal area. Can you see this protein coagulum? This is what it gets formed on day 3rd. And that's the reason when you do with laser frenectomy, they don't have that pain. Have you witnessed when you do a frenectomy with scalpel, there is a lot of inflammation, right? Patient is in severe pain, but that's not the case when you do it with laser. So this is how it looked after 1 week. This is your 1-year follow-up. So from papillary attachment, we came to mucosal attachment. So whenever you do frenectomy, do not aim to have a wide rhomboidal area. If you get that wide rhomboidal area, you can just add one suture that I done for my last case. Coming to the vestibuloplasty, we had high frenal attachment at 3141. This is a very common clinical finding that we have. We have decreased vestibular depth, so we planned for vestibuloplasty with help of laser, and this is how it looked post-operatively after 1 week. So this is your protein coagulum that gets formed. This is after 1 month follow-up. And with help of laser, we could also increase the vestibular depth as well as the tension test got negative. So whenever you plan for vestibuloplasty surgery, you have to make sure that you extend one teeth mesial as well as one teeth distal to the surgical site. This is a case of tongue tie. The patient had slurred speech. The palate, the tongue could not touch the palate, so we planned for tongue tie surgery. The tip was initiated and the fibers were excised. As we went to have the fiber excision, the tongue was able to roll the palate at that point. So this is how it looked immediately post-op. Just imagine if you do the same surgery with scalpel. Because as a periodontist, we have done the surgeries first with scalpel and then the laser was used at last. So when we do it with scalpel, there is tremendous amount of bleeding. You have to give sutures also. But in this case, I did not have to give any suture because the protein coagulum was getting formed and the patient was not having pain. That is the beauty, right? So after the surgery, that's what I told you, we do LLT for all the cases, and this is my follow-up that was seen. We had results very, very fast. This is a case that is curettage with diode laser. So this patient is just 20 years old and she was getting scaling done, but her problems were not getting solved. So as you could see, there is tremendous amount of redness, inflammation, bleeding on probing, and there was severe halitosis. So what did we plan? We first went with oral prophylaxis. We gave her mouthwash, gum pens. We made the gums ready for the surgery. If directly that patient comes to me, it's not that I'll start with the surgery. I have to go through the basic protocols. I have to do first scaling, remove all my hard deposits, and then plan for the laser surgery. So this is how it looked after 1 week. So what do? We place the fiber tip inside the pocket, and we do complete inner pocket de-epithelialization. So how is it done with laser? Please have a look at the video. Can you see the fiber tip is placed along the pocket wall? So complete de-epithelialization is done. This is how it looked 1 week after the surgery, 3 weeks after the surgery. So that is how the results were. Whenever you do the surgery with laser, make sure you do not heat up the papilla. Go slow, but allow the laser to also interact with the tissue. Only debride the soft tissue wall of the pocket. Very common cases, cosmetic cases that we do, and it is beautifully done with laser because it gives you instant result. Like, in today's world, as instant Maggi is very famous, people want instant results, right? Everyone that pays you in your dentistry with advanced technique is just to have instant results. Why did the digital dentistry got a boon? Because everyone wants to have super fast work done, right? So this is a depigmentation. Record was done. So what do you do with fiber optic? You use a paintbrush stroke and you do complete de-epithelialization. So this is how it looked immediately post-op. But if I do the same surgery with scalpel, I have to do a split thickness flap where my incision has to be very, very precise, okay? This is after 2 weeks follow-up, and this is the result. This is how even one more case, we had very good results. So whenever you do laser surgery for depigmentation, do not forget to check the biotype. You always have to check the biotype before you plan for your laser depigmentation surgery. So this is how your location has to be. Stay away from your gingival margin and do not cross your mucogingival junction. So this is a case where we had to go for second stage surgery. It's a referred case where the zygomatic implants were placed with multi-unit and you're not visible. So what do we do in second stage? We give an incision with scalpel, open up, see it, and then you place a former. But with laser, that's not the case. Just see the video. Can you see? The multi-unit abutment is getting exposed. I could easily do that, and I don't have to reflect the flap. So once this is done, it was visible, the former was placed, and this is how it looked post-operatively. So always make sure, allow the laser energy to interact with your dental tissues. This is the last case of periimplantitis. Yes, to be very precise, this case is recorded here itself in Krishna College 10 years back that I had done with my PG. So this was a case of periimplantitis. The problem was high frenal attachment and thin biotype. So first we did the frenectomy. After doing that, we planned for connective tissue grafting. So before placing the connective tissue graft on my laser site, I wanted to have a complete decontamination. So how can you do decontamination? You will use local antibiotics, locally irrigate you will do it, but at the same time you can also use laser. Just have a look how. So incision was placed, I reflected a full thickness flap, and then we did irrigation with Taxim. Once the irrigation was done with Taxim, to have a complete thing of antibacterial reduction for sterilization, we also did laser decontamination with the laser. And then the connective tissue graft was placed and sutured. This is how it looked post-operatively. So in 2013, when I did my PG here, the laser was just started and we were like, laser. So let us have a study. So this was my short study, and yes, Siddharth sir is here. We did it together. Okay. So this is a split mouth depigmentation study where half side I did depigmentation with scalpel and half side I did it with laser. So just have a look. So once I have a case, I record the case completely. I we had informed the patient that this is a steady case. You have to go under scalpel also and laser also. So the left side was treated with scalpel. I did a split thickness flap, and this is a photograph taken immediately on second day, right? And the right side, we went with laser. Laser depigmentation was done. This is how, where the immediate post-operative thing. When I did it with scalpel, I had bleeding. The patient was also in pain. But the right side, when I did it with laser, there was no bleeding. Patient was not having pain. So that is what was the key point. This is how it looked post-operatively. Once you see the post-operative results, you will be not able to identify which side was treated with what, right? And yes, we also published this article in PubMed journal with Dr. Girish sir and Dr. Siddharth sir. So the findings suggested that laser treated site, very, very important. It shows reduced pain experienced by the patient. That's the first point. And second is better operator comfort. Got the point? That is the key point message to take home. That is what we had published. So what are the advantages of laser? As I showed you, you have a complete dry field surgery. That is bloodless site is there. You have reduced post-operative edema. Antibacterial, you have complete sterilization. I don't consider to have any disadvantage, but yes, there is a consideration to be taken into account when you use laser. What is it? Laser is costly. Why? Whenever you plan to have a soft tissue laser, that will cost you in between 2 to 5 lakhs. And it's not that you take a machine and start doing it. No, you have to undergo training specific before you start doing it on the patient, right? The next is protective eyewear is very compulsory, and laser plume that comes out is hazardous. So you have to keep high vacuum suction on always. So what are the advances? Yes, this is called as Ferrari of laser. That's hard tissue laser, and that will cost around 30 to 40 lakhs. So whatever you do with your handpiece drills is completely done with this, and it has no pain. So that's the beauty of hard tissue laser. Very few people have it in India because it's quite expensive. And the next is your perio wave, where we use a photosensitizer with laser to destroy that specific bacteria. So to conclude, laser has more of precision. It has excellent hemostasis, reduced pain, and patient compliance is very, very nice, better operator comfort. So laser is considered as brush for the painter, chisel for the sculptor, instrument for the physician, but you could not forget the ultimate healer. These are references. Thank you everyone for patiently listening to me. Thank you Dr. Anmol ma'am, Cynodent, for giving me the opportunity to talk at my parental college. This lecture will be very, very special to me. I've delivered a lot of lectures, but yes, it's very special to me because I'm the founder batch of UG. That's when the dental college started, 2007 to 2012. And I'm the founder batch of Perio also, 2013 and 16. So this has a special place in my heart, and it will always be. So these are my ideas. If you want to have any update regarding laser, I do keep conducting courses. You can get connected with me anytime. Thank you everyone for patiently listening to me. Special thanks to all the backbenchers who came ahead to attend my lecture. Yeah, to be precise.
Thank you, ma'am. Now I request Dr. Sashikaran ND Sir, Dean, School of Dental Sciences, Krishna Vishwa Vidyapit, Karad, to felicitate ma'am with a memento.
Ek minute. Thank you so much, sir. Thank you so much, sir.
Thank you, sir. Thank you, ma'am. Moving on with the next, I would like to invite Dr. Lisa, Professor and PhD Guide, PG Guide, PhD Scholar from SMBT Dental College and Research Center, Nashik. Ma'am's topic of presentation is platelet concentration, past, present, and future. Over to you, ma'am.
And I thank the organizers of the Cynodent, the institution, for giving me this opportunity to address all of you and share some insights on the topic, the journey of platelet concentrates. If I may know how many of you are aware of what platelet concentrates mean? Could you just raise your hands? If you're aware of what PRF technology is, what are platelet concentrates? Are you aware or are you not aware? Okay, maybe you've just heard this terminology. Okay, so this is going to be a little vast, so I'll just try to concise so that you get the journey, yes, and you exactly know where we are currently. So let's delve into this journey. And this journey comprises of basics, biologics of platelets, the evolution, how it evolved, how to prepare it, what are the different forms, what are the different generations, how do you classify them. Besides that, the various generations I mentioned, the various factors that affect the outcome of these platelet concentrates, how to optimize the quality of platelet concentrates, and the future prospects. So going back to the origin, that is the life-sustaining force, blood, yes? So we are aware it is plasma, red blood cells, and just very little, that is just less than 1% of what accounts is your WBCs and your platelets, okay? And this happens to be our focus. We need to concentrate this in our product that we are planning to give our patients, that is the platelet concentrates. So you can imagine this is the fraction that we want to, yes, collect and make it clinically usable, yes? So you need to know this ratio. For every 600 red blood cells, you just have 40 platelets, yes, in the whole blood. So if you want to concentrate it, you would need something. That is called as a fractionating instrument. That is, I hope you are aware of centrifuge, yes? A centrifuge is a machine which would spin and let the fractionation of the liquid or the blood component happen. And what happens when you fractionate it? It will show up these layers. The topmost layer is the platelet poor plasma, PPP, the one that is yellow. Then the middle coat, if you see the bluish layer, that is referred to as a buffy coat, and that is the area that we are primarily going to be talking of common. That is made up of, or that consists of primarily the WBCs and platelets. That is where it settles. And the bottommost layer is your RBCs. So this fractionation is happening because of the densities here. Yes, the denser the component, it is going to settle down. Okay. So this is how it will be. PPP, PRF, RBC. The RBC we discard. PPP does have some platelet value, but this is what we are concentrating. This buffy coat in the center, PRF, platelet-rich fibrin, okay? So when we are talking about healing and regeneration, the focus here is platelets, okay? So this is a electron micrograph, how a platelet looks like. This is an activated platelet, and we all know the biogenesis. It is arising from the bone marrow, and its journey like a megakaryoblast to a megakaryocyte till it gets triggered. Yes, it gets triggered by injury, vessel, trauma, and the journey from bone marrow to the periphery is worthy of being examined. Why? The moment it gets triggered, yes, the moment it gets triggered, it gets activated. There are a lot of granules. It has got basic morphology of like any other cell, but it has got special granules, alpha granules, beta granules, lysosomal bodies, and what happens upon trigger? These break open, and these release over 1,500 different compounds. And to name a few are these growth factors, yes? Growth factors, because we are talking about healing, we're talking about regeneration, right? So to name a few, so that you are aware of certain factors at least: platelet-derived growth factor, vascular endothelial growth factor, yes, epidermal growth factor, several cytokines. So once it gets triggered, this is what it releases, and what are these bioactive molecules bringing about? Cellular synthesis, fibroblast, they are laying down collagen, they are triggering a lot of cells, and they are bringing about not just proliferation, but angiogenesis, even repair. So even apoptic activities are set up by platelet. So that is the beauty that platelets possess. So now what makes it so special? It's just a blood component, patient's own component. How is it assisting in healing? What is so special about platelet-rich fibrin, yes? So the basic mechanism is, now this is a clot that is formed. It is basically a scaffold, okay? Scaffold is a matrix, And this matrix is helping to trap the cells and keep the cells in place. Not just that, it is a storage scaffold. That means whatever is trapped there, it is gradually going to release these bioactive molecules over a period of time, over a good span of time, so that healing is facilitated, yes? So it just not acts as a scaffold, it also liberates these, not just platelets, there are several of these cells that liberate, these are granulocytes, monocytes, macrophages, they are also liberating their bioactive molecules, and they are also channelizing healing. They are also helping to recruit endothelial cells into the picture and facilitate neoangiogenesis. Neoangiogenesis. Yes, so this is how it just not forms a scaffold, but is also helping in neoangiogenesis. Now what happens, the lifespan of these platelet cells is just 7 to 10 days. So once the viability is lost, yes, it is starting to fade, what happens, it stimulates the macrophages to take up the charge. The macrophages bring about the vacuum cleaning, that is, macrophages bring about the phagocytosis. So it also sets up the pace for repair. So not just cellular proliferation, but also repair activities. And that is how this scaffold is basically a live engineered tissue, yes, with a lot of scope for regeneration, healing. Evolution dates back to as early as 1954, where this PRP term, that is platelet-rich plasma, was coined by Kingsley 1954 for some basic blood transfusion experiments, and later on in 1970 was the fibrin glue that was put forth, that was used for healing ulcers, yes, and it gained a lot of popularity. And since then, 2 decades, there were a lot of experiments going on with the blood extracts, and a lot of vague terminologies like platelet gel, platelet wound formula, platelet healing formula, all these terminologies were because there was paucity of a proper terminology until 1989, 90s, that is Robert Marks, who put forth PRP, platelet-rich plasma. So the experiments led to the formation of platelet-rich plasma, which was basically a concentrate that could bring about, yes, growth, regeneration, and healing. Now, obviously, when we are talking about evolution, something is lacking. That is why the next generation and the next generation is coming, right? So this was, a lot of biochemical handling was there. It needed anticoagulants, it needed certain other preservatives for its processing. And hence, there was this second generation that came into picture in 2001. I hope at least this you must be familiar. Chukron, Joseph Chukron's classic PRF, platelet-rich fibrin, that made a drastic shift in the evolution, yes, and it enjoyed great success. It still continues to do so. Yes, so Joseph Chukron is one of the researchers who has contributed immensely to not just PRF, that is platelet-rich fibrin, but also to several modifications in platelet-rich fibrin. Okay, so what happens next is the same PRF, LPRF, which is also referred to as a leukocyte-containing PRF. That underwent several transformations. These got certain classifications, certain sports medicine classifications were there which utilized PRP. Then they were prepared in certain different tubes. They were prepared in certain different centrifuges. So they got different names, titanium PRF, they got horizontal centrifuge PRF, they got IPRF, which is an injectable format. So from 14 to recent times, a lot of evolution has happened. Basically, they have changed timings, they have changed the centrifugation protocols, they've changed the tubes, the centrifuges, and so many things. So much madness going around how to make the optimal platelet concentrate, yes? So in that you have so much ongoing. Now, the researchers or the people who are highly acknowledged for their work, so some of the names, Dr. Joseph Chukron, Dr. Cohen, and Dr. Richard Myron, besides others. So when you've seen these names in the evolution, it is simply, let us simplify into certain categories or in generations. Generation 1, platelet-rich plasma, platelet-rich fibrin being the second generation, the third generation being concentrated growth factors, and the fourth are novel platelet concentrates, because constantly there is some or the other additions happening. So this is the most recent one in 2024 that you could follow. Now, classification, I would not go into the details because then it becomes very boring, but 2009 was the first classification that was proposed because several protocols started coming in, several centrifuges, several protocol timings, and there was so much confusion. Cohen proposed the first classification. Again, we'll look into that. But there were several others, and the basis for all the classification happens to be common. What? What are we trying to check? Efficacy. So platelet, what is the count of platelet? What is the count of our WBCs? Yes. What is the centrifuge used? What is the separation method? How effective it is? How effective is the fibrin content? Yes. So all that was the basis for the classification. So all these classifications that you see, yes, for example, DEPA, PLRA, platelet, leukocytes, red blood cells, activation methods. Yes, so these are all acronyms and what all they have used, but the basis remains the same, either platelet content, leukocyte content, fibrin content, and other methods. But the most cited, advocated, and validated classification happens to be of Cohen, who primarily put that into two groups, PRP, PRF. PRP is platelet-rich plasma and platelet-rich fibrin. So one section is basically plasma, yes? So it's basically liquid formulations. So these both two liquid formulations, and this is fibrin formulation. Again, this classification happens to be on the basis of two things. Yes? Does it have leukocyte? Okay, so leukocyte, in the presence of leukocyte, in the absence of leukocytes, or how dense is the fibrin? Is there any fibrin content or no? So basis of these two, presence of leukocytes and presence of fibrin, Cohen classified this, yes? So why leukocytes? Because earlier it was believed in PRP, in those stages of evolution, it was believed that leukocytes were believed to be adding to some inflammatory component, and that is why PRP, the first generation, excluded it from their preparations. They didn't want any leukocytes to be in their preparation. That is why they centrifuged it in a specific manner. But in PRF, they have incorporated leukocytes because they have seen benefits. In vitro examinations have led to the conclusion that it has the ability to induce bone, induce tissue regeneration. Yes? So before we get into the intricacies of those platelet concentrates, let's try and understand what is it exactly, what you do. Yes? So phlebotomy, or what you refer to as venipuncture, is done from the antecubital vein. That is the most preferred site. Yes? So you need to have a proper pressure venipuncture system, the butterfly needles, specifically 21 gauge needles, yes, or anything beyond that. And once that is done, this all is highly, time sensitive. So you cannot just play around with drawing the sample and just waiting for things to happen. So you have to ensure that the centrifuge is already in place, set up. Yes, it is balanced. What do you understand by balancing of the centrifuge? Supposingly if you have one tube, yes, of the blood sample that you've drawn, you need to have another tube, yes, filled with water at least for you to have a symmetrical centrifugation. Otherwise the centrifuge rocks or there is resonance. That again will impact your quality of your platelet concentrate. So you already balance and keep, and then set up your, withdraw the blood, put it in the centrifuge, whatever is your protocol, whatever type of platelet concentrate you want, you can put the spin, put the time, run it, let it stop totally, don't take it out immediately. The resting period is 3 to 5 minutes. Don't handle the clot. That is what most of the postgraduates I've seen doing, yes. They just handle it and see if it has set, if the fibrin is formed. No, let it set, yes, and then you work it out. You can see that clot there, yes, and you can cut that clot. Again, there is a method to cut that clot and where to cut that clot. You can see a portion of RBCs is also included in the clot, yes. Why? Because that is the area that contains maximum platelets and leukocytes, and that is what we want, yes. So don't just totally eliminate that blood clot, a portion of it, that is called as a face of the clot. So at least take a portion of that face of clot in your section, okay. Then you either spread it on gauze or on your specific PRF boxes are available. Yes, those are the standardized tools in the armamentarium. Then you could just actually maneuver it however you want. The clot can be converted into a plug, into a membrane. Even the injectable forms are there that can be injected. So that preparation protocol is different. Or you could cut it into fragments. Yes, those become biological connectors when you put it in between grafts. Yes, so it's actually increasing the viability of bone graft materials. Or you could prepare, or you could directly inject the platelet-rich, injectable platelet-rich fibrin solution into the bone grafts and prepare sticky bone, the concept of sticky bone. And recently, gel form is also been introduced, which we will come towards the end of this session. The armamentarium that is required for preparing the platelet concentrates, basic phlebotomy set, venipuncture set with the appropriate plastic tubes, glass tubes, whatever is required, and appropriate centrifuge. Yes, there is very little knowledge about what centrifuges to buy, what are the different components. Yes, because again that is going to massively impact the quality of the platelet concentrate. Then this is a PRF box with the lid with a weight, you know, and you could just suspend it over your clot so that there is a uniform membrane that is produced. Besides scissors, you have pistons, you have bowls where you could put the clots, and you could just use a piston and make it into plugs and use it. Yes, bone carriers, you could have graft carriers, you could have scissors in that kit. Besides that compression device, you could see a spoon here. Yes, this also put the clot in between, and it is a you could just press it like a spoon and leave, it turns it into a membrane. Besides that, you also have a compression device, a sticky bone preparation device, wherein you don't have to maneuver anything with your bone graft. Yes, it is a tool that would help you to carry the graft with the PRF membrane appropriately into the site. Now, PRF tubes, it is really significant how it affects the quality, because for clinicians what they feel is every red tube is just like that. Yes, because all we know is are those red tubes, blood collection tubes that we are aware of. Yes, but that's not the scene. There are hydrophobic tubes, hydrophilic tubes. If you want to prepare liquid PRF, you are opting for hydrophobic tubes. If you want liquid solid PRF clot, then you are preferring hydrophilic tubes. Again, we have several tubes, glass tubes, plastic tubes, silica coated plastic tubes, titanium tubes, but you should know which one to use, and that we would come to it when we discuss about the optimization. Centrifuge machine. Has anybody seen a centrifuge machine? Okay. So Remy models are the ones that are commonly used in our country. Yes, of several models are there with several rotor radius sizes. Again, that component is very important and least understood. So amongst the systems that are available, Intraspin is the only system that is FDA and CE clearance that it has got. The other systems are there, but again, they are not extremely standardized to prepare or ready to receive or ready to prepare ideal platelet concentrates. Now coming to the centrifuge rotor. Yes, the centrifuge specifications, this rotor is what is the central axis of the rotor. Yes, now around this tube spins. Okay, so you can imagine if your particles in the your blood test tube are towards the end, those will receive maximum radial force, okay, than the ones that are on the top. So even that parameter is important and least reported, least mentioned, and that is why when the communication goes wrong, the product that we prepare according to the protocol set and the machines that we have are different, most of it goes wrong. Yeah, this is not working. नहीं हो रहा है. Okay, नहीं. पीछे, yes. नहीं वैसे नहीं, मैं इसको ठीक कर दूँ ना. Okay, just get a slide before. हो रहा है? So sorry, apologies. नहीं होता है. Just excuse me, I just get my pointer. Hey, use करो. Yes, get back to the slide. Yes, there is a concept called as G-force. Okay. Now, most of you are not aware. Most of the scientific publications, how they outline is when they want to prepare a platelet concentrate, the only parameter that they outline is time and rotations. Okay, 300 rotations, 500 rotations for 2 minutes, for 5 minutes. These are the only two parameters that people are aware of. Yes, but that is not the right thing. What is right is the relative centrifugal force, which is also referred to as the G-force. G-force here is the gravitational force. So when this liquid spins, it is not just the revolutions that it makes, but also the radial force that is acting upon it. Yes, so that also has to be included. So please ensure that when you are preparing a protocol, what is the relative centrifugal force falling upon the product that I am preparing. Yes, so look for RCF values and not revolutions per minute. Yes, because there are several factors that go into consideration. So again, coming back to the generations, generation 1, 2, 3 and the novel platelet concentrates. Obviously something is distinct in all these generations. First generation, PRP, what was different? They were using anticoagulants, bovine thrombin, calcium chloride, and there was an external activation. Whereas in second generation, there was no such thing, they avoided all of this. It was more natural, yes, it was simplified use. The first generation, it was double spins, two-way centrifugation steps. PRF, that is a second generation, it was just one simple stage of centrifugation. And the third generation, it was acceleration and deacceleration. Again, there is reason for that. We come to it when we discuss the third generation. Coming to the platelet-rich plasma. Yes, what do you see here? This is the first generation. Yes, put forth by Robert. And what is happening here? And what is happening here? And what is happening here? The whole blood is collected. It undergoes the first spin. You see the 3 layers there. Yes. You discard the red blood layer. You discard the supernatant, that is the PPP, and whatever is the buffy coat, you again centrifuge it in a medium spin or the second round of centrifugation. And then what you get, you discard the supernatant and use the PRP. Yes. That was PRP, but there was biochemical handling. That is why Joseph Shukron's PRF came into existence. Yes, wherein you see there is just one spin here. Yes, just one spin, and the 3 layers are distinct. And this is what we have obtained, that is the PRF membrane or PRF clot. The cycle is 2700 RPM, and you could see what is the G-force there, 400 G-force at or for 12 minutes. So the cycle runs for 12 minutes. Now, this is also referred to as an optimized blood clot because there is no external agent that is happening. The polymerization that happens in natural cascade is slowly happening. So what happens? There is gradual entrapment of cytokines, growth factors, yes, and that is, if it is natural, it is always beneficial when it is natural. In the first generation, it was not natural, it was activated, yes, with some external agents, the polymerization was activated. So that was rapid polymerization, this is natural polymerization. So obviously the benefits are long term. So as I mentioned, the parts of this clot, the face, the body and the tail, you also have to include the face of the, that's the red thrombus part in the clot when you prepare your membrane or when you use the clot as such. So every generation has its drawback. Even PRF, that is the second generation, had the drawback of structural integrity. It resorbs in 10 to 14 days. Okay? So if you want regeneration or healing benefits for an extended 1 month, 3 weeks, 4 weeks, it is not going to offer. Why? Because it is going to resorb. Yes? So most of it is advantageous, but this being the limitation, this was worked upon in the next modifications. Again, Joseph Shukron suggested or put forth the advanced PRF. What did he use here? He changed the centrifugation process. The concept of low centrifugation was introduced by Joseph Shukron, and what he did here, for example, it was 400 G-force with which the plated concentrate was prepared. In advanced PRF, the force reduced to 200. Now what is the relevance? Why do you want to reduce the force? Because every kind of force, the revolutions is maximum, and the cells that are vibrating, oscillating in that tube, maximum, they might undergo, the vitality is getting reduced, the cell death is more. So obviously if the cell death is more, the quality that you receive at the end is going to get compromised. That is why the concept of low centrifugation, that means the radial force is reduced on that blood component in the tube, right? So that was put forth by Joseph Shukron. Obviously, what was the benefit? See, I want you to observe this. The benefit was, this is a clot, okay? And if you see those patched colored segments, you see the entire segment is colored, which shows that the platelets, WBCs and all other non-platelet components are dispersed uniformly across that clot, and not like in LPRF, that is Joseph Shukron's first LPRF clot, where you could see that it is only concentrated at the layer where the RBC and the buffy coat was there. Yes. So this is what we want. We want uniform distribution throughout the length of the clot and not just centered around one place. Yes? So that is the difference between LPRF and the APRF. Though the clot segment, the length is small, but the distribution of the cells, the cellular distribution is more. And that is because the cells that are getting saved are more. Another most important, injectable platelet-rich fibrin, most commonly utilized now. Again, what changes here? Just the form changes. It is liquid in form. So obviously the spin is going to be less, even the time is going to be less. Yes. So this is 700 RPM for 3 minutes. Now 700 RPM is around 60 G. Okay. So that less a centrifugal force and that less a time. So what is going to happen? The polymerization is not going to be complete. You are going to get the fibrinogen in a liquid state only. This orange color fluid that you see in the topmost portion. Yes, so that you could easily inject, yes, syringe it out and utilize wherever you want. Either you could do an intra-pocket delivery, yes, or you could even use it to facilitate orthodontic movement, accelerated orthodontic movement. That is also tried. Plus, you could mix it with grafts. That is the best way to use it. Yes, so injectable platelet-rich fibrin. These have to be prepared in hydrophobic tubes. Hydrophobic tubes will not let the blood clot form happen, or the polymerization will be slowed down. So those are the tubes that we would want. Yes, those are the white cap tubes or the blue cap tubes that you commonly use. Yes, one tip here is, because you want to use this once you prepare this in 10 to 15 minutes, it will polymerize. Then it will be a gel state. You will not be able to use it in the fashion you wanted to use it. So the tip here is, don't open the lid. Yes, from the centrifuge cap, do not open the cap. From that rubber seal itself, draw the IPRF, the orange colored straw fluid. Yes, so because on exposure to oxygen, atmosphere, it will start polymerizing rapidly. So to avoid that, ensure that you don't pop up the lid. Now, the glass tubes or the silica coated plastic tubes also, even the regular plastic tubes were reported to have incidences of silica toxicity. What do you understand by silica toxicity? Now, because these tubes are coated with silica on the inside, yes, those are activators, or those are that's the routine element of the vacutainer tubes. Now, it was found that though they are dense enough to sediment in the red blood sedimentation layer, but some of it was found in the clot as well. Now this was an experiment that was done. The clots were prepared in the tubes, plastic tubes, glass tubes, and they were subjected to clot formation, and then the enzymatic degradation of those clots happened, and what you could see was the silica particles were seen in the what was the residues that were left behind. So obviously that is substandard treatment that you give to the patient, because it all ends up in the patient's system. Yes, so to avoid silica toxicity, titanium tubes came into place by Tunali. Yes, and it was prepared in grade 4 medical grade 4 tube, titanium tubes. Again, the spin was pretty much like Chokran's protocol, 2700 RPM for 12 minutes, and it is hemocompatible. You can reuse it. Yes, so that's and it activates the blood cascade, clotting cascade, better than silica, as proven by studies. So all the studies, that is light microscopic studies, electron microscopic studies, and fluorescence microscopic studies that have compared TPRF, that is titanium PRF, to LPRF and advanced PRF, have shown that it is certainly superior in terms of its fibrin density, in terms of its fibrin architecture. Even the chemical, structural and mechanical analysis with APRF, LPRF have proved in several studies that TPRF, the fibrin that is formed is much better. Even the release profiles of what? Growth factors that it contains, even that is higher compared to the other two PRF plated concentrates. Again, Tunali modified the titanium PRF into modified titanium PRF by just changing some spins. Yes, centrifugation in clockwise and centrifugation in anti-clockwise direction, and again found that it was superior to titanium PRF. Horizontal platelet-rich fibrin is something that is prepared in horizontal centrifuges. I hope you can understand what a horizontal centrifuge is. Yes, where you could see the tubes are kept almost perpendicular. Yes? The tubes are kept, see, the first figure represents the fixed angle rotor, wherein the tube is kept at an angle. Okay? This is what we are using commonly. In most of the practices we are using a fixed angle rotor, and this is what a horizontal rotor is, or a swing out bucket is, or what do you say, a horizontal centrifuge is, wherein you could see that the cells are freely moving. Yes, they are not banging against any walls. So the cell trauma, the cell death is less compared to a fixed angle rotor. So always horizontal centrifuge is always the choice if you want to prepare PRF, but it is expensive. So that is how we end up with fixed angle rotors. But when we are dealing with fixed angle rotors, at least let us follow the appropriate guidelines. Yes, let us understand, if we have to follow a low centrifugation time, or if you want to reduce the time, spin or the time. Yes. So this was horizontal platelet rich fibrin prepared in a horizontal kind of a centrifuge. Then this is the recent addition, wherein I hope you got the topmost layer, which was platelet poor plasma, yes, which barely had platelet cells. That was taken, heated at 70 degrees centigrade for 10 minutes. Again, you have a bioheat device for this, where you just place your sample, it gets, that supernatant is taken off, heated, it turns into a gel. That gel is called as an albumin gel, because most of it is nothing but plasma proteins, the topmost layer. And now because you have heated it, what has happened? It has lost its cellular viability. But why have you heated it in first place? Because you wanted that membrane to last long. Yes, now the cell viability is reduced, but it is going to stay in place like a scaffold. Yes, it is going to resorb even slowly. But then what do you do for the cell viability? You infuse some growth factors. From where? From the liquid PRF obtained in the same process. Yes, so the person's PPP is also utilized to use albumin gel, and the same segment, the PRF is also added to that, and that mixture is given to the patient in for various regenerative aspects, and that has shown that that scaffold stays in place for as long as 3 months. Yes, so this has also been again, but these require different setups. Yes, these require different centrifugation devices. Again, heat treatment, this was, you're freezing it. So the clots now are prepared and they are stored. What happens when you store it? You are increasing the workability. So if supposingly you want to use liquid IPRF, yes, IPRF, and you want to use it, you want to increase the workability, yes, because it's going to just polymerize in some time. If you want to increase the working time, you could use a cooling device. Just place this tube in the cooling device. It will help you retain that. It will not change the working characteristics, and you can use it, yes, for an extended period of time. The third generation, concentrated growth factors. What is happening here? Acceleration, deacceleration. Now what do you mean by this? Yes, so basically it is happening in one step in this one unit. Yes, you set down the parameters and it accelerates and deaccelerates. Now what do you understand, and how is it going to change any dynamics? What is happening is you spin it, you accelerate it, you get the maximum benefits, and then you stop. You deaccelerate it. That means you don't want that sample to go through the trauma of those radial forces. Yes, so that means you're preventing the trauma to the cells. So obviously the cell vitality is there, better regenerative ability is there. Yes, so that is why this centrifugation of what do you say, the methods that have changed in the centrifugation spin protocols. So this is by far the most effective method if you want to use for GBR, for any membrane that is that you want to be there in place for a long extended period of time. CGF, that is concentrated growth factor, is the thing to look out for. These are referred to as PEVs, that is platelet derived extracellular vesicles. Okay, now these are also platelets. As I told you, they release a lot of bioactive molecules. So if you extract each one of them, yes, that is what would be referred to as PEVs. Yes, so since it has got several useful biomolecules, you could actually imply it for osteogenesis, for bone regeneration, and for several other purposes. So this is again being done, but what it requires is, it requires the centrifugal forces which are high enough. Why? Because they are cleaning up everything. They are taking off the cell, the cellular debris, the apoptic vesicles. So this is a very tedious task, but yes, it is on. Optimization, a lot of clinicians fail to actually optimize the use, yes. So let's understand venipuncture, what goes wrong. Please use glass tubes, dry glass tubes, the best ones. Don't use any modifiers. How do you know if it has been modified? Just take some water in a glass tube, shake it. If you see some residues, that means it has got some additives. So just use plain glass tubes. A study has confirmed that glass tubes, when you prepare platelet concentrates in glass tubes, the clot size is bigger, and even the exudate, the volume is bigger. So that is one. If you want to use chemically modified, you can, in certain conditions where you want to extend the time of the liquid PRF concentrate. Yes, titanium tubes are there to prevent the silica toxicity. If that is a safety concern as reported, that can be used. That is again available, and it is also in the affordable range that can be invested in. Again, time taken, time is sensitive, as I told. The time that you withdraw blood, that has to be quick, and the time you put it for centrifugation, that has to be within 1 minute. Yes, so that all has to be quick enough. As I told you, always follow RCF compared to RPM, and always note down the RC values, that is the G values at the R max, that is at the bottom of the tube, not at the clot level, not at the top level, right? So even researchers, when they want to have a communication, those are the values that they suggest should be reported in your publications, should be reported while you're working also. Centrifugation, I already told you, those are the fixed angle rotors. These are the horizontal horizontal rotors, and the horizontal centrifuge systems are the best ones to prepare ideal PRF, both liquid as well as solid PRFs. So there was this low centrifugation concept. This is, even when you reduce the time, you can see benefits, yes. So for example, this 12-minute was reduced to an 8-minute cycle. And what do you see here? The cells are concentrated in this particular area. The cells are concentrated in this particular area, yes, and the cells are concentrated in throughout the length of the clot, yes. So not just low centrifugation time, but low centrifugation force, low centrifugation time can also bring about the outcome, can affect the outcome of platelet concentrates. Balancing the tubes is already done. Vibration, yes, every instrument will have some sort of vibration. Intraspin is a model that has got the least vibration, but vibration and resonance do affect the quality because cellular damage is more, cell death is more. Centrifugation temperature between 21 and 30 degrees, 31 degrees is the right temperature. At low temperatures, the clots don't form, okay. You could heat treat it, or you could even freeze it, depending upon what is your use, what you want to do, yes. When you heat treat it, obviously the viability is reduced, so you'll have to infuse it with certain things. When you preserve it in lyophilizers or in biocool devices, you can extend the working properties. Now, what do you do after you've taken those clots out, because you're maneuvering those clots? So ensure that you compress everything between 2 minutes. Don't use a gauze as routinely performed. Why? Because it absorbs the exudates, yes. So you're actually losing out on the exudates that you could work with. Rather, what you do, you could use PRF boxes, compression devices for compression. And the face of the clot that I mentioned should always be placed on the bed that is going to receive that, yes, not away from it. The most interesting part is where do you apply? Multiple applications, almost everywhere that you can think of. Periodontal regeneration, yes, intrabony defects, solo, as plugs, as membranes, mixed with bone grafts, furcation defects as a membrane, mixed with bone grafts, recession defects as an alternative soft tissue healing biomaterial. Obviously, it's not going to give you a superior root coverage, but certainly some increase in the soft tissue thickness is reported in meta-analysis. Because of its syringeability, the IPRF, which is the injectable form, syringeability is there. So obviously the application is you could inject it into periodontal pockets, yes, non-surgical therapy. Palatal bandage, when you're retrieving connective tissue grafts, pregingival grafts, you could use the PRF as a biological dressings. Soft tissue aesthetic surgeries, interdental papillary reconstruction, obviously, as I mentioned, as an suitable alternative donor material. Accelerated orthodontics, yes. What is happening here is you're injecting IPRF into the area which needs to be closed, yes. So what is basically happening? You are trying to play around with the bone metabolism, yes, so that those dynamics are altered, yes, because you're creating trauma, you're infusing this, so obviously the bone dynamics are changed, remodeling is set in, and obviously it is going to facilitate accelerated tooth movement. Socket preservation, according to a meta-analysis, already been proved that it is a good biomaterial, either solo or mixed with a bone graft to preserve the socket well. Avul's teeth management, this was something interesting that I found, wherein the PRF was wrapped around the membranes. It is created into membranes. It was wrapped around the chemically treated root surfaces before it was re-implanted back. Yes, regenerative endodontics, as obviously not indicated to be mixed with bone grafts, but certainly as a solo material for large, after you enucleate the large cystic lesions, pulpal floor repair, end apex, root end apexification. Oral lichen planus lesions, some of the cases have been reported where IPRF has been injected into those lesions, yes, in the range of 1 ml or so. The studies have been compared to those of with corticosteroid injections also. Obviously not as great as that, but when it comes to patient comfort, patient-centered parameters, certainly it has shown some improvements. Sinus floor elevation as a subsinus filling material, we know that it can be utilized. However, the primary what is required is the available bone support has to be there. Only then these things work. Sinus floor perforation, perfect materials to use. Again, what has been now tried almost in many areas, what you could see is it has been used as a drug delivery agent. Yes, so the scaffold is there, you mix it, you infuse it with certain drugs that you want to reach, you want those drugs to be at the site for a long period of time, you invest in PRF as a drug delivery system. So again, it would reduce the systemic antibiotic dependence. This is already, a lot of studies have been going on incorporating metronidazole, doxycycline and several other biomolecules in PRF. And it is believed to stimulating the dental pulp cells, yes. So again, there is scope for regeneration, as we are aware. Now, one more question, I mentioned that it is being used as a membrane, but I don't see much value as a membrane because membrane should have certain specific properties, like it should be, it should have that membrane barrier property, occlusivity, specificity, it should maintain space, none of which is provided by the PRF membrane. It is just as a supportive living bio healing material, yes, nothing more than that. So don't expect it to serve as a barrier membrane. None of the meta-analysis that has been conducted has involved PRF as a membrane, but just as a healing biomaterial. Future trends, a lot awaits. Optimization, working upon this scaffold to make it as a good local drug delivery agent, exploring other non-platelet components, not just platelets, but leukocytes, even RBCs, even erythrocytes, even hemoglobin. So many components can be explored. Yes. Besides that, as a topical carrier for bone tissue engineering, we say that it is osteoinductive, but most of the pioneers in their research have said that PRF has the ability to osteoinductive, but this is where we can think where the future is going. Besides that, how these bioactive molecules are working in that fibrin, because there are so many. So what is this biomechanics? How much can it hold? Those are also certain. It's not just we are just keeping on concentrating the factors without knowing if it is leading to failure or is it going the negative way. So that also has been reported. So future trends are those. Some recent researchers have said that PRF has the property to secrete some neurotrophic factors which could be beneficial in nerve repair. Again, that will become a boon if something like that is found. So a lot of tissue engineering aspects. Coming to the conclusion, from tissue sealants to new regenerative tools in medicine, it has come a long way, yes, not still ongoing, yes, not complete, and ideal scaffold in every possible way because it's a live engineered tissue, everything is just working together. Optimization, clinicians reporting it, performing this in an optimized way using the optimized protocols would lead to better direction for others also to follow the same path so that they can give good standard treatments to their patients. So working on the limitations currently to extend the properties, to extend the resorption of this membranes is already ongoing. So the future is very promising, because that is a beauty that these platelet concentrates have. They are natural, they are autologous, and they have so much to offer. Yes, so that brings me to the end. Thank you so much. I know it was a little rushed, but then it had to cover everything. Thank you so much.
Thank you, ma'am. Now I would like to invite Dr. Abhijit Sande, Associate Professor in Department of Oral Medicine and Radiology in D.Y. Patil Dental College, Pune. He has 3 patents and 6 copyrights to his credit and has recently completed his PhD. I request sir to take over.
Am I audible, guys? Good enough? Yeah. So actually I see a lot of familiar faces. The SDS family is here, the D.Y. Patil family is here. So actually it feels like a home for me. So I am Dr. Abhijit Sande, and I am Associate Professor at D.Y. Patil Dental School. And today I am going to talk something, and I am going to actually have a discussion related to a very famous topic of oral medicine and radiology, which is the cone beam computed tomography. Now before easing into this topic, I just came across a wonderful motivational story few days prior. So I just wanted to narrate that to you. So this story is actually about an eagle, and it is also called as the very famous story of flight of rebirth. Have you guys heard of this story? Yes? I'll just narrate it to you. So basically, an eagle actually is the bird who has got a longest lifespan in the entire species. So eagle lifespan is almost about 70 odd years. But by the age of 40, the eagle tends to grow a little bit old. The beak which it is using to eat is actually becomes blunt and bent. The talons which it uses to grasp the prey becomes unsharp. And the feathers which it uses, the feathers tend to become old and they become heavy. So here, by the age of 40, the eagle has to make an important decision. It has got 2 ways here. One, to accept as it is and die, or second one, to go ahead with transformation. Now this transformation what we are talking about is actually very painful. It lasts for about 150 days. Now in this 150 days, what the eagle is going to do, it will fly at the top of the mountain, and it will find a big rock, and it will start hitting its beak against the rock till the beak breaks off. It will wait for the beak to regrow. As it regrows, it will start to plucking out its talons. It will wait for the talons to regrow, and then one by one it will remove all the feathers until the new feathers grow. So the main question that comes here is, why did eagle have to do this? What do you think? Obviously for survival, right? So this survival was very important, because after that the eagle lives for 30 more years. That is how it lives for 70 years. So the important question that is here is, why is change needed? This change was needed for survival, and the similar type of change was required in radiology, because initially what we were using in radiology were all 2D images or 2-dimensional images, which we were using as an OPG, which we were using as an intraoral periapical radiographs. But why do you think there was a need of 3 dimensions or 3D? So if you can see at the diagram that is present here up, you have an X-ray source on one side, you have 3 different objects that are present in the center, a yellow, a black and a green. But what you can see, when the X-rays are going to pass through them, the resultant image will have a lot of overlap. On the surrounding structure or on the surrounding radiograph, what you can see here is an impacted tooth that is present. But can anybody tell me that impacted tooth is buccally placed or lingually placed? Can anybody tell me that the inferior alveolar canal is lingually placed or buccally placed? No. So these are the reasons why we require 3 dimensions in imaging. So 3 dimensions is going to provide a real and a more real-time representation of depth, height and width. It can also show images in multiple angles. It is going to be giving a realistic and dynamic representation and as well as 3D reconstruction. What this is, we are going to see it in the further slides. So giving you the more important perspective of this, can we just try to describe what is present on the slide? Can we just describe what is there on the slide? So what you can see there, you can see a house. The house has got a roof which is conical in shape. You have a small chimney that is popping up from the roof. Yes? So this is the information that we have got from this image. But what if I tell you that I can give you another angle to this? With side view, what you can note here is the house which is conical in shape, but there is no chimney that is popping up through the roof. It is actually a pole which is distant from the house, and the house and the pole appear to be connected by a blue line which is the water body, right? Now if I give you a third perspective or third dimension to this, what you can see here, the roof of the house that we were talking about conical is actually broken from the backside, right? The water body which appeared to be straight is actually in zigzag manner, and the pole is distant apart from the water body, so it is not connected to the house or it is not connected to the water body. So this is the information that we were able to collect from 3 different views. This is the importance of getting multiple views for diagnosis and treatment planning. So what exactly is cone beam computed tomography? It is actually a radiographic imaging method that allows accurate 3 dimensions or 3D imaging of the hard tissue structures. What you can see here is the machine which can actually be adjusted depending upon the height of the patient or any disability if the patient has. It has got a handle for a stable position. There is a small device which is attached to it which is called as a touch panel, which is utilized for getting KVP and MAs. Sorry for the inconvenience. So you have the video which resumes. So the height can be adjusted depending upon the patient's height. There is a handle for the stable position of the patient. There is a touch panel which you can control the KVP and MA which are required, and then the patient is going to be exactly in the center. So this machine appears to be just like a regular OPG machine where the patient is present in the center. There is a chin rest on which the patient will rest the chin, and the head will be supported by the head prongs, and the image is going to be constructed. You can see that as the image is going to be progressed, you can get a 3D reconstructed image at well surrounding it. So understanding this CBCT scan is actually important for us. So prior to that, we need to understand what are the different cardinal planes. Now these cardinal planes we have already studied in the first year anatomy, right? The cardinal planes. So I am going to talk about the 3 cardinal planes here. One is the coronal plane which divides the body. If I am going to divide the body like this, I am going to divide it into the front and the back part. Then you have a sagittal plane which divides the body into right and the left part, and you have a transverse or axial plane which divides the body into top and the bottom part. Easy to understand? Yes? So this was about the cardinal planes of the body. Similarly, applying these cardinal planes to the maxillofacial region on a dry skull, these are the images that you are going to get. So if you see that wherever this slice is going to pass, those structures, anatomical structures are going to be noted here. Am I clear? going to the radiological aspects of it, these are the multiple radiographs. So as and how the slicing is going to take place, these are the various anatomical structures that you are going to come across. Now these anatomical structures appear very different on a diagram, but when we see on a radiograph, they appear to be very different. So having a proper anatomy knowledge is very important here. A 3D reconstructed image also takes place in CBCT, where you can adjust the bone volume, you can reduce the entire bone so that you can check which are the teeth which are impacted. The teeth, what is the position of those teeth, whether they are buccally placed or palatally placed, and you can also see what are the various vital structures associated with them. Understanding the slicing or actually looking at the workstation is actually identifying the correct logo from the Google. Can anybody give me a guess which is the correct logo? Which appears to be the correct logo of Google? Anyways, F is the right answer for it. So how does a CBCT software look? Now this is where an oral medicine or oral physician comes into play. Whenever the patient goes ahead with the scan is going to be seen in this fashion. I'll just show you a live case. Are you able to appreciate this? So this is one of the case. This is the three-dimensional view, and you can see three different planes which we have already spoken, right? So what you can see here is the clean line, and you can see a violet line, and you can see a yellow line. All these three lines are going to represent the three boxes that are present around it. Are you able to appreciate this? Yes? So when we move the mid-sagittal plane, you can see that only this structure moves because I am moving this color line. I am going to appreciate it in this box here. When I move this violet color line, I am going to appreciate it into the violet box, and as I am going to move this yellow color line, I am going to appreciate it in this axial sections. So are you able to appreciate the three different sections that we have spoken about? Yes? So that is how a CBCT software looks like. So uses of CBCT in dentistry, CBCT is going to be used in all the branches of dentistry. Let it be oral medicine, radiology, let it be perio, OP, everywhere it is going to be used. I'll just show you few cases which were reported to us. So this was one of the case where the patient was having a small swelling that was present in the lower anterior region. Are you able to appreciate this on the three-dimensional area? Yes? So what you can see here on the right side is a mandibular canal which has been marked. And as I move these sections, I will be able to appreciate the exact size of the cyst. So a hollow space that is present just below the teeth. Can you see the dimensions of the cyst clearly now? Yes? So on an OPG, we are not able to clearly identify what are the various margins that are present of the cyst. So with this tool, we can easily appreciate what are the various extensions of the cyst. So depending upon that, the treatment plan is also going to be altered. Whether you have to go ahead with only marsupialization or enucleation, where are the exact vital structures that are present, all those things can be easily noted on this. Coming to sinus pathology, what you can see here is an axial section of one of the patient who had reported with a pain in the maxillary posterior region. Now this pain was related to the sinusitis area. There was a mucocele that was present in the sinus. What you can appreciate here is the mucocele which is attached to the anterior wall of the sinus. Now this anterior wall of the sinus is not normally seen on a radiograph. This will be seen mostly on CBCT cases. One of the important thing that you need to note here is various three turbuncles that are present of the nasal fossa, right? So these are the various conchae, the superior conchae, the middle conchae and the inferior conchae. Now where does the maxillary sinus open into? Into the second conchae, right? The maxillary sinus opens into the second conchae, which is through the hiatus semilunaris, right? So from here what you can see there is the sinus and a small opening into that second conchae. Now this is very important because understanding this, whether there is any obstruction there, because of that obstruction the patient might be having sinus or the sinus issues. So understanding this and reaching to a diagnosis becomes very easy if you have such type of imaging tool. Coming to one of the endodontic cases where the patient had reported with the pain in the upper left back tooth region, what you can see here with the 6 is there are 3 roots that are present. With the 3 roots of 6, if you are able to appreciate the mesial root, you can see 2 different canals, the mesiobuccal and the mesiopalatal canal. But one of the important finding which was present here in the 7 was the mesial root and the palatal root were fused together. Are you able to appreciate that with the 7? With the distal root of, or the mesial root of 7 has got entirely fused, there was a developmental anomaly present. So there are chances that the endodontist will have a missed canals here. So if you have a tool like CBCT, it is very easy for diagnosis and the treatment part of the patient. For impacted third molar, the use of CBCT has been rampantly used. What you can see here, you have we had a case of an impacted third molar, and the distal root of third molar is in highly or close proximity with the inferior alveolar canal. So what you can see here is the distal root is actually in contact. The distal as well as the mesial root appears to be in close contact with the inferior alveolar canal. Now why this is important is because for extraction you need to be ready that there might be chances, if you go ahead with extraction, there might be injury to the inferior alveolar canal. Various trauma cases that were reported to us, what you can see here is whether the fracture line is favorable or unfavorable, what is the extent of the fracture line, whether both the buccal as well as the lingual cortical plates are involved, all those things can be easily understood with these radiographs. One of the case which was reported to us where the patient had undergone trauma with the lower anterior region, but the radiograph or the CBCT was taken for the entire volume. What we came across that the patient was complaining of pain in upper region where there was no fracture line that was present. But on CBCT few sections, what we were able to see is there was a small fracture defect or fracture line that was present in the anterior region. So that's why the patient was complaining of pain, and with routine radiographs this line was not evident. One more case which was reported to us where the patient had undergone extraction of 8 almost 2 to 3 months back, but the pain did not subside. The dentist was thinking that it might be a case of a dry socket or something else. But when the CBCT scan was taken, what came across is the fracture of the distal root of 7. So that was an iatrogenic trauma that was caused during the extraction of 8, but that's what was the cause of the complaint. Coming to airway analysis, which is mostly used in orthodontics, where you can directly get the markings and you can get the analysis of airway. That means what you can see here is the nasopharyngeal and the oropharyngeal airway, the nasopharyngeal airway and the exact volume which can be calculated through by using of CBCT. This is mostly used in the cases of obstructive sleep apnea. So obstructive sleep apnea where there is any obstruction that is taking place in the airways. Now the tool that is being utilized very rampantly is also used in the cases of implant planning. So how does an implant planning is done? What you can see there in an orange line, that is actually the inferior alveolar canal. And what you can see here that the plane that we are talking about, the blue line, that is the mid-sagittal plane. So this is the magnified version of it where an implant is placed and you can have multiple systems. So whichever system you want to use, you can select an implant from there, select the height of the implant from the inferior alveolar canal, and you can adjust the implant as well. So you can adjust the implant anteriorly, posteriorly, or you can actually change the site of an implant as well. You can change the implant position in 3 dimensions. What you can see here is the red color when it shows, that it means the implant is in close proximity with the inferior alveolar canal. You can change the position, you can tilt the implant, and you can see it in 3 dimensions, that after prosthesis, what will be the exact angulation of that implant, whether the prosthesis can coincide with the maxillary teeth. So all those things can be easily seen and achieved through CBCT implant planning. So to conclude, yes, definitely CBCT is a wonderful tool which can be used in the entire dentistry, but all the cases are not CBCT cases. A patient coming to you with a simple tooth pain can be a case of a simple caries, and you can go ahead with removal of caries or extraction and you can finish off the case. But definitely when you think that there is some complication involved in it, then CBCT is the choice. So I would like to end my presentation with the same eagle story, that all birds find shelter during a rain, but it is only the eagle who avoids the rain by flying above the clouds. The problems are common, but the attitude towards the problem are going to making the difference. Thank you so much for patient listening. I would like to thank Dean sir and the entire School of Dental Sciences as well as the Cynodent for giving me this opportunity to present a paper in front of you. Thank you so much.
Request Dean sir to felicitate Lisa ma'am with a momentum. Thank you, sir. Next, I would like to introduce Dr. Shriram Kulkarni, Associate Professor in Department of Public Health Dentistry. He has 1 patent and 7 copyrights to his credit. I request Dean sir to felicitate Dr. Shriram sir with a momentum. Thank you, sir. Now I request Dr. Sagar to accept momentum. Thank you, sir. Now I
Okay. Interns, how many interns are here? Okay, be careful, I'll be questioning you a lot. Fine. Okay. So what topic am I going to talk about? पढ़ा होगा ना ब्रोशर में कहीं तो? Yes? You said something? Evidence-based dentistry. How many of you have heard this before? Evidence-based dentistry. कभी सुना है इससे पहले? Or is it the first time? Yes, interns. Quick. The sooner you answer, the sooner you will be free. बताओ. Evidence-based practice or evidence-based medicine. Are any of these terms familiar to you? No? Okay. I'll give you a, say, situation. Okay. Suppose you have a practice, okay, and you have been doing your crown cuttings in a particular technique for all along, like 5-10 years, whatever your practice is, but then you notice that your crowns are failing, okay, and now you need to see what is going wrong. So in this case, what would be your approach to rectify this particular problem in your clinic? Yes? Anyone? What would you do?
Okay, she did not hear the question at all. Yes, you? Yes? Anyone? Quick. You, ma'am. Suppose you have been doing a crumb cutting in a particular way in your clinic for many years, and then you observe that your cases are failing. Now, this is a particular clinical problem in your clinic. So, how would you address that? Okay, and so, but how will you address that? Now you have noticed the problem, how will you address it? How will you rectify yourself? Whom would you approach? What would be your source of knowledge to bring that correction in your practice? Senior dentist. Okay, that's the most common approach we have, that we directly go to our maybe a senior dentist or your teachers, okay, or anybody who is having a practice since like good established practice, you'll approach him and ask. Okay, whereas that's not the case. That's not how it should be. Okay, we should go for the evidence that is there out there. Now, what do I mean by evidence? Scientific evidence. Yes? Your, yeah? It's been proven. Yeah, very good. Okay? Anything that has been proven is nothing but an evidence. In our case, it's the scientific literature that is out there. Okay? So, under this scientific literature, what all things do we know? Your articles. Okay, your peer-reviewed articles, then journals, then thesis, dissertations, systematic reviews, yes, Cochrane reviews, there's the most polished reviews, okay. So, even among these evidences, we have a hierarchy. At the top, we have our Cochrane reviews, and at the bottom of this hierarchy is nothing but the opinions that you take from the experts, okay. So, we are doing it wrong. And that is what I want to talk about, and that is evidence-based dentistry. So, our dentistry has been mostly based on people's anecdotes, experiences, okay, their opinions. It should not be the case. Okay, so this is the definition of evidence-based dentistry. I won't go into it. A brief history of it. Okay, so to implement evidence-based dentistry in our practice, these are the actions that have been taken in our Indian scenario. Okay, in which you can see in 2007, the Dental Council of India, it emphasizes on research methodology in BDS curriculum. Okay, interns, again, if you remember your topic on research methodology and biostatistics, usme se kitna yaad hai? What is even the application of it? Does anybody know? Nil, right? All you remember is mean, median, mode. Yes, normal curve, bell-shaped curve, bar graph, charts. That's it. उसका application कहाँ है? कोई आता पता नहीं है. Okay. So, what is the current state of this awareness amongst the practitioners in India? Okay. So, these are some of the studies that I could find, wherein you can see in Kerala, 75% of the practitioners are aware of EBD, and in Bengaluru, there are 88% of practitioners who are aware of this thing. But you see here, the application is very less. Thus, there is a massive gap between your awareness and the implementation. And there are several reasons for it. We won't go into this. Not required. Yes, the barriers for its implementation. What it could be? What are the potential barriers here? Yes, the first one is time constraint. Nobody has enough time that you will come across a particular clinical scenario, then find out that article or any relevant article on the internet, see where in the hierarchy of evidence does this fit, then which one is applicable for your scenario and how can you implement it. Nobody has enough time for it. Next is our lack of skills. Just now I told you that you learn research methodology only for those 10 marks questions. That's the only application you have right now. Yes? Then patient factors. Whether whatever I do, okay, fine, I'm comparing two different materials. One material is better than the other one, I found out. But it is very expensive. I cannot use it in my practice. So then again, your patient factors come in. Next is infrastructure limitations. Okay, or typical answer in all the PhD thing. Okay, urban में अच्छा रहता है, rural में कम रहता है. Urban में dentist ज़्यादा है, rural में dentist कम है. Similar here, the application is better in urban regions than your rural regions. And last is language barrier. None of us here have English as the first language, and most of the literature out there is in English. But this one particular thing, I literally want to rant about it. Why? Why have we like neglected this particular thing in our practice? Your research methodology and biostatistics. Again, it is not only you UGs, even the PGs, the PG guides, the PhD people. I've come across so many things. Like I do statistical analysis for many PGs and PhD candidates. The first thing they will come to me is sample size chahiye. Okay, sample size, okay, fine. I will derive that scientifically. Then they'll be like, no, this is not feasible. This is too huge for me. This is too expensive. Then I have to reduce the sample size. But there is no significance for it. Next thing, they'll do the study. Then they'll send me the data. I have to analyze it. I give them the results. But then again, they'll call me up and say, nahi, guide ne bola hai significant chahiye. Kya significant chahiye? Like, why do we require that? Nobody knows how to interpret a p-value. Yes, interns, anybody knows? PGs, anybody here? P-value. Nobody knows it. Next is, then I have to manipulate their data, because that is what is going to satisfy their guide. Okay, I do the manipulations, I give them the results, and then they call me up and again and said, sir, abhi thoda likh ke de do, ye padh ke nahi samajh mein aa raha hai. Like, again, all these PGs, they do not know how to interpret a table or a graph. Why? Yes? So that is the need of time right now. Our negligence towards this is costing us a lot. Our theme of the conference is what? Future, the evolution of dentistry. And this is the one thing that is going to play a key role in it, and we are neglecting it. So these are some of the efforts we can put into it to make these scenarios better, to fill up the gap between the awareness and the implementation. The first thing is educational reforms. Don't keep your, like, let's not make research methodology and biostatistics just a 10-mark thing. Okay, the research methodology and biostatistics in itself is a complete course. We do not understand that. Okay. Next is continuing educations, like conduct more amount of these kind of conferences, CD programs. Not just that, even your KSDC or MSDC, your state registration councils, every year you have to give the, say, renewal of it. For that, make it mandatory to have certain CD points, so that that particular practitioner goes out there, learns something new, implements that into his practice, and only then he is giving the renewal. And last one is the professional association efforts, like things like IDA, this Indian Society of Dentistry. These kind of efforts can help in EBD. Promotion for research, development of guidelines in this field, and use of technology. Nowadays we have got AI, we have got social media, everything is in our palms. Let's make a better use of it. Okay. To conclude with, I will say, don't be lazy. Don't directly go to your seniors or your teachers. Read an article. First of all, know how to read an article. Then see if it is applicable for your case scenario or a case problem. Apply that and help evolve dentistry. These are the references that I had used for this presentation. Thank you all for your patient listening.
Thank you, sir, for your wonderful lecture. Valedictory function will be starting soon, so I request everyone to be seated.
Welcome to each one of you as we gather here today for the valedictory function of 14th World Dental Sciences and Oral Health Conference organized by Cynodent and Indian Society of Dentistry in collaboration with School of Dental Sciences, Krishna Vishwavidyapit, Karad, Maharashtra. It's been an amazing journey of learning, enriching scientific sessions and vibrant cultural events over the last 2 days, and we are honored to have you all with us this evening.
I request respected Dean Sir, Dr. Sashikaran ND Sir, Dr. M. Uthaya Kumar Sir, Dr. Ashish Sir, Dr. Anmol Ma'am, and Dr. Siddharth Verma Sir to come up on the dais and give over the award functions. Moment to announce a category award for Budding Public Health Dentist of the Year, and the award goes to Dr. Asmita Ma'am from School of Dental Sciences, Krishna Vishwavidyapit, KV Karad.
The delegates who are in the hall, kindly note, once you are done with your prize distribution, we have high tea served in the college. So please don't leave from here only. After we finish the function here, we shall gather at the second floor in the dental college where you had your breakfast and lunch. So there is high tea being served there. Have your high tea and then please carry on.
Dedication and hard work of all our participants. First, we'll proceed with the scientific sessions, starting with the paper presentation from slot 1 category, which was held in lecture hall number 3. First prize goes to Vaishnavi Rajesh Zambulikar and Lakshmi. First prize is shared with Anushka Rudravar and Sanjana Mahadik and Tapasya Deshmukh. Second prize goes to Ruta Mahamuni and Prerna Zadav. Third prize goes to Ekta Lahoti and Rutuja Bosle, and it is shared by Akshata Pise.
For slot 2, first prize goes to Siddhi Desai and Stefan Rebello. Prize goes to Cindy Fernandez. To Anish Khambate, Ujwala Bansode, and Shubhra Desai.
For slot 3, that is spot presentation, first prize goes to Dr. Mihika, Arya Golwani, Aman Khan, Veena Menon, and Dr. Rahul. First prize goes to Dr. Mihika, Arya Golwani, Aman Khan, Veena Menon, and Dr. Rahul. Second prize is backed by Dr. Utkarsha, Aishwarya Derekar and Sahil Zadav, Dr. Harshvardhan Mohite, Dr. Siddhi, Dr. Divya, Dr. Kirti, Dr. Samruddhi, Nivedi Ajmera and Vaishnavi, Karuna Gaikwad and Zoe Deshpande. Dr. Utkarsha, Aishwarya Derekar and Sahil Zadav. Dr. Harshvardhan Mohite. Dr. Siddhi. Dr. Divya, Dr. Kirti, Dr. Samruddhi, Nivedi Ajmera and Vaishnavi, Karuna Gaikwad and Zoe Deshpande. Third prize for spot paper presentation goes to Dr. Priyanka Patil and Dr. Jagruti Somani, Dr. Anupama More, Dr. Sejal and Kalyani. I repeat, third prize for spot presentation goes to Dr. Priyanka Patil and Dr. Jagruti Somani, Dr. Anupama More, Dr. Sejal and Kalyani.
Moving on with the next category, that is PG paper presentation, slot 3, which was held in lecture hall 2. First prize goes to Dr. Ayush Bhatt. prize goes to Dr. Sharon Fernandez and Dr. Aishwarya Patil. Goes to Dr. Anisha and Dr. Ekta and Dr. Kedar Kulkarni.
For slot 5 spot entry in UG category, first prize goes to Samruddhi and Sahil. Second prize is backed by Janvi Patil, Vaidehi and Ketki. And the third prize goes to Sohardya and Swarali, Priyanka and Veena. Second prize backed by Janvi Patil, Vaidehi and Ketki. Third prize backed by Sohardya and Swarali, Priyanka and Veena. For slot 5 spot entry in PG category, first prize goes to Dr. Bhavna and Dr. Saili. Dr. Bhavna and Dr. Saili. Second prize goes to Dr. Prasad and Dr. Rajni. Third prize goes to Dr. Soumya, Dr. Sanya, Dr. Abhishek and Dr. Rohan. In the faculty categories, first prize backed by Dr. Prashant Punde sir. And second prize backed by Dr. Madhura Mahajan ma'am.
Moving on with the next category, that is poster presentation, which was held in meeting hall. Slot 1, first prize goes to Jia Joy, Veena Menon, Shruti Deshmukh, Sanjana Patil, Neil, Simran, Ulfat and Mokshada. First prize goes to Veena Menon, Shruti Deshmukh, Jia Joy, Sanjana Patil, Neil, Simran, Ulfat and Mokshada. Second prize goes to Tanvi, Shreya Kamate and Shreya Vyas. goes to Tanvi, Shreya Kamath, and Shreya Vas. Third prize goes to Sanjana Mahadik and Anushka. Muskan. Prize goes to Sanjana Mahadik and Anushka, Ashika and Muskan.
Moving on with slot 3. First prize goes to Dr. Rucha Pawar. Moving on with slot 2. First prize goes to Vinaya Fernandez, Divya, Rutuja Ramesh, and Ekta Lahoti. I repeat, in slot 2 category, first prize goes to Vinaya Fernandez, Divya, Ekta Lahoti, and Rutuja Ramesh. Second prize goes to Karuna and Ayman Momin, Anushri Santosh, Prachi Damani, and Akansha. I repeat, for slot 2, second prize goes to Karuna and Ayman Momin, Anushri Santosh, Prachi Damani, and Akansha. Third prize goes to Janani Bhatt and Iravati Suryavanshi, Samruddhi Patil and Alia, Anushka Ashtekar. I repeat, third prize goes to Janani Bhatt and Iravati Suryavanshi, Samruddhi Patil and Arya, Anushka Ashtekar.
Slot 4 spot entries. First prize goes to Meema and Spurti, Avishka, Neha, Mrunal Pawar, and Rutuja Sarunkhe. I repeat, spot entries for slot 4. First prize goes to Meema and Spurti, Avishka, Neha, Mrunal Pawar, and Rutuja Sarunkhe. Second prize goes to Shreya Jain, Shefali Sharma, and Purva Tambekar. I repeat, second prize goes to Shreya Jain, Shefali Sharma, and Purva Tambekar. Third prize goes to Divya, Savni, Ruchira Sawant, Sandesh, Tanvi, Harshada, Aniket, Pratyesh, and Dharya. Third prize goes to Divya, Savni, Ruchira Sawant, Sandesh, Tanvi, Harshada, Dharya, Aniket.
These awards are for poster presentation. Repeating the third prize, that is Divya, Savani Purohit, Ruchira Savant, Sandisha, Tanvi Afle, Harshada and Sharanya, Pratyash and Dharya Pawar, Aniket Nandulkar. Moving on with category of Table Clinics Awards. First prize goes to Ketki Muhire and group from SDS KVV Karad. Second prize goes to Anant and team from SDS KVV Karad. I repeat, for table clinics category, first prize goes to Ketki Muhire and group from School of Dental Sciences KVV Karad. Second prize backed by Anand and team from School of Dental Sciences KVV Karad. Congratulations to all the winners of the scientific session.
Moving on with the next awards for the cultural event. For the face painting, we have first prize goes to Rashi Rathi from School of Dental Sciences KVV Karad. Second prize goes to Sanjana Patil from School of Dental Sciences KVV Karad. Third prize goes to Aditi from KLE Belgavi, Karnataka.
I repeat, for face painting, first prize goes to Rashi Rathi from School of Dental Sciences KVV Karad. Second prize goes to Sanjana Patil from School of Dental Sciences KVV Karad. And third prize goes to Aditi from KLE Belgavi, Karnataka. Moving on with the next category, that is Rangoli competition. First prize goes to Aditi and team from KLE Belgavi, Karnataka. Second prize goes to Neha Thorat and Shravani from SDS KVV Karad. Third prize goes to Harshada and Sanjana Patil from SDS KVV Karad. I repeat, for Rangoli competition, first prize goes to Aditi and team from KLE Belgavi Karad, Karnataka. Sorry. Second prize goes to Neha Thorat and Shravani from School of Dental Sciences KVV Karad. Third prize goes to Harshada and Sanjana Patil from School of Dental Sciences KVV Karad.
Moving on next, for solo singing, first prize goes to code S2, that is Anarya Ladi from School of Dental Sciences KVV Karad. Goes to code S1, Sanika Pawar from KLE Belgavi, Karnataka. Third prize goes to code S3 Shanaria, also from KLE Belgavi, Karnataka. First prize goes to code S2, that is Anaria Lade from SDS KVV Karad. Second prize goes to code S1 Sanika Pawar from KLE Belgavi, Karnataka. Third prize goes to code S3, that is Shanaria, also from KLE Belgavi Karad.
For duet singing, first prize goes to code D1 Sanika Pawar and Sharanya Raghavan from KLE Belgavi, Karnataka. I repeat, for duet singing, first prize goes to code D1 Sanika Pawar and Sharanya Raghavan from KLE Belgavi, Karnataka.
Moving on next for solo dance category, first prize goes to code SD2 Jia Joy from SDS KVV Karad. Second prize goes to code SD1 Riya Doshi from SDS KVV Karad. I repeat, solo dance category, first prize goes to code SD2 Jia Joy from SDS KVV Karad. Second prize goes to code SD1 Riya Doshi from SDS KVV Karad.
For duet dance category, first prize goes to Shreya Ghor and Srushti Patil from DYP Pune. I repeat, for duet dance, first prize goes to Shreya Ghor and Srushti Patil from DYP Pune.
For group dance, first prize goes to code G3 Vinyan Group from KLE Belgavi Karad. Second prize goes to code G2 Vaishnavi and Group from DYP Pune. And there is a tie between for prize 3 between code G1 and G4, that is Ekta and Group from SDS and Pranali and Group also from SDS KVV Karad. For group dance, first prize goes to code G3 Vinay and Group from KLE. Second prize goes to code G2 Vaishnavi and Group from DYP Pune, and tie between G1 and G4 for third prize, that is Ekta and Group from SDS and Pranali and Group from SDS.
Second prize goes to G2 Vaishnavi and Group from DYP Pune. And there's a tie for third prize between code G1 and G4, that is Ekta and Group from SDS and Pranali and Group from School of Dental Sciences, Karad.
fashion show, first prize goes to code F2, KLE Belgavi, Karnataka. Second prize goes to code F1, DYP. And third prize goes to F3, SDS Karad.
I think whoever have witnessed the cultural night yesterday, this was the most easiest choice to pick a winner in fashion show. So that's a truly remarkable performance from KLE as well as the other teams.
Prize goes to code F1, DYP Pune. Goes to code F3, SDS Karad.
Moving ahead, on behalf of KVV and School of Dental Sciences, we would like to extend a token of appreciation for the organizing team headed by Dr. Anmol. I request Dean sir and Uthai Kumar sir to kindly deliver the token of appreciation. Dr. Anmol, founder and CEO of Cynodent. And a small token of appreciation to Dr. Ashish Chandra, co-director of Cynodent. So coming to the last set of appreciation, we like to extend our sincere thanks to the team of photography and videography. We request the team of photography and videography to kindly come on the stage to receive a small token of appreciation. Hemant sir and his team.
I also call upon the technical team to come over the stage.
The technical team, please kindly come on the stage. So without you guys' support, we could not have made this event a good success. Thank you, sir. The technical team, please come forward. I think for the next conference, we have a new role for Dr. Pankaj Patil.
Now, I request Dr. Anmol ma'am and Dr. Ashish sir Now, I request Dr. Anmol ma'am and Dr. Ashish sir to present a token of appreciation to School of Dental Sciences, KVV Karad, on the occasion of 14th World Dental Sciences and Oral Health Conference for their valuable support.
Now, I call upon Dr. Anmol ma'am and Dr. Siddharth Verma sir to present vote of thanks.
Few who have been part of this event. All the delegates are requested to have the high tea and leave. The high tea is being served at the second floor of School of Dental Sciences. So we thank all the delegates and the faculty members for their tireless efforts in making this event a grand successful event. Especially the most taxing department being the scientific committee, headed by Dr. Uzma and her team. We are really thankful for you for putting your best efforts. Then we also troubled the registration committee to an extent. So we thank Rashmi and Apurva for handling the registration committee. And the hospitality and food committee, very well taken care by Dr. Pankaj and his team. Now all this would not have been possible without the ample support from our dear students, especially those interns who have already finished their internship. They did make a point, they stayed back and extended their support, and the new batch of interns who are very much part of this team. So I thank one and all for extending your support. And also I thank the cultural committee, Dr. Amit and Dr. Sonali, for having a wonderful evening yesterday night. So once again, we thank you all for your kind participation in this event, and kindly proceed to the high tea which is being served at the second floor in School of Dental Sciences. And a big thank you to the Cynodent and the team Cynodent who made this possible to host this event in School of Dental Sciences, Karad. Thank you all for your kind support.
A big thank you to our speakers, participants, and the entire organizing team for making this event a grand success. Your efforts and enthusiasm made all the difference. We hope to see you soon at our future events. Thank you.